to our institution who have come from various parts of country and from different walks of life to share their knowledge and vast experience with us. Thank you for taking out time from your busy schedules to extend your support. Your extreme presence has glorified the event. We are eager to benefit from the wealth of knowledge and experience that you bring. We are excited to have you here at today's conference. This will be an opportunity to learn from each other and grow together. We are all so much disappointed about the shaking incident that happened in Archibald Medical College, Kolkata. As we move forward, we also convey our condolences to the family of the deceased. ENT Resident Conclave is organized every year to enhance the academics. It was first organized last year in previous GMC Kanpur with the aim to prepare the students for upcoming PG exams. This year, we are provided with a unique opportunity to host this at our college. We hope this conference will deepen the understanding of ENT and will ignite a passion for learning amongst postgraduate students that will resonate in the years to come. We are now ready to kickstart our event. Onward we go with a ride filled with knowledge, inspiration, and excitement. So let's start with the first session of our conference, orientation lectures by senior faculty members. I am highly privileged to invite on stage respected chairpersons for this session, Dr. S.P.S. Yadav sir, Dr. Vinder Ranga sir, Dr. Nitin Gupta sir, and Dr. Gini Datta ma'am on stage, please. Now I would like to invite the eminent guest speakers for this session, Dr. Ishwar Singh sir, Dr. Uma Gagan ma'am, Dr. Gurban Singh sir, to come on the stage. Sir, ma'am, please. So we are starting with the first session, autopsy session. I welcome Ishwar sir on the stage. Sir will be discussing about the management of autosclerosis. Dr. Ishwar Singh sir is MGIMS 81 alumnus who has made significant contributions to the medical field. He has advanced through the roles from assistant professor to director professor and head of department at Maulana Azad Medical College, New Delhi. His leadership extended to being the medical director of Indira Hospital, Dwarka, and director principal at Baba Saheb Ambedkar Medical College, Rohini, Delhi. He is currently working as professor in Maulana Azad Medical College, Delhi.
Good morning, everyone. With your permission, sir, Dr. Yadav, I start the thing. I will be talking about the salient features of autosclerosis. It's a very important topic from exam point of view. You can get a question either in theory as write the differential diagnosis of various conditions and describe one of it with the intact and preparing membrane. It means you have to write conductive hearing loss, what all will be the differential diagnosis that can come as theory. And in practicals, you will be certainly asked few questions because this is one surgery, stipulated, not me, which is performed by every one of us. So I will be talking about, and if you have any questions, and I will be telling what all questions at what stage are generally asked during exam. With this, and thank you, Rishi, for the introduction. I have been taught and groomed by Dr. Yadav, under whom I did senior residency. I did my UGPG from Varda under my late professor Dr. V.N. Chakravarti, whom I my co-PG. So the definition is autosclerosis is a hereditary disease. So it is seen in the family, and in which the enchondral bone is replaced by irregularly laid new bone. In the active stage, it is called active sponiosis, and subsequently, when it becomes inactive, that is autosclerosis, and it leads to conductive hearing loss. So, disease is not new, nothing new. It's very old, described in 1704 by Valsalva, and he made this osseous ankylosis septis fenestra ovalis. It leads to deafness. It means there is an ankylosis fixation, and that leads to loss, hearing loss. So this sometimes this can be asked, who is he? So this can be a YOC question during your quiz. Identify various persons. So these are the fellows who coined the terms, and this Adam, he coined the term autosclerosis. There are three misnomers in otology. One is this, so the more familiar term it should be autospongiosis. Other is acoustic neuroma. That is, the right term is vestibular schwannoma. And third, who can tell the third misnomer in otology? Yes, cholesteatoma. What is the new term for it? Anyway. So the etiology is well known, nothing new. The first is unknown, since it's genetic, autosomal dominant. Race, more common in Caucasian, and in India, in fourth recent advance, it has been quoted as 10%, 1% of the conductive hearing loss. It's more common and prevalent in South India as compared to North. In Japanese, it is 3%. In females, around 35 years is the age which is usually seen related to the pregnancy, so that means they are hormonal. And nowadays, the measles virus has been implicated because it has been seen and genome is seen in the stapes or the histopathologically. So the various factors which are infective is measles, hormonal I said, more associated with pregnancy, and 60% of the clinical autosclerosis is this other either mother or the father that daughter they do have this problem, so it is passed on from one generation to the next. This is the new field which has opened with this genetics and various genes, especially this type 1 collagen gene is held responsible. Collagen gene 1A1 has been implicated, and the other factor which has been implicated because of this molecular thing is transforming growth factor beta. So these growth factors, they are even for the carcinoma also, and here also the growth factors by molecular biology it has been implicated. Cytokines, again there have been resorption of the bone, and these are the factors which have been implicated for this disease. So what started with hormone and racial, now we are boiling down to the genetics. So various genes, autosclerosis C1 to C10, these 10 genes have been implicated, and you can see the worldwide distribution. It is the first gene which has been seen in South India, and I said 10% of the conductive hearing loss is because of autosclerosis with the gene is intact. So for any diagnosis, these are the various steps you have to take: history, detailed history, and there itself you are able to make out the diagnosis. And detailed history is the one which you have to present during your exam also. Better the history, more elicited one, the examiner will feel better that candidate knows, and you will be thrilled for that during your history. In the long autopsy case, it is the history which is on which your YY is held, and that determines your future. Physical examination, these are audiological and radiological investigation. Is audiology is more important, so is radiology. And then you should know what are the differential diagnosis, what could be the other things which can mimic this disease. So history, hearing loss, which is slow progressive, it can be bilateral. When we are talking, we are hearing also. As we know, when you go to market or at railway station or in a noisy place, your voice tone is raised automatically because you have to speak loudly to overcome that background. But in a conductive hearing loss or this deafness, for him everything is calm and quiet. He is not able to see the ambient noise. So his volume or the speech will be soft. So this is very characteristic of it. And paralysis will say that is what I explained you in a noisy listening. So when the person speaks loudly, the threshold of this autosclerotic patient is crossed and person is able to hear. So autosclerotic patient they hear better in noisy background. Patient can have various presentation. So deafness is bilateral, progressive, adult onset. In a conductive hearing loss, stapedial type of autosclerosis, it is conductive type. It could be sensory neural when the cochlea is involved, and in almost 20 to 40% of the cases, cochlea can also be involved, and there those inner structure, endosteum, triavascularis, and basilar membrane they are involved, leading to sensory neural kind of hearing loss. So it can have both, and I'll be showing there could be various varied presentation of the audiograms. The next vertigo. This is present in 40% of the cases, and when these two symptoms are present, it means it's more in favor of cochlear type, and that is more dangerous or more severity is more. Now this new term that is superior semicircular canal disease. It is one of the differential diagnoses because the pressure is diverted adjacent and patient presents with conductive hearing loss, but he has a versatile tinnitus and autophony. He hears his own voice, and by pressure fistula test, patient is vertigo. It can be associated with Meniere's disease. All this is given in text, nothing new. When you examine the patient in textbook, the appearance, welcome Dr. Pasi, good morning sir. Dr. Bhargav, Jain sir. The TM is described classically as mint-like. Mint is a factory where coins are made. So, कहते हैं ना, you are minting money by your practice. So, TM will be normal. Uniform test to assess the hearing. Linear will be negative since it's a conductive hearing loss. Weber will be lateralized to the worst ear, and sometimes if the autosclerotic focus is young, growing type, active, then you can see a red blush there, and this is known as flamingo sign, which is a sign of active autosclerosis. The audiogram, in the low frequency, there is a hair bone gap, so it's conductive type, and in higher frequency below above 1000, the hearing is more or less normal. So in the low frequency and after 1000, high frequency there is normal, and subsequently 2000, and this is Carhart's launch. Carhart was an audiologist from Germany who noticed this feature. It's not ENT surgeon. And this is because part of the bony conduction is through the air conduction. So because of fixation of the foot plate of stapes, this part is represented here, and this is also known as pseudo-bone depression. Once the successful stapedotomy has been done, so this Carrot's notch will disappear. That's why it's known as pseudo-bone depression. Same thing. And sometime in a cochlear autosclerosis, if you get this kind of presentation where it is mixed type, both sensorineural and conductive, and also in the mid frequencies, then it is cookie bite, as if you have taken a bite on the biscuit. So this kind of appearance is called cookie bite. Then this is a secondary test, tympanometry. Here the is it should be a investigation along with the audiometry, and you can see there is a thickening. This is the pyramid, this is the round window, and here you can see anteriorly fossula interfenestrum, where this newly put laid down bone is seen. This you can see in the round window, basal turn, and this is the part where the round window should be there. So this is the again another focus. They can be in cochlear type. There is something called halo sign. So here you can see almost all around the cochlea. There is a spongy bone, and this is radiolucent, known as halo sign. This is diagnostic based on radiology. A classification of autosclerosis has been devised, and it is mainly the fenestral type, type 1, where the enlarged part and it begins in the anterior part, fascial antifenestral, and then posterior part. They can be double ring. Then type B is when the beyond the fenestra windows. Then narrow basal turn, and in type C, double ring plus narrow band basal turn is included, and in type 3, that is cochlear type or severe type, where there is a obliteration of the round window, that is type 3. So this is one something new. In histopathology, this bluish discoloration is known as blue mantle of Manasseh. So this very patient who had a halo sign, whose histopathology was done, these are the photo from latest Hosseini. So you can see the ring all around and see it is being correlated with the radiology. So what I said just now, this is anterior type, this is posterior type, and this is marginal or circumferential, and this is distal type, and there the almost all of the plate and the niche, round window, wall window niche is obliterated. Other side could be in the internal aortic canal, cochlear aqueduct, and these fascial antifenestrum and round window plus cochlear effects, they almost constitute 2/3 of the site where it is seen. The differential diagnosis, this would be the come as a query question. What are the degree of autosclerosis? Third window I said, pulsatile, tinnitus, autophony, pressure, vertigo. These are special features of this. And to detect this fistula or erosion, postures is the view which is sometimes asked in exam to see the superior and semicircular canal cases. It could be congenital fixation. Even simple thing like middle ear effusion that can present with this, conductive hearing loss, ossicular discontinuity, tympanoid sclerosis, tympanic membrane. Then it may not be the stapes which is fixed. It may be the other ossicles like various incus which could be fixed, congenital cholesteatoma, Caroline fistula, Paget's disease. cholesteatoma, and osteogenesis imperfecta. So once the diagnosis has been seen, so what could be the contraindications for this surgery? There are two, relative and absolute. Absolute are when only hearing aid, and if by chance the patient is so unfortunate, something goes wrong, infection or because of anything, with that ear which you are operating only hearing aid, patient will be lost with the left with the total deafness. So only hearing is again contraindications and development and drops. So others are pregnancy, early fixation. Don't operate the patient when he has hearing loss less than 30 dB, because if it is less than 30 dB, which there are high chances that you will end up with a floating foot plate during surgery. So the plate may get lost and you will then have a floating foot plate. That is a complication. So at least 30 dB hearing loss should be there before you subject the patient. Below that, person is able to carry out his day-to-day services or he can hear. So that is the cut-off line. So what are the options for the patient to look for? He can have a surgical treatment. He can go for a medical if it is cochlear type. That is the one which is active. Or if patient doesn't want anything, simple solution is sending the hearing aid. Hearing aid, if it is surgery, patient is poor candidate for this thing, or early conductive hearing loss can be taken care by amplification or with the surgery. Then the various surgeries which can be done are stapedectomy, that was earlier, and stapedectomy has been associated with more complication. So people have modified, and stapedectomy is making fenestra or hole in the foot plate so as to transmit the sound. And stem. Stem was asked in this Indian exam once, so you should know what it is. This surgery can be done under GI or local, depending on the facility and the compliance of the patient, or with the patient in confidence. You explain it will be mild pain like this. You get the tooth extraction under local, something similar. So this incision is Rollins incision and bucket handle, and this is because when you elevate the flap for tympanotomy, it should not fall short when the bone is curated. And if you have to take plan the thing subsequently, what will be done? Next step is to curate. So it should be reflect back and stay back on the bone. Otherwise, if it is too, if you take a incision closer and you are curated, so you will be leaving the middle layer exposed to the external canal. That is a preventive step. And this is how the curettage is done after tympanotomy. Elevating the flap. This is the site which you have. This is the round window, long angle of long process of incus, chorda, and the curate should just engage to the edge. Some people where the facilities are there, speaker can be used before you elevate this. After elevating the flap, when you reach the analysis, don't open the middle ear and do the thinning with the help of speaker in the facilities, or sometime even a small size bar can be used. And the question is, I showed you in the last slide, curettage. When you say that curettage is adequate, there are three sections which should be clearly visible: complete foot plate, pyramid, and the facial nerve. These are the again a standard YOC question. This can be either in the instruments where you are asked to pick up an instrument. So in general, the examiner gives CPs and they want to discuss that. Stapedectomy, when the whole foot plate was removed, and every one of you must read the history of stapes. It's well given in OCNA. And earlier, the stapedectomy was condemned outdated operation because patients used to have a lot of pre-antibiotic era, meningitis and all kind of problem because of urinary infection. So those fenestra operation, all that started. It was John Chia at the age of 37 in 1956 in a World Congress on cornerstoma. He asked the organizers to give him 5 minutes, 15 minutes to present his work, and they what he did. It was against all odds that he presented, and it was well appreciated. So in this normal conventional study and this surgery, you have to do the dichotomy. Till now, this stage, elevating the flap, either you do dot me or dat me. Remove the whole foot plate or just make a fenestra in the foot plate, the steps are the same. You remove the suprastructure, then with the measuring rod, you measure the distance at 0.25 for the penetration of the foot plate of the stapes. So the distance could be measured from the upper surface of the this thing malleus, or it could be measured from the upper surface. If you measure from upper surface, detect 0.25, and if you measure from the under surface, add 0.25. Then this tapedectomy, it has more trauma to the inner ear. There could be more complications, high incidence of sensorineural hearing loss, and the complications could be floating foot, they could be fracture of the foot plate, or they could be during this curettage dislocation of the subluxation of the malleus. So these are the problems which can occur. So it was modified, and there is a modification. Fish modification is reverse the steps. First measure the length, do the fenestra, and then do the subsequently. So by this suprastructure and all this, the foot plate is still intact, and you are not going to have the chances of floating foot plate is less, and the process is placed, and then do the steps in from reverse. As in nasal surgery, when you start doing from posterior to anterior, this ethmoidectomy. So that way this surgery is done. So first you put a prosthesis and then remove the suprastructures. The other modification is in that we cut the tendon, and here we preserve the tendon because stapedial tendon and this muscle is important. If there is any blast or something of that kind, then this tensor tympani and stapedius muscle, they stiffen or tighten the ossicular chain so that no more energy is transmitted and the inner ear is protected. So God has taken all precautions even at such a micro level that the excess energy cannot be transmitted to the inner ear. So during this SETI surgery, the tendon was sacrificed, but when you cut below the insertion of the tensor, this SETI tendon, so this dynamic or functional type of this thing is done, and again those steps are done where the piston is put, and this type of stapedotomy is known as functional or physiological. As the advancement is occurring, the various advancement which has occurred is the micromotor or the drill. Second is STEPI, this laser which has come, and the FES, endoscopes. These have revolutionized the scope, widened the horizon of surgery of ENT. So the laser, to start with, argon and KTP were used. Now even carbon dioxide used. So it avoids trauma to the inner ear, which occurs because of fenestra, making fenestra, or reduces the post-hearing hearing loss or dizziness. These are the symptoms which sometimes the patient may linger on with post-operatively. Or that since we are not pressurizing, we are just making rosette on the foot plate of therapies, and easier to carry out the fenestra as compared to vaporize the tissue, depending on the power of the laser which is used. So if there is any stapedial artery, you can achieve good hemostasis, and the long-term results are better as compared to the conventional cold steel surgery. STEM. Again, this had come as a question in your, it can be there in the theory, it can be in the OSCE, and in this NTA type of autosclerosis, fistula antifenestrums, where this is the one, and when this lesion is there, it pushes the, so there occurs jacking of the foot plate. If something new is fixed, so the foot plate mobility is reduced and the plate is pushed posteriorly. So with the laser, you cut the anterior part and get rid of this excessive uniformly formed bone, and your bone of the rest of the thing is mobile. So this is known as stem. This is staphylotomy without prosthesis. So tendon is intact, the plate is quite good enough, and your fixed status becomes mobile. So all of this problem protruding into the vestibule, length, measuring everything is same. So it's more or less you are using the natural status, just getting rid of the extra. So this is stem. Processes. This was the earlier start of John Cia, which he used, and this is the natural normal stapes, and this is what he carved out, and this was the one which was used. This is housed wired with the loop where the fat is kept, and this is long. In Mansi, one of the theses for this netinol was done. It's an alloy, and Dr. Pasi guided one thesis, and this paper, I think it was published. So here it is when in one of the steps you have to crimp. So it is self-crimping. So you just put a small heater, that lighter kind of thing which you see on the palm scala, that kind you put on to light up your cigarette. So that small heater is there, battery operated. With the small probe you touch it and it crimps. I've seen the surgery being done by Dr. Asi. So it's very self-memory without any pressure, extra pressure on the handle of Milius, because that is subsequently undergoes necrosis. This is that thing. Now this clip is there, that this Teflon which is commonly used, and these are the special one. Suppose the handle is a long process of incus is subluxated, and then what is the option? So here these are longer loops as compared, you can see the length, and this is directly put on the malleus. By your virtue of knowledge of anatomy, that tympanic membrane is just like your तीर कमान की तरह attach होता है उसके ऊपर. So at the short process of lateral process of malleus, and at the tip of handle of malleus, it is attached. So that is the two sides, and in between the under surface of the malleus is free, where this and it is crimped. I have not seen it. That is what is being described at textbook. And they say, once I spoke to Dr. Puri, this complication had happened while he was doing. So what is the option? Because that is the type, and it is quite difficult to carry out. And this is a new type of this thing, processes which has come, or piston which has come. Suppose the revision surgery, and you find that long process of incus on which the piston was kept, it has undergone necrosis. Now what is left? Small remnant rudimentary type of thing is left. That is put into this, so it gets inserted, and this is the which acts as a piston, and here is the that necrosed part. So these coils are just to make up that necrosed part of the handle of long process of incus. The laser surgery I talked about. Now keyhole or everywhere you want to have minimum access. So endoscopic surgery has taken up now, endoscopic position has been formed, and people are doing in mesh under this endoscope. The disadvantages are it is single hand, risk of thermal risk is there, and long learning cow is there. But the additional advantage is It has a better visualization, wide field. You are closer to the structure. You can see it loud and clear. This is again an important question which you will be asked. What all can happen during surgery? So when you are raising the flap for a noise, even while infiltrating, there can be the skin is quite firmly adherent. There can be flap formation. There can be tear, and your diagnosis may. So in state of status, it was Marius which was fixed or subluxation of incus. Again, this is a YOV question. Descent, and it happens above the whole window, and it happens almost in 2/3 of cases. You can come across the obliterative focus. You have to thin out or laser out or drill it out to make the thing. And when you are closer to the thing, vestibule, the bluish line is there, and then you can the perforation. They can be round below autosclerosis, epithelial artery persistence can be there, and pressure can be there when you open. There is a lot of fluid loose, and the surgeon sees one such case in the life, and I saw in Ajmer during one of the camp, and it was Satish Bhatnagar who was doing. He was our senior resident, and I was AP that I saw him there in that case. Cochlear type of autosclerosis. Earlier, these were patients which are left to their destiny, but now they have hope in the form of cochlear implant. So, in the case of advanced cochlear autosclerosis, this is a flow diagram which I had taken from the latest OCNA. So, if the patient doesn't accept for surgery, then he is the one potential candidate for hearing aid. And if hearing aid again is not agreeing for the stapedotomy and this hearing aid, then is the one because the nerve endings are still functional and intact in this. Or accept, then do the stapedotomy, and then patient can use the hearing aid. So hearing will improve. If the outcome is or speech discrimination score is below 30 or 50, then So one should be careful when doing it, otherwise you can hit the handle of a long process of vehicle. Piston is put on the long process, and then crimping is done, and then you have to press the hearing on the cable, speak slightly loudly, and then keep on releasing the tip. The question is, you are in one policy, what can be asked? You have done a successful CT surgery, but still the patient is not able to hear and is after use. This could be one practical problem. What could be the base of this? If the measurement of the length was not proper, it was short, or if it is the low end has come out, patient has some other fixation on the either aliens or incus, or various that could be there, or the earlier it has improved, now it has deteriorated. The long process of incus has undergone necrosis. So or that superior semester canal lesions is there. So these are the questions which can be asked in our course. With this, I come to an end. Thank you. Thank you. I will be more than happy to answer any question. Thank you so much. Answer. लेकिन मैंने तो आपसे कॉपी मान सीखा
You have taught all of us, especially focusing on postgraduates. You have told at every step what can be the viable question. That's very, very important information because this is primarily a resident conclave. I just want to add one more thing into the procedure of tracheotomy. Dr. Ishwar Singh has told about the curate, but you can also use a drill to remove the posterior superior osseous canal wall.
For user, Skeeter can be used there.
Skeeter is the one which you can use. But of late, I have started a different technique which is not given in the books. I have started using the post-oral approach under very much better vision in narrow canals in particular. Post-oral approach, and you can use your drill freely without any risk to the facial nerve and the suprasummative. So this is just what I wanted to add. Thank you for giving that. Yes.
Conventionally and also told, we have been taught that this is regarding the tympanogram. That we get tympanogram, that we get type AS type of curve. This type AS type of curve is not pathognomic of autosclerosis. It is rather very uncommon in the autocrosis. We have seen it is very much common in other types of fixations like sclerosis and extensive tympanosis. ऑटोस्क्लेरोसिस में हम पेशेंट्स देखते हैं टाइप ए कर्व ही दिखती है टाइप ए इज वेरी 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 तो हम लोगों को पढ़ाया भी गया है लाइक दिस वी हैव बीन कन्वेंशनली taught it is given in the books also so there might be some reason I started searching for it for the last so many days I couldn't find type S curve is I repeat not pathognomic of autosclerosis second point we were talking of aviators. Mind you, when your person comes, his profession, his or her profession is aviation, pilot, please don't offer staphylococcus to him because he or she will be permanently unfit for flight because staphylococcus. Okay, so these two things I wanted to clear. Thanks.
Sir, this what you said. This type of this is known to occur because what you said other than STDs. So these are the differential diagnosis. So even the differential in that STDs, you have opened, you have done everything, but the cause is somewhere else. So that is one of the cause of failure. So it can be there, agreed. You can. Do you mean to say that it is not diagnostic?
They should not expect ES curve in all cases or simply.com.
Yes.
This is what you want to say.
And other thing is, yeah, those who are in pilot or flash, actually they should be not subjected to step that I agree to that point, and it's well established, well known because they are known to both complications. So now we have better equipment, laser and other things, so patient can have that. Earlier, the popular type of autosclerosis, those patients were left to just medical type. Now, so that they are offered popular equipment. Threshold is more than 50 TP. And nowadays, I said it's that right. So even those patients, they have a right feature in the form of cognitive. Yeah. Yeah.
Yes. One practical question is when there is the overhang of the patient now is inside. So what condition you decide that we cannot go ahead with the surgery and it's better to wait in the surgery?
When the facial nerve is covering 2/3 of the full plate of stapes, that is where we is taken now. Because rather than giving a irritated face to the patient, it's better that we also hearing irritation.
Interesting that in so detail, there is hardly anything to add. But I want to add one thing. Here is called bisphosphonates. Bisphosphonate for the and everybody will be happy and told so many side effects. But there is a serious side effect. It can lead to cardiomyopathy. Actually, each patient should be told to stay erect after taking the drug, at least for 2 hours.
Reason for it, it's not given in Oceania. My reference is Oceania.
Because this phosphonate is noted by opinion.
It is given by the orthopedic.
That's why it is not given. Second, a very odd thing I want to tell. Everyone who have had a renal positive, renal negative, false negative. There is a false positive. Anyone? Have you heard of this term, false positive? This is the oculopostures.
Thank you, sir. After 2 weeks, it has been said.
Other? Yes. I think we have already overshooted time. Thank you, sir.
I request the resident to come forward. Why you are sitting so back?
Thank you so much, sir. Now I am honored to introduce our next guest speaker, respected Umagat ma'am on the stage, who will enlighten our knowledge regarding oropharyngeal cancers. Ma'am is currently professor and head of the Department of ENT and BPH CMC Kanpur. She is very actively involved in research. She has done 2 projects with ICMR as the principal investigator. Ma'am is an active member of AY Haryana branch, FHNO and IAOHMS. She is the chairperson of TOEFL and BPH Kanpur. Ma'am has published more than 60 papers in various national and international journals.
Good morning, everybody. So, after this extensive knowledge on otology, now we'll shift to head and neck. So, whether it is a PG for MS exam or DNB, usually we get, if it is available, we get a case of head and neck oncology, and that is why I want to discuss colorectal cancers. So, anatomy is a roadmap to any area for understanding anatomy, physiology, and later on pathology. And we know that oropharynx is a part of pharynx between nasopharynx and laryngopharynx, and this is the area of oropharynx. The upper limit is posterior part of the hard palate where it joins the soft palate, and below it is at the level of hyoid bone, and in between is the, you can see this is the oropharynx, above nasopharynx and below oropharynx. The old Scott Brown gives classification of oropharynx just into 2. One is the palatine arch, which is consisting of this anterior pillar, uvula, and anterior on the other side, and rest of the oropharynx was oropharynx proper. But this was the old classification, and this is again in detail because you have to understand. This is the superior limit or the superior or roof where it joins the nasopharynx, where it joins the hypopharynx. This is a posterior wall or posterior pharyngeal wall, and lateral is anterior pillar, tonsil, and posterior pillar along with pharyngoepiglottic folds. So you can see roof is deficient posteriorly and even floor is deficient posteriorly. This rises up and closes in the form of soft palate going towards the posterior pharyngeal wall to prevent food from going into nasopharynx during swallowing. And here also it is supposed to, the epiglottis is supposed to cover the larynx during swallowing to prevent aspiration. So it is crossroad between aero and orodigestive tract, but has got several small subsites which may be base of tongue, tonsils, as we saw, soft palate, posterior pharyngeal wall, valiculae bound by median and lateral glossoepiglottic folds, lingual sulcus of epiglottis, posterior pillars, tonsillolingual sulcus, anterior pillar, uvula, lateral pharyngeal wall, pharyngoepiglottic folds, and posterior pharyngeal wall that rests on C1, C2, 3 vertebra. And as I told, old spot bone is just 2 parts of oropharynx. But these are so many small subsites. And being a crossroad, it has an important role in various functions like swallowing, speaking, and breathing. Important to note that anatomy of oropharynx is very intricate. The boundaries between oral cavity and oropharynx, nasopharynx and oropharynx, oropharynx and laryngopharynx, and larynx and laryngopharynx, that is very subtle, just in the form of ridges and depressions, and they are ill-defined and imperceptible. In addition, irregularity over the base of tongue and tonsils make it difficult to identify small lesions on naked eye and also pose difficulty in achieving surgical markings. So anatomy is very intricate. And because of this inappreciable demarcation between different areas, between different subsites, the disease crosses easily the boundaries without manifesting apparently, and clinically it becomes difficult to know where actually the pathology started. However, clinically from the hierarchy of symptoms, this can be known. Another important points about oropharynx is that the retropharyngeal and parapharyngeal spaces are in close proximity and serve as potential cancer. BOT tumors can spread to larynx, tonsil, and oral tongue, as we discussed. Then bony boundaries which are in close approximation are maxilla and mandible, and tumor can involve these areas without presenting with variant disease. And the nerve supply is from 9th and 10th cranial nerve. Lymphatic drainage is very important to discuss about oropharynx. Mainly, it is to level 2, which is known as uterodigastric lymph node, level 2 lymph node, or a junctional lymph node, which is at the junction of level 2 and level 3, which is known as jugulo-omohyoid. And here, even other areas can drain directly or indirectly, and therefore, level 2, especially, sometimes level 3 becomes important to attach significance in case of this suspicion of oropharyngeal malignancy, and also in carcinoma of unknown primary. In carcinoma of unknown primary, also more than half cases, the primary later on comes out to be oropharyngeal. Ipsilaterally, some drainage may occur to level 5 and contralaterally to level 3. So here you can see basically that when contralateral from the posterior part of the oropharynx, even contralateral, the lymphatics may drain. And in this picture, it is important to note here that this is a uterodigastric lymph node, these are the level 3 lymph nodes, and this is the posterior part. And the lymph may drain from uterodigastric directly or sometimes indirectly to retropharyngeal group of lymph nodes. So, and Mayer says that soft palate especially has got 3 drainage systems, anterior and posterior, and in this case, posterior in particular can drain to retropharyngeal lymph nodes, which can be bilateral because this crosses and penetrates superior constrictor muscles besides the bilateral deep cervical nodes, which are set laterally. So, but tonsil also drains mainly to tonsillar node or level 2 node and sometimes to level 3 node. And posteriorly, sometimes to level 5, but retropharyngeal lymph nodes are mentioned almost in every textbook that oropharyngeal and posterior part of the oropharynx drains to retropharyngeal lymph nodes. And from here, the simple extension, direct extension can also occur to parapharyngeal space, which is close to retropharyngeal space, and this can also lead to retropharyngeal lymph node involvement. This is another same diagram showing uterodigastric, retropharyngeal, level 3, and the superior constrictor muscles, so retropharyngeal lymph nodes are involved. Same thing you can see here. So, retropharyngeal lymph nodes are involved, which may be directly or indirectly involved in oropharyngeal cancers, and different studies show varying involvements of retropharyngeal lymph nodes in advanced oropharyngeal and sometimes hypopharyngeal cancers. One of the studies shows involvement of retropharyngeal lymph nodes radiologically in 26.5% of cases. But the thing which I want to emphasize over here is that usually retropharyngeal lymph nodes are not mentioned in staging of oropharyngeal cancers. Physiology will know that this is such an area that all 3 functions of swallowing, speaking, and breathing, they are affected or they are helped by oropharynx. And in advanced presentations, it becomes difficult to know where the disease started. So how do these oropharyngeal cancers present? We know the subsite. Any subsite can be involved. Dysphagia, difficulty in swallowing, painful swallowing, or just pay attention that it may just be an irritation in the throat, a sore throat for a long time, or a sore mouth. Just refer to otalgia because of its nerve supply. A painless swelling in the neck because lymphatic drainage is so rich that sometimes patient does not present any dysphagia or rhinophagia, just a lymph node in the neck in the form of a secondary. The duration to present will take usually 2 to 3 months, but patient may take longer to reach a doctor. Sometimes over-the-counter medicines are taken. So you have to be very careful about the features that even if you are not, I mean, if you are suspecting and you're not able to find anything on examination, you may keep the patient in follow-up or do a better examination. So besides history, clinical examination is very important by inspection, palpation of oral cavity, pharynx, larynx, and neck. And it is important to mention here that it's not only the inspection, palpation with a gloved finger is very, very important because sometimes over the base of the tongue, which is a very common site for oropharyngeal malignancy, just a thickening or an irregularity is there, and therefore just looking at it during inspection or even by a 70-degree endoscope may not suffice. Palpation of the area is very, very important. USG for neck nodes is very important. Very good investigation with a good radiologist. It can give you an idea about the lymph nodes involved. CT, MRI, and PET scan are advanced investigation, but they are now a part of our diagnostic armamentarium. In early stages, a simple X-ray test sapien lateral can give you an idea about the distant metastasis, which is most common lungs, and USG abdomen for distant metastasis. Then final aspiration biopsy, incisional biopsy or biopsy, and after all this workup, staging is very, very important. So how is the staging? Staging is TNM, clinical TNM, radiological TNM, and pathological. Clinical is now divided into HPV associated and HPV not HPV associated because nowadays is about 2-3 decades. Many of the oropharyngeal cancers, a good percentage of oropharyngeal cancer is found to be HPV associated. So a different classification for HPV plus or HPV minus oropharyngeal cancers, and it is important to know because the diagnosis is okay because prognosis and treatment may be different. Then radiological TNM and then pathological TNM. So now clinical, this is a theoretical part which you all have to learn because whenever you get a case after evaluation, it is very, very important to know the stage. What is the TNM staging? Because depending on the TNM staging and the composite staging, the treatment or management will start. So this is from 8 AJC and you can all see it in the books or on net. So it is T1 less than 2, T2 2 to 4, T3 when it is involving lingual surface of epiglottis, and this is T4 and T4A and T4B. N is almost same as it was. Only thing added here is that whenever there is an extra nodal extension of the nodes, then it becomes N3B. And then there is a composite staging which is combining TNM. Then radiological TNM, because when we do CT, MRI or PET scan, many of the times or mostly the TNM staging is upstage. And then you decide the treatment because there are some things which you cannot palpate with your finger, which you cannot see by endoscopy, but radiology is able to tell us about those areas. This is composite staging. Again, this is a theoretical part and you will all have to remember it. So what about the treatment? Since many years, I mean, the last 3-4 decades, because whatever growth was seen, that was removed. So open surgery was the first line of treatment. And sometimes they were giving radiotherapy post-operative period. Then radiotherapy, chemotherapy either in the form of induction, but then came concurrent, which is CCRT. Even though we got transoral laser surgeries, means surgical methods that we got in an improved manner and transoral robotic surgeries, but still we needed something else. And in the last but not the least, we are now, which is still in experimental stages, we are using it also immunotherapy, which is more useful in recurrent and metastatic settings. So it was either open wide tonsillectomy, which was intraoral, and we during surgery we support the superior constrictor. Then there were various other approaches to oropharynx by mandibular lingual release. pull through with an oral incision through lingual periosteum, or from the inner edge of the mandibular table, or a suprahyoid approach, or a lateral pericordial approach, or external approach. Then sometimes transmandibular approach, which was either an approach to mandible or sometimes along with a part of mandible to be removed if it was involved, which was in the form of segmental or margin. Then till mid of 20th century, commandos operation was very popular. And now also, if you are interested in head and neck oncology, you all must know what is commandos operation. Commandos operation is basically an extensive surgery for an advanced oral or oropharyngeal cancers, and it means combined dissection of oral cavity of oropharynx along with neck dissection and mandible. And it's an extensive surgery, and still it is being done in its modified form. But these surgeries were extensive, extraoperative, mutilating, and they result in all three functions disturbed, that is dysphagia, speech dysphonia, because speech was also not very good, and also aspiration. Also lead to velopharyngeal incompetence, pharyngeal stenosis because pharyngeal muscles were cut, and leading to decreased pharyngeal contraction and the suboptimal and delayed swallow. And at that time, because antibiotics were also not so good, so results were not that. If neck dissection was done, it was more morbidity. If bilateral neck dissection was done, still more. And then in many of these cases, retropharyngeal lymph nodes were not being addressed, and in the literature, the involvement of retropharyngeal lymph nodes is known to affect the oral survival, disease-free survival or otherwise. Then post-operative also, if nodes were positive, there was extracapsular extension or margins were positive, again something. So this surgery, whatever we were doing was not enough and something more in form of adjuvant was needed. So though we got advancements in the form of transoral microsurgery, transoral robotic approach, and a small triangle transoral robotic surgery was done, a thulium laser, but adjuvant was needed in all. This surgery alone was not sufficient. Then came radiotherapy. Because during these days when we were doing surgeries, whatever was available and whatever knowledge we had, in those cases also, the research was going on in other parts of the world to see a modality which can preserve functions better than surgery. And the radiotherapy came into light. The radiotherapy was being used sometimes radically, 70 gray units in 35 fractions over 7 weeks of time with covert or linear accelerator. And as we had progress in delivery methods of radiotherapy in the form of intensity modulated radiotherapy, image guided radiotherapy, intensity modulated proton therapy, we had better results because this could spare parotids and also pharyngeal constrictors. And these modifications lead to improved leukocyte scores and better swallowing status. So results alone with radiotherapy were not good, whether they were being used alone or before or after surgery. In the beginning of 20th century, we started thinking about chemotherapy. It was single agent or multiple, but toxicity was very, very high. Though it was said to control or help in controlling distant metastasis. Different agents which were being used were methotrexate, 5-fluorouracil, cisplatin, carboplatin, paclitaxel, docetaxel, and it was being used as either induction or neoadjuvant and sequential, and these all mean same. Induction, neoadjuvant, and sequential mean same, followed by a radiotherapy or surgery. And adjuvant when it is used along with radiotherapy after surgery, and now latest is concurrent. Cryosurgery I just mentioned here because we have in our time seen cases of oral cavity and oropharyngeal cancer treated with cryosurgery, but nowadays it is not being used at all. But latest in treatment of oropharyngeal cancers is when we use combined modality, which is also known as consort or concomitant, and this is concomitant radiotherapy. And now it is the definitive curative treatment for locally advanced tumors of oropharynx, may be sometimes used post-operative or as salvage. It always, or whatever studies we have, they show better results. Like here, the complete response was seen in 80% versus 67 in other arms. Overall survival 3 years was 62 versus 42 in other arms. Overall survival again for 3 years was 51 versus 31 when CRT or combined radiotherapy was used in comparison to radiotherapy. The latest thing is red flat. So concurrent radiotherapy, in main this drug uses cisplatin which can be used daily or weekly or 3 weekly, and all these doses are still being investigated or experimented to have a toxicity to the minimum because chemotherapy has got a great toxicity. Then now this can be used with cetuximab, with paclitaxel which has got less side effects, carboplatin which is less toxic than cisplatin. Red blood is the latest, which means radiation along with platinum based therapy. Here the platinum based therapy is used intra-arterially along with radiotherapy, and this is being planned, or this is being still experimental status to again have minimum toxicity and maximum good effects by chemotherapy. So CCRT is proving better because it is preserving anatomy physiology better. Here chemotherapy is acting as a radiosensitizing agent, and when radiotherapy is used along with it, it becomes super additive, survival is good, but toxicity is still formidable and very high with chemo CCRT. And distant metastasis which they claimed before may not be controlled. But still, it is being used as standard treatment for locally advanced oropharyngeal cancers, and this gives better results. Immunotherapy also, many drugs are being used, but cetuximab is most commonly used. It is EGFR inhibitor, and it is said to act on programmed death ligand 1 axis. Despite of all this, we have recurrences, results are not good, and you have to have a very intensive follow-up, and combined modalities are better. And factors affecting recurrence and further prognosis in oropharyngeal cancers are the results are not good. Why? When it is advanced stage, when short disease-free interval, when it is in site is oropharyngeal, chemotherapy is previously used, poor nutrition, comorbidities, and all those things. So why did I choose this topic? Because the area everywhere in other parts of the world and in even India, oropharynx, they constitute a very important percentage of head and neck cancers. But in the area where I am working, and we have seen that of all head and neck, sometimes 50, 55, 60, sometimes 75% of all head and neck cancers are oropharyngeal. And again, the tonsils and BOT, they remain most commonly involved. So why is it so in that area? This is that mostly were squamous cell carcinoma. For example, in last 125 years, 99 cases of oropharyngeal out of 142 cases, more than 70%. All were smokers, as we all know that the etiology is tobacco along with alcohol, tobacco alone or alcohol. And the mode of tobacco use is hookah, very commonly in this case. And even in recurrent cases which we had in our follow-up, there were the cases where they did not stop bleeding or hookah. Other than squamous cell carcinomas, we had some poorly differentiated carcinomas, some 2 cases of minor salivary gland tumors, and 1 or 2 cases of lymphoma. And again, this is a very important slide to see that stage 1 or 2, this is I am talking about the series which we have. Stage 1 or 2 were very few, and almost most of them were stage 3 or 4. More than 67%, 2/3 was stage 3 and 4, which is considered advanced and early. And we all know it's a very simple thing to know that if stage is early, natural results are good, and most of the cases they are present in advanced stages. So why is it so? So I tried thinking that why it is so. Is it because of more hookah smoking in this area that we get more oropharyngeal cancer? Is it because of delay in presentation and diagnosis? Is it because we have less resources? It is because some pitfalls in staging where retropharyngeal should be considered, or it is because now we have got cases because of HP. Now, hookah, what happens in hookah? We know tobacco is important. Alcohol synergistically is important. So, how does hookah make a difference? Because for hookah sessions are very long. So, amount of smoke taken inside is very high, 20, 30 times more. Because cigarette or bidi will take 5 to 7 minutes, but hookah sessions are about an hour or even more than that. So, when smoke is inhaled through mouth, this is through hookah, and a puff is retained in mouth for a while. It is held for a period of 2 seconds. It forms a cloud in the oral cavity oropharynx. Some deposition occurs there, but moistened, as they say in hookah, the smoke comes through water. So moistened and also stickier. The stickiness also increases because of saliva. They become heavier. These particles in the puff, rather they are now converted into aerosol. They may be more in hookah puff, and then some of them deposit in oral cavity, and then rest of them they go to oropharynx, and then left over lighter particles in the puffed air which travel further downwards. So I tried to make a hookah hypothesis at why this occurs. So there are large volumes of smoke, because large volumes of smoke are taken in hookah. They are being inhaled at lower temperature as it passes through water. They are held as puff in mouth for 2-3 seconds from a cloud, and they are cooled, heavier, and sticker carcinogens. But when they travel from high volume area of oral cavity to low volume area of oropharynx, which further concentrates the chemicals, and in addition, oropharynx has got turns, bends, roughened areas, dips, elevation. They are very small subsides. And therefore, a bottleneck is created with the smoke particles. This congestion leads to more deposition of carcinogenic agents and leading to carcinogenic changes pre-cancerization. Also, in smokers, impaired mucociliary mechanism aggravates the problem as there is less movement or drainage and more occupation, so more damage. So, hookah may be responsible for more oropharyngeal cancers in this area. Then, second point was delay. Everywhere there is a delay. Patient takes 2-3 months to appear, first to RMP or the local practitioner, and then to specialist. But still, there is a delay in presentation to the qualified or specialist, and hence leading to delay in diagnosis. Because in the beginning, just a sore mouth or sore throat, patient may be because of because of smoking, because of GERD, and a local practitioner may tick it off. And this delay is either at the level of patient or clinician level. And I would like to mention here that we had conducted a study in the form of a thesis at our institute, where we found that there was a mean total delay of 22.38 plus minus 7.3 weeks in presentation and then final diagnosis of these patients. And here, patient delay constituted most of it. Because patient keeps on going here and here. Patient doesn't want to listen or doesn't want to acknowledge that he may have a malignant pathology. Sometimes there's a delayed patient's level. But then at clinician's level also sometimes we have a delay reaching a definite diagnosis because it involves multiple visits, years of investigations, preparation for biopsy, histopathological procedure, delay in biopsy report, and these patients often being smokers, they are poor candidates for anesthesia, and so they are at risk for complications. So this also adds to delay in taking biopsy where we cannot take the biopsy under local anesthesia. So retropharyngeal lymph nodes, literature showed that will be involved in 10 to 44% of head and neck cancers. Head and neck cancers I'm talking about. But we all must remember that retropharyngeal lymph nodes are neither clinically palpable not accessible, and usually they are not looked for in radiological pictures we usually get for evaluation. And there's a possibility that apparently N0 neck may not be an N0, leading to inadequate staging and prognostication of cancers. And CECT, what we usually get to stage, has got a low specificity for retropharyngeal lymph nodes, either MRI or a PET CT should be done. Again, a study is going at BPS, and radiologically, we are finding in series whatever we had till now, 30% cases of oropharynx cancer or growths, they show radiological involvement of retropharyngeal lymph nodes in about 30 out of 100. Resources are very few in my area or the area I'm working. Only few tertiary care centers, accessibility, affordability, few medical oncologists or surgical oncologists, or lacking a teamwork, not much of choice, and this also delays treatment. Then there is a new class, HPV associated oropharyngeal cancers. These patients are younger, usually male, from educated strata, maybe association with sexual behavior, often non-smokers, have small primaries, lower p-value, large cystic nodes, unpredictable distant metastasis, but have got a good response to radiotherapy for RDC, and better survival, and recurrence and failure rates are also low. So most of the, if you have got an HPV virology lab, then we can send a specimen for this testing. And here in our institute, we had got it started, but now it is not working. And initially, out of 20 cases, we found H2B positive over 10 cases. But I think this is inconsistency of results. And in detection of HPV positive over cancers, various studies say that it may be from 25 to 80%. But in addition to this, if these patients are heavy smokers or taking alcohol, then HPV positivity makes them higher risk. There were some differences or additions in 8th agency. This is again to be seen on the books. Only there are some differences because they wanted to give a separate classification for HPV positive and HPV negative oropharyngeal cancers. So from our series, all were sent to higher centers. They were treated either first only for radiotherapy or CRT or surgery wherever it was possible. And we found that early stages had good prognosis, though I don't have the data. And survival with CRT, RT, if tobacco is stopped, the results are very good. And 3 patients we are having a follow-up, which are having 6 years post diagnosis. Survival 10 years and 23 years, though this patient was not diagnosed by me. So a very intensive follow-up is required. So what are the recommendations for all these cases? For oropharyngeal cancers, I'm talking about that all chronic sore throats, you must pay attention. Don't ignore them. Follow them up if you're not able to find any pathology. Inquire about smoking and stop it. Field cancerization is over a large area, and this may be making any area fertile for carcinogenesis. Growth become later. Clinically apparent lesions, or you think that there may be something but you're not able to find, a good examination, counseling about tobacco, and good follow-up. And it is absolutely essential to examine meticulously and palpate than to just see it with naked eye or with endoscope along with mandatory documentation. Neck should never be forgotten. In case of negative biopsy or dysplasia, negative biopsy is also problematic in some of the cases. Or dysplasia, again follow up. But important thing is that lifestyle modification is must. It has been found. If patient does not stop smoking, result of treatment may not be good and recurrence is earlier or must. HPV testing is very important if it is available. Early diagnosis undoubtedly gives good results. And it is for the authorities, it is for the government. Give us more infrastructure for human resources. Immunotherapy is still in experimental stage. Thank you.
We accept excellent lecture, ma'am. Such a detailed and your personal experience you have added. It was a very nice presentation. And I think for the PGs also, you started with the right form, the format, history taking, and the importance of palpation, which is so important in diagnosis of oropharyngeal malignancy, especially the base of that. Thank you so much.
Very nice presentation, ma'am. I want to add one thing. If we take smoking plus alcohol, it increases 17 times more chances of inhalation to oropharyngeal. I want to ask one thing, madam. Patient routinely asks which option is better, surgery, radiotherapy, or robotic surgery. Which one is better?
This is to be decided on the staging and then availability. As I said, everything is not available. First staging, and then if surgery is available in the form of TOS, this transoral robotic surgery, or it was preceded by transoral laser microscopic surgery, the results are good. Because open does not have that much good results. But now, even as I mentioned, even for locally advanced oropharyngeal cancers, CCRT or combined or conserved or concomitant radiotherapy is basically these days is considered the best option. Though chemotherapy when combined with radiotherapy still has got toxic effects, but they are less than chemotherapy alone or radiotherapy alone. And we must have various studies to compare. And one of the studies or one of the papers showed that between some 20 years, last decade of 20th century, I mean for 20 years in between, the percentage of patients having surgery that decreased as compared to CCRT. So we cannot, it is not customized thing that we give radiotherapy or chemotherapy. Patients should be tailored along depending on the staging, depending on the site, and depending on the availability. Because if you don't have anything, at least you have to do something. The most important thing I want to mention is because in most of the cases, almost 99% of the cases are, I don't know whether the cases which they said that tobacco is not being used, whether they were giving us a good information or not. So lifestyle modification is a must because if it is not done, it is going to worsen the case. It is going to affect your results and recurrences earlier, faster, and if recurrence occurs, the results are still. So lifestyle modification.
You talked about hookah smoking.
Yes.
So there are three, one is bidi, one is cigarette, and third is this hookah is socially accepted, so it is taken more. And now it has become a fashion for investors. I can tell that tobacco in cigarette is a refined tobacco. In bidi, it is partially refined tobacco, and in hookah, it is raw tobacco. So it is more harmful. But they think it is coming to the water, so it's very good. They are accepting.
The day before I was talking to somebody from the same area, they said that it is a social शान जिसको बोलते हैं और social शान मतलब किसी village में if something happens तो उसको हुक्का पानी बंद कर देते हैं. The person is not able to join them for hookah. Hookah is so popular. Sometimes I travel in the mornings and every alternate household has got a hookah outside and some 4 or 5 people sitting. No age bar from a young male of teens, 16, 17, 60, 70. They are all taking hookah. Not only infections, but I think it causes more harm than anything.
Secondly, to my mind, smoking as well as alcohol is not the primary cause of oropharyngeal cancer. But when they are taken together, and which is usually the case, because there are microcarbons in the hookah or whatever smoke, which is not absorbed by the glucose. Once you are taking it alcohol, it is soluble in alcohol, so it is taken It is absorbed locally, so it can lead on to.
One more thing about hookah, they say it is filtered, but it is hardly 5% nicotine which is filtered. 90%, 5% is still going to oral cavity and oropharynx, and then it is for a longer time. Many liters of smoke they inhale in one session, so it causes more cirrhosis.
Otherwise, nicotine is not the cause for carcinoma.
Many other things, but nicotine they say.
They present late. The late presentation is due to because there are big symptoms.
Yes.
The patient of abscess ulcer will present very early because there is a pain. In carcinoma, pain is when pain starts, it's already stage 3. So that's why they present late.
Is it either irritation? At that time, you do not find anything, or it is dermatotalgia, which is sometimes this is due to certain thing, another thing, or GERD. So, a proper follow-up examination. Because for small ages,
And lastly, for base of tongue, there is force plus there is additional force for metastasis because it is a muscular structure.
Yes.
So they are pumped.
Is that the poor prognosis of surgery is, as you widely pointed out, is that because it is metastasis to the retrofrangial group of lymph nodes. One, and secondly, because oropharynx is a midline structure, so the chance of metastasis to the neck is more. So we cannot do a radical night dissection both sides. That is also one point of contention.
not in Haryana, I am working in Haryana, very few centers, and we have to know about it. Delhi it may be, NCR it may, they may be available. Chandigarh. Not working. Is it available in Chandigarh area? What was immunotherapy?
Yeah, immunotherapy is not available. Few of the drugs have been tried actually. Oral drugs, cetuximab and I think for chemotherapy, they are also referring patients to Chennai. One or two of our patients have gone.
So very few centers.
One more thing, I wanted to say that as when I have asked for the transfer robotic surgery. So transfer robotic surgery has a role mostly in post-RT patients, not in the straightforward. Even in the smaller cases, as Sir said that this is such a vascular structure that this is so common, even bilaterally. So it is always advisable that we need to do it with patients in which RT has been done and very small lesion has left. So in those cases, only transfer robotic surgery.
Thank you so much, ma'am. Now let's progress to our next session, recent advances in ENT. I would like to call upon stage Dr. Gulbakh Singh sir, who will be presenting the role of narrow band imaging in ENT. Gulbakh Singh sir is working as professor and head in GMC Amritsar. Sir did his MBBS and MS from GMC Patiala and senior residency from GMC Chandigarh. He has special interest in surgery surgeries and cochlear implant surgery. Sir is an executive member of Punjab Association of Otolaryngologists and member of various professional bodies.
Thank you so much for giving me the opportunity to present. So the topic is recent advances. These postgraduate students, how many postgraduate students are there? We are in third year, first year, second year, all. So please you can come in front rows. No, comfortable there? Okay. So, ENT resident conclave. So, what do you think is the role of ENT resident conclave? So, the material is available everywhere, but we gather there to give lectures. Yeah, so, the motive is to impart the knowledge. And for you, I think all senior professors are there who are examining for last 20 years. So when you discuss and during your exam, it's supposed to be one of your examiner and he will ask you questions and you give the answers according to them. Then I think they like it. This is the importance. So this is the importance of interacting in lecture. Otherwise, everything is available. I think everything is available on net, internet, and book. But once you give that answer, everybody will like that. Yeah, you know that. This is important. So whenever you come and participate in the conference or the workshop, always try to know something what they are saying. That is important. So today's topic is narrow band imaging. So anybody can tell what it is, or anybody have seen that from residents. So it is comparatively quite a new topic. So it is in technology. Basically, narrowband imaging is a technology that is basically developed by the Olympus system. So it is come by various names. NPI, that is patent for the Olympus. Another name which I scan, that is a patent for the Pentax. And third one is a blue laser imaging, that is patent for Usinon. Okay. So these are the same technology, but they are patented by different name by different makers or the manufacturers. That is why they are using different names. Otherwise, it is the same technology which is used. So what it is basically? Basically, it is a filters. Normally, the we uses the white light in endoscopy, and whereas in NPI, or slightly more, we use the two light filters. One is green, another one is a blue one. So removing the red filters. So that helps in detection of the mucosal surface patterns on the various tissues. So I have concentrated topic quite elaborated in the way in which you can adapt the question. So usually this question has been asked in recent advanced year both paper and write a short note, maybe 10 marks or 15 marks on the narrowing. So normally the mucosal surface, as we are dealing with the mucosal surface of the aerodigestive tract. So there are several pathologies, different etiologies and clinical presentations and practices. So considering it being a benign or the malignant lesions, it presents some of the most frequent pathologies by various basically practice in which ENT surgeons come across. So various diagnostic tools are available, out of which the narrowband imaging is one. So it is a one way of the endoscopic imaging technique that uses the absorption characteristic of light to enable the detailed analysis of vascular pattern and the mucosal structure within and outside the lesion. So as compared to the white light, it helps in detecting. So what is the principle? So this is the normal white light in which you have a green, red, and blue lights are which combine to form a white light. And whereas the NPI filter here will blue and green wavelengths. So this observation to say that these filters or the penetration of the light depends on the wavelength of the light, wavelength of the color. So in this technology, we use a two wavelengths. One is green and another is a blue. So the blue filter has a wavelength of 415 nanometers, and it picks up the superficial capillaries which appears brown. So the blue filter helps in detecting the capillary patterns on the superficial mucosa, Whereas this green pattern that has a wavelength of 550 nanometers, that penetrate more because the wavelength is more. So it has in detecting the submucosa. Everybody knows one is mucosa and another is a submucosa. So the submucosa pattern which here is a scan. So that is being picked up by the. So this is a NBI endoscope is available from where you pick up these signals, and that signals then is subject to the narrowband lighting on two wavelengths 415 and 540 or 550, which then is when picked up by the camera system or the video processor or the software system, which then transfer the on the monitor. So the brown color is a superficial mucosal surface, whereas the cyan color is a submucosal capillary pattern which you pick up. Principle of the narrowband or the eye scan. So what is the role? Application. One role is the detection of the early cancellous lesions. So what we detect is the interpapillary capillary roots, which are different patterns. In certified epithelium, we have a single loop originating from the Watson vascular network, which is connected to the submucosal. These structures of the vessel change dynamically through the metabolic exchange. So, as we said, initiate, which may be either elongate or dilate when the tumors invade the submucosa and they are destroyed and replaced by the irregular new tumor. So, this is one of the image of the larynx. White light will pick up this like a white patch on the vocal cords. Whereas if you subject it to the narrowband imaging with the filters, you see a much more lesion. See the pattern of the lesion. So here you can have type of a small lesion, but here in the periphery of it there is a big lesion with various mucosal patterns, which you see in the this is a picture in which carcinoma. There are various classifications to be discussed later on, depending on it, which will tell about whether it is an area or the mucosa or the malignant. There is a picture which is depicting the carcinoma cytoplasm. In the next images, here again you see on the normal white light to be a typical white fish, leukoplakic type of lesion, but if you subject it to the narrowband imaging, you discover it to a very big lesion, which may be going into the other side also and subclotted lesion also. This is the picture in which you show, like a picture in the pure case of the carcinoma. Another importance of the NPI is to classify the lesions in the head and neck lesion. So various lesions in the head and neck like the laryngeal lesions, then the sinonasal lesions, then you can have the oral mucosal lesions, then hypopharyngeal lesions, and upper esophageal lesions and the gastric lesions, which are classified according to the narrowband imaging. So in the laryngeal lesions, you have one of the classification that is NICE classification in 2011, which has given. So we divided into the five categories, the various lesions into the five categories, out of which first one and first three one are the normal causal pattern in which the IPSL, interpapillary capillary are invisible. All in these first three categories, these are invisible, but other further pattern or the characteristics are different, like they are oblique, porcine vessels. In the type 2, it can be a larger diameter vessels, whereas in the type 3, it has a whether oblique or the tree-like vessel. Whereas to categorize the leukoplakia here as a type 4 lesion, whereas type 5 lesion as a pre-malignant or the carcinoma cyto and pure carcinoma. So there are various efficiency in systems. So he modified this leukoplakic lesions into the 2019 depending on the further category, that is the high classification for focal body in 2019. So this contrast to this IPCL what he described, he then further classified the white plague which is seen into various categories. So various now in according to the 2019 classification into the six categories. So Again, so these are the NICE classification 2019 classification which provide these categories into the 6 types of the leukoplakia. No, sir. Welcome all to this NICE resident. So this is the NICE classification 2019, which further classifies the leukoplakia into further patterns from 1 to 6 categories. Again, in which category 1 is obviously the normal. This type 1 is a normal one. Leukoplakia normal one. It is not a malignant condition still normal. In A1, this is the white light picture. This is the picture which is depicting the on the NPI. And in the second category, again, this lesion becomes larger one on the white line. But on the NPI, again, the lesion appears to be a much more larger with intercapillary differences. But again, this is a normal leukoplakia, not changes in the malignancy. So this is the normal one, and the second one is a leukoplakia pure. And the third one is a, here you start seeing a dilated blood vessels, okay, on type T. So this is the starting of some specific changes on the epithelium or the mucosa. So in the fourth one, you have a clear-cut white lesions on this side, and on this you have again a big lesion with dilated blood vessels in the mucosa and the submucosal regions. So this again is a starting phase for the dysplasia of the carcinoma situ. So fourth one is a carcinoma situ, and this is the final picture in which you can have changes of the malignant lesions. Here again, this lesion, white lesions, but underground is some flower-like pictures of the blood vessels which depict the carcinoma. So here you can pick up depending on your these categories, the lesions. So one the classification of the lesion is the laryngeal classification. Another classification which you can have, which can detect the narrowband imaging is a sinonasal lesion. So again, this is the imaging which is white light imaging, and this is the narrowband imaging, and this is the drawing picture. So you have various categories depending on the sinonasal lesion 1 to 5. So 1 is a normal pattern. So dotted pattern like this is a normal pattern. Okay. So this SN1 is seen in the normal case, whereas this SN1 is on the head of the turbinate, this is on the body of the turbinate, and this is on the nasal septum. All this is a normal one. Okay, so this pattern is a normal one, but SN2, 3, 4, 5 is the abnormal. What you see is SN1 is a normal thing, whereas SN2 you can see on the various lesions, irrespective, like this dilated blood vessels which are you can say partially drained, scattered. All these are seen in SN2 is seen in inflammation like allergic rhinitis. Then you have a polyposis, chronic rhinosinusitis without polyposis. So these are the lesions which you see in the SN2 category. SN3 category lesions you can see in the inverted papilloma, squamous papilloma, or you can have a polyposis, chronic rhinosinusitis with polyposis. Okay. So these type of lesions you see on the chronic rhinosinusitis with polyposis, and in also in chronic rhinosinusitis in cystic fibrosis. You can have this type of. So SN4 lesions usually see you have seen on the again is the T-malignant lesion like squamous papilloma. So these type of lesions again use this type of pattern you see on the squamous papilloma. So this is a SN5. This is clear-cut seen in squamous cell carcinoma, squamous cell papilloma. So this type of lesion you see on the squamous papilloma, you have dilated vessels on the surface which are partially erased. This is the sinonasal lesions which can categorize on the nerve end. Third is the oral lesions. Okay, these are oral lesions. This depending, Lane classify this superficial oral mucosal epithelium into three categories: type 1 epithelium, and type 2 epithelium, and type 2C epithelium. So, depending on the first three pictures, A, B, C, this is a normal picture. There is no malignancy. This is the type 1 epithelium you see on the heart. Okay. Heart palate. So if you have seen these type of pattern, heart palate, this is a flower-like pattern, which has been described to be like a flower-like pattern on the heart palate, which is considered to be a keratinized thick epithelium. So it gives this type of picture. So corresponding to this is a normal picture in D1. Okay, see D picture. Here again, this is a picture of heart palate, type 1 epithelium. So here you start seeing a purplish or the brownish discoloration on the surface. Okay, on circular lesion. So this is the pattern which you see on the narrow band imaging. So this is a dysplasia. Okay, so dysplasia. Then correspondingly, the key picture. Okay, A. No, sorry, that picture. So that picture is a again the picture of the heart palate. Here there is a ulcerative lesions. Ulcerative lesions which show the picture of like this dilated blood vessels on the superficial surface, whereas the IPCL pattern of like this on the submucosal. This is seen in the ulcerative malignant lesion. So the first one is a normal, and this D1 is a malignant lesions or the dysplasia, or this is a few full-fledged picture of the carcinoma. Okay. So second one is a type 2A epithelium. So type 2A epithelium is seen on the floor of the mouth. Floor of the mouth. So on the floor of the mouth, you can have this type of pattern. Superficial vessels brown color, and this cyan color is showing dilated blood vessels on the submucosal area, and the pattern is somehow like this on the diagrammatic region. So corresponding to this is the normal one. Corresponding to this is the you have a picture of E. Okay. So here again you have what you see is a circle is a necrosis, central necrosis with dilated blood vessels. And this is again the central necrosis with the cyan color blood vessels. So like this pattern you can see on the dysplasia or the carcinoma city. And the third epithelium type is a non-keratinized thin epithelium or thick epithelium areas. Here you can see a rectangular surface and the circle one. Circle one is showing a normal mucosal surface pattern, and this is mucosal, and this is the submucosal pattern. So somehow like this type of pattern. This is the normally type 2B epithelium. So corresponding to that, this one is BC, and this one. So this is the corresponding pattern in the dysplasia. Okay, dysplasia. Here again you have a circle like this. You replicate this circle. So these are the dotted line where we see a dilated blood vessels, whereas in the rectangular area is submucosal pattern which is cyan colored blood vessel, and pattern is somehow unique like this. Narrow band. So this is the oral lesions how you can pick up on the narrow band. So this is the classification given by the release classification for the oral mucosa. So third feature you can appreciate is the reticulation of the precise vascular pattern. Because the narrow band imaging is taken now establishing the vascular pattern in various benign lesions like in the angiofibromas, vascular malformation in the nasal cavity and paranasal sinuses, which helps in managing or moving the tumor precisely. So it enhances visualization of the blood vessels, which helps in surgical planning the approaches and reducing the risk of bleeding during the procedure. So various type of patterns like dotted. So the benign lesions in the nasal cavity, you can have a dotted LIGO pattern here. This is the tortuous LIGO pattern, and this is the abruptly ending blood vessel. So tortuous and abruptly fractures are seen in the squamous cell carcinoma, whereas the dotted vascular pattern is seen in the adenoma. Fourth important is the guided biopsy and surgical plan. Because as you see on the white light, lesion is somehow to be a circumscribed one, whereas on the NBI lesion is quite much more larger than the other lesions. So here it helps in taking the biopsy in a precise way and then taking if you remove the carcinoma, it is supposed to be a laser or surgical incision with the core instrument. You can precisely demarcate the lesions if you know the anatomy. So again, this is the picture in which is on the white light you see a painted stippled vascularity, where on the narrow band imaging you can see this picture which you see human. Again, another characteristic use of this narrow band imaging is so it helps in the real-time assessment for the vascular changes which is happening post-treatment, like in radiotherapy or in this capability helps in evaluating the effectiveness of the treatment. The picture again showing the multiple keratotic lesions on the left side with the white light, whereas in female post-close-up this remains confined, so it is not progressive. So you can have easily lesions for cases after treatment. Then again it is the educational value and providing clear and more detailed view of the results. And it has been training the residents. So that's recognizing the subtle pathological changes and improving the diagnosis. So advantages: enhanced visibility of the capillary network, identification of the cancer lesion in less than 5 mm in diameter, which cannot be detected by the traditional white light imaging. And second one, it helps in providing better definition of tumor staging, surgical margining, pre and intraoperative settings. In postoperative settings, the NBA values consistent, recurrent, or the metachronous tumor in the pharynx and the labia. So, what is sensitivity? It has a sensitivity of about 89% and specificity of 93% in the diagnosis of the primary laryngeal lesion. So, this is the pattern again, which we have discussed in the Maryland lesion of the pharynx. This is the white light pattern. Okay. Here you see the white light pattern, and on the NBI you see this dotted line, that is the dotted vessels dilated in the mucosa and down in the submucosa because it has deeper penetration, so it has a attacking the dilated vessels in the submucosa. So, what is more advantages? The higher values can be achieved in contrast to assessing the lesion following the radiation chemotherapy treatment. It is non-invasive, high versatility and easy to use and limitation. So, what are the limitations of the NPI? It is a part of the light specific to acquire information on mucosa and submucosa pattern. So, not the muscular imaging. Adequate light and clear field are critical in imaging results. So, light penetration may be altered by the presence of the blood vessels, saliva, thick mucosal laser, mucosa hurting in the take up of the black and red imaging, which interferes with the evaluation of the. So it mainly assesses the mucosal surface structure including light penetration characteristics. Therefore, all the classifications are based upon the mucosal and submucosal pattern of the morphology only, and the superficial depth penetration will be assessment of the deep extent of the. So you can access only the superficial pattern, not the deeper one. NBA. So the pickup is there in every and each procedure. So more and more you do these endoscopies and helps in establishing the various patterns, and that will help in picking up the who have more expertise in this. Future prospect, you can have a now artificial intelligence is available, so you can now incorporate into the software various features of these IPCL factor, which was in diagnosing more on the software where you can match these in the video patterns based on your software. So AI maybe in the future can incorporate into the instrument which have been detecting the this is about the MBA. Any question? Thank you, sir. Thank you. Try to finish in time.
In old times, there was a technique known as supravital staining. There was a technique known as supravital staining.
Yes, sir. Yes.
It has gone into different, but as good as this one.
Yes. Previously, being used for vital staining for the laryngeal carcinoma, the laryngeal lesions. Yes.
Painting it has to be washed also, otherwise this mucus also take up the same color.
Yes.
That has to be washed.
Yes.
Otherwise,
Line washing.
positive.
Yes.
What is the cost of investigation?
So this is MBA basically the light source that is a different and I think the total endoscopy set will cost about 20 lakhs approximately. If you have a endoscope, you can use the same endoscope but have a light source of NBI. That will cost because it is a patent technology that is I think 10 lakhs if you want to purchase only the light source. Other system, camera system and all system you have. So you can just incorporate this blue and green light filter. So because sir, I am working in the government medical college, so we will not charge a single penny.
You are working private. How much will you charge?
Also, sir, depending upon the infrastructure and the cost that you have to calculate and viability of the instruments. Yes, sir. Yes, sir. It is inflammation. Tuberculosis is an inflammation. So, if you case in the laryngeal pattern, you can have a type 1 and type 2 only, not the type 5 and type 6. And in sinonasal also, you can have a type 1 and type 2 only. From type 5 and 6 are characteristically the carcinoma. And then again the inflammation, they will come out to get type 1 and type 2 only. Sir. It is just inflammation and there is a let's say yes.
I think this is one of the very common topics in the meeting.
Yes, sir, yes. Yes. Thank you. Thank you. Thank you.
Thank you so much, sir. Now I would request Dr. S.K. Yadav, sir, and Dr. Upinder Ranga, sir, to kindly facilitate Ishwar sir. I would request Umagar ma'am and Gulbakh Singh sir to speak on the stage. I would now request Dr. S.P. Sadhu sir and Dr. Nitin Gupta sir to kindly felicitate Uma Garg ma'am. I will request Dr. Nitin Gupta sir and Dr. Vinitata ma'am to kindly felicitate Gurvasan sir. Now I will request Dr. J.C. Pasi sir to kindly felicitate Dr. S.K. Yadav sir. Now I will request Dr. J.C. Pasi sir to kindly felicitate Dr. S.K. Yadav sir. Now I will request Dr. Aditya Bhargav sir to kindly felicitate Dr. Jitendra Ratna sir. Now I will request Dr. Krishnan Kumar sir to kindly felicitate Dr. Nitin Gupta sir. I will request Dr. Rajamita ma'am to kindly felicitate Dr. Vinitata ma'am. Thank you so much, sir and ma'am. Now we shall proceed to the inaugural ceremony. I will now invite Dr. Ashima Katyal to please come on the stage.
Thank you, Dr. Harshi. A very good morning to one and all. I, Dr. Ashima Patel, welcome you all on behalf of Department of ENT, Kalpana Chawla Government Medical College, Karnal, to the ENT Resident Conclave 2024, under the aegis of AOI Haryana branch. At the outset, I would like to propose a thanks to all the delegates to make this academic extravaganza a success. Thank you. Without further ado, let us start with the inauguration ceremony. I request Dr. Ashok sir and the organizing team to kindly escort our guests on the dais. First, I would like to request the chief guest of today's event, our worthy director, Professor M.K. Garg sir, to kindly come on the dais, please. Now I request Excellency Observer, Dr. Satish Khattar sir, to kindly join, please. Further, I request Medical Superintendent Dr. Vijay Pal Khanagwal sir to kindly come on the dais, please. I request our guest of honor Dr. S.K. Yadav sir to kindly join, please. Further, I request Dr. J.C. Pasi sir, Dean World Medical College, to kindly join, please. Further, Doctor. I request President AOI Haryana, Dr. Rupinder Ranga sir, to kindly join, please. I now request to call upon Dr. Sanjay Khanna sir, President Kanal ENT Surgeon Society, to come on the dais, please. Now I request Dr. Ashok Kumar sir, the organizing chairperson, and Dr. Vikas Thillon, organizing secretary, to kindly join our guests on the dais, please. I would like to grab the opportunity to call Dr. Ashok Kumar sir, a scholarly personality in himself, to formally welcome you all. Sir,
good morning to all the dignitaries present over the desk. On behalf of our organizing team, Society of ENT Surgeons, Karnal and Department of ENT, both of us, we jointly welcome all the dignitaries present on the desk to our conference. I welcome our worthy director, chief guest of the event, Dr. M. K. Agarwal sir, to our this conference. I welcome Dr. Vijaypal Khanewal, our MS, to the our conference. I welcome all the dignitaries, Dr. Satish Khatta sir, our senior most ENT surgeon, Dr. SPS Yadav sir, Dr. Pasi sir. I welcome President AI Haryana, Dr. Rupinder Ranga, who has initiated everything for this conference. Please welcome sir. I welcome Dr. Sanjay Khanna, Dr. Vikas for the stage. I welcome all the chief guests, chief speakers, guest speakers who has given their presentation in their first session, Dr. Ishwar sir, Dr. Uma madam, and Dr. Gurbash. We have missed, our welcome has been missed by Dr. Sujit Singhal, our uh, fourth guest speaker. I welcome all the guest speakers for the sessions. I welcome all the delegates from all over the different states from Haryana, Punjab, Uttar Pradesh, and all the uh, delegates and faculty attending this conference. I welcome everyone to this inaugural ceremony. This is the auspicious event, most auspicious event of this CME, in which we always pray the God for success of our CME. I welcome all the faculty members from Kalpana Chawla Karnal also to this event, who has spared their time from their busy schedule to attend our conference. Thank you.
thank you, sir. Now it is my honor to call upon and welcome a magnanimous personality, our worthy director, sir, Dr. M. K. Garg, sir, to formally inaugurate the ceremony by lighting the lamp. I request all the dignitaries on the dais, guest speakers, and all HODs of KCGMC to kindly join, sir. I request all the security members, HODs of KCMC to join, please.
I would request Uma Garg ma'am, Aditya Bhargav sir, Ishwar sir to please come on the stage for the lamp lighting ceremony. Dr. Gurbash Singh sir, Dr. Arvinder Singh Khan, Dr. Khosar, Vishnita ma'am, Raman Sharma sir, please come on the stage. I request all the guest speakers to please come on the dais. I would request Dr. Nikhil Arora sir to please come on the stage. I would request Dr. Kishan Kumar sir to please come on the stage.
To keep the ball rolling, proceeding further, amongst us is a revered and learned personality, our worthy director, Dr. M.K. Garg sir. I request him to kindly say a few words of encouragement.
Haryana ENT Resident Conclave. Dr. Dr. Dean, College of Medical Sciences, Dr. Vijay Pal, our Medical Superintendent, Dr. S.K. Yadav, Dr. Ashok, Organizing Chairperson, and Dr. Vikas, Organizing Secretary, to name a few whom I know, Education, Techno Director, and Services, Professor Ishwar, who is ex-director of Ambedkar Institute, Dr. Aditya Bhargav, to be Doctor, former Institute, Professor Umagar, actually ENT Resident College, HODs from other specialties, faculties, and other faculties from the medical colleges, my dear delegates. On behalf of ACGMC family, I formally welcome you all to this ENT Resident Conclave 2024 being organized by the Department of ENT in this institute. And it's a personal pleasure for me to be chief guest, despite the fact that I am a surgeon. But ENT is not very far off, both professionally, let me comment that incidentally, I am married to ENT surgeon. So, this becomes a personal pleasure for me. Entire efforts of Ashok, Vikas, and Arushi has been there. I was told that somewhere around 130 registrations have been there, which is remarkable. In this era, where a lot of conferences are being organized, it is something I didn't expect. I thought that Ashok will not be succeeding in getting more than 50 registrations. But I do not know whether it is the personal attraction that has attracted so many delegates, or it is basically entire efforts of the organizing team, along with the location of Kalpana Chawla to the highway. Kalpana Chawla Medical College was established in 2017, and is a recognized college having graduation course. There, and post graduation is almost important. This year we have applied for post graduation in some other departments, and we are likely to get approval for the PG in other departments. And this being located on the highway, we expect a lot of trauma patients in addition to the emergencies and elective patients in every specialty, maybe surgery, maybe eye, ENT, and so on. And recently, we are trying our level best to have a center for organ retrieval. This is what the government is trying to have the centers in Haryana for organ transplant as well as organ retrieval. There is a proposal now. Organ transplant has been started in Rohtak, though a very scanty number, but the emphasis is on that organ retrieval centers should be there, and we are trying very hard on establishing an eye bank very soon, along with other facilities. Kalpana Chawla Medical College becomes special in another way. Around 15 kilometers from here, that is near the Karnal Road, we are going to have another University of Health Sciences, India University of Health Sciences, very soon. The buildings are ready, and probably after 4th October, maybe this session only, we will be having University of Health Sciences in force, in action. And Kalpana Chawla Medical College will be a medical college under the Indian University of Health Sciences. And not only so, what is more important, that in that university, there is a 750-bedded super specialty hospital having 19 departments which are only super specialty, but the basic. Super specialty means super specialty, medical oncology, surgical oncology, transplant, cardiology, cardiothoracic surgery, plastic, pediatric, everything. And the recruitments probably will start somewhere around in December, and we hope that when we meet next time to Kalpana Chawla Medical College, there will be a lot of improvements as far as professional equipment, professional activity, operative activity, the facilities they are concerned. Community is also contemplating now to have PET scan in medical colleges on PPP pattern, and very soon we are likely to have a PET scan in Government Medical College Karnal as well. Maybe within 6 months or so. All the cath labs and dialysis, they are going to be started very soon. Like Dr. Gurbar said, that is in Government Medical College. Sir, especially I will ask about something in the Government Medical College. Sir, when we were students, Government Medical College meant fewer facilities. Government Medical College meant hospital without even cooler. Sir, in our OT, at Rohtak, there was air conditioner, and we used to sleep during summers in the OT, whenever we were on emergency duty during the business. And the generator was not connected to the passing. Generator was not connected in the water side. And equipment. But now this is not so. Government of Haryana, which I know, is saying that you buy anything, but it should be justified. We are going to have demand for robotic surgery also in government medical colleges in Haryana. Probably we would have never thought of 10 years back. So we have got a lot of budget, lot of finances. So no issue about purchasing anything, buying anything, and therefore the faculties, the consultants, the doctors are today more equipped with the diagnostic as well as therapeutic facilities, and therefore are more intelligent, more conceptually clear than we were at that stage. And of course, endoscopy has improved everything, understanding what we see, we learn, and now technically advanced. It is not like that we should buy the basic camera, basic equipment. ENT particularly, sir, if I see, has progressed quite a lot in the last 20 years, particularly in the last 10 years. I have seen closely when it was a branch of only consultant support, but now it is from bigger to poor. Neck is common, thyroid is a bone of attention to the surgeon at the ENT service. In myself, before surgery, there were occasions when we had to fight it out to have thyroidectomies in the surgery department rather than in ENT department. And I was accused of not saying anything, not objecting to thyroids in ENT because of some personal reasons. And I had no option, sir. To keep myself happy, I had to do that. So now I'm doing a sea change. And not in ENT, every branch is in the legacy. But postgraduates, those of you who do not know many persons sitting here, I know personally that they are scholars and you will have an opportunity to learn so many things from them. Don't leave them till today evening, get something from them. I have seen them working personally many times when I used to attend the ENT conferences possibly. So, for postgraduates, it's a good opportunity, and I was told by Dr. Ashok that not only from Haryana, we have got delegates from Gujarat, Uttar Pradesh, Haryana, Delhi, Pune. And I expect that Dr. Ashok and his team will keep it up, keep their enthusiasm, so that next time when we organize a play or a conference, we will be getting more delegates, more crowd, and they will be benefited a lot from the faculties. And I would request Dr. Ashok that next time, kindly spread your wings to invite those scholars over here so that we are benefited. In life surgery, it is possible, we will do. It's not a problem. From my side, administratively, it is an unconditional help as far as organization of the conference is concerned. So, expecting next time better gathering, I again congratulate Ashok and his team for this wonderful organization. At least, as an administrator, I was not expecting this much gathering. Thank you.
Thank you, sir, for your words of wisdom. So, starting with the felicitation ceremony, first of all, I would like to call Dr. Ashok and Dr. Sanjay Khanna sir to kindly felicitate our chief guest for the today's event, Professor N.K. Garg sir. Sir, please. Thank you, sir. Now I request Professor N.K. Garg sir and Dr. V.K. Agarwal sir to kindly felicitate agency observer Dr. Satish Khatta sir. Sir, please. Thank you, sir. I have always felt that the true textbook for the pupil is his teacher, was the statement by Mahatma Gandhi. It gives us immense pleasure to honor one of our rebel teachers with Vishesh Samman. Dear delegates, let us honor Dr. S.P.S. Yadav sir for his many years of dedicated service, research, commitment, a teacher par excellence in the field of otorhinolaryngology. I request the organizing team to kindly honor Sir with Vishesh Samman. Sir is Senior Professor and ex-HOD PDMS author. Sir did his post-graduation from AIMS Delhi with teaching experience of more than 40 years and has trained numerous students who are spread all over the country. Sir, thank you, sir. I further request Dr. Ashok and Dr. Vikas Dhillon sir to kindly honor Dr. Rupendra Ranga sir, President AOI Haryana Chapter. I request Dr. Vikas Dhillon and Dr. G. Jayawardhan sir to kindly honor Dr. Vijay Pal Khanalwal sir, Medical Superintendent AC. Thank you, sir. Now I request Dr. Raja Kansalman, student, Dean Student Welfare, Dr. Arushi Kashish, Organizing Secretary, to kindly felicitate Dr. Krishan Kumar, DHS Haryana. Now I request Dr. Shyam Kalra sir, Patron PAOI Haryana, and Dr. Ashok Kumar to kindly honor Dr. J.C. Pasu sir. Thank you, sir. Now I request Professor Jayant Keri sir and Dr. Abhinav to kindly honor Dr. Shyam Kalra sir, Patron AOI Haryana.
गणपतये गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय
Now request Dr. NT sir and Dr. Rupendra Ranga sir to kindly felicitate Dr. Ashok Kumar sir, organizing chairperson for this event. Thank you, sir. I further request Dr. Satish Khattar sir and Professor Uma Garg ma'am to kindly felicitate Dr. Sanjay Khanna sir. I further request Dr. Aditya Bhargava sir and Dr. Gurjeet sir to kindly felicitate Dr. Vikas Chillo, Organizing Secretary, for today's event. Last but not the least, I request Professor Vijaypal Thanagwal sir and Dr. Harsha Yadav sir to kindly felicitate Dr. Arushi Vashish, Organizing Secretary, for today's event. Thank you, sir. To conclude the ceremony, I request Dr. Vikas Chillo, Organizing Secretary, to give vote of thanks.
Very good afternoon. On the behalf of organizing team, I would like to thank the Director of ENT Resident, Dr. Kumar Ma'am, the Medical Superintendent Dr. Vijaypal sir, Professor Dr. Ashok Kumar, Head of the Department ENT, President Society of ENT Surgeons Dr. Sanjay Khanna sir, and all the members of Society of ENT Surgeons. Haryana Medical Council Observer Dr. Sandeep sir, IMA Haryana President and team Dr. Putindra Ganga sir, IMA President Dr. Rohit Sadana sir, and our invited guest speakers, moderators, chairpersons, and various faculties for their focused presence. I am highly thankful to all for making this Resident ENT Conclave a grand success, wishing everyone good luck for their future endeavor. A very special thanks to intern, MBBS students, and residents who have made special contribution for organizing this event and conduction everything with ease. In case I have missed any name, I feel sincere apologies from the bottom of my heart, and once again I sincere thanks to each and everyone from the bottom of my heart.
I request all of you to kindly stand for the national anthem, please.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you. Now I request Dr. Arushi for thank you very much.
Let's continue our journey to the next session, which is otology case discussion session. I welcome all. Next session is by Dr. Respected Dr. Sanjay Khanna sir. He will be telling population training on tonsil trainer.
So good afternoon, everyone. At the outset, I am thankful to the Tulna Chavla team, especially Dr. Ashok Kumar and his department for giving me the opportunity to speak on sleep disorder breathing in children. This is a very recent advancement in ENT, but it is unfortunate that most of us are not willing to adopt this subject or learn about it. So, starting from the basic, I will stick to the basic. And if we talk about sleep or disorder breathing in children, it is a mystery. OSA is always a mystery, but we have to solve it. And continuing with this, the key points which I will discuss over here is the pattern of sleep, the normal sleep, again the growth pattern in children, the sleep patterns, the relation between the growth hormone and the sleep, effects of mouth breathing, craniofacial development, and then the sequelae of OSA in children. This is equally good for adults also. These all sequelae. So what is what is sleep? Sleep is basically is not merely the absence of waking up. If we call sleep, it is the contrary of this. In active part of sleep, there is lot of metabolism going on. There is tissue restoration, there is memory consolidation, and so on. So all the systemic effects they occur during sleep. So normal sleep is around 7 to 8 hours. But if we talk about sleep disorder breathing, which is commonly known as SDB, snoring is can be divided into three. The snoring is noisy breathing with there is no ventilation disturbance. URS is upper airway respiratory syndrome, in which there is excessive daytime sleepiness associated with snoring, but there is no oxygen desaturation. And if we define OSA, it is a recurrent episode of partial or complete upper airway obstruction with disturbance in normal respiratory patterns and is associated with oxygen desaturation. So these are the main common types of SDBs in children or adults. If we talk about growth, we are not talking about growth intrauterine, we're talking about the postnatal growth. So it can be infantile growth, infantile phase, childhood phase, or the pubertal phase. So the rate of growth in children, it is basically the age group is 4 to 14 years, and in this age group, the most of the growth of a child is happening. But if we talk about growth failure, so there are so many features associated because of OSA that the growth pattern is disturbed in a child. So yes, if we talk about sleep, it is equivalent to growth. If the child has to grow, he has to sleep 8 to 9 hours. In a life cycle, when we talk about sleep patterns or the duration of sleep, the maximum newborn child sleeps for 16 to 18 hours, and we have seen that. Accordingly, as the age progresses, the sleep pattern is a bit less, and in adults, it is around 7 to 8 hours. So the question arises, does sleep promotes growth? Yes, of course, and we can prove it. Growth hormone secretion during sleep, it occurs usually in the slow wave sleep, or we call REM sleep. So in these children, the plasma levels of growth hormone, their maximum, the peak levels are at, you can say about in the midnight, maybe 2 a.m. to 4 a.m. It is the midnight time when there is the levels of growth hormone is at its peak. So if we take a relationship between the growth hormone and the sleep, so growth hormone releasing hormone and ghrelin and somatostatin, these are at its peak, which causes growth hormone release, and reverses REM sleep. The growth hormone creates the REM sleep, and the slow wave sleep, if it is less, it has the opposite effect on the growth hormone pattern. So sleep disorder breathing is relatively very common in children, but the parents and the doctors and the pediatricians, they may not be diagnosing it. If we talk about the growth failure, only just maybe say 20% of the pediatricians will focus on SDDs. But as a ENT surgeon, we have so many patients of the age group of 2 to 6 years, those who are having obstructive sleep apnea. In these obstructive sleep apnea, there is an effect of mouth breathing, which causes more of sleep disturbance pattern. So the most common in this is the patterns which are related to mouth breathing, and the craniofacial development is hampered. Seeing this patient, so these patterns, sleep patterns, they are the kids are misdiagnosed as having respiratory problems. So just see the abdominal breathing and the disturbance in sleep. Similarly, this is a child who is having a mouth breathing during his sleep. So all these mouth breathers, basically there is ill-formed phase, or we call it craniofacial development is hampered. So in such cases, usually we see a syndrome called sudden death syndrome. And commonly we see that this patient is having, the child is having obstructive sleep apnea. So this child has stopped breathing, and if the cessation of breathing is say more than 10 seconds, we call it apnea. And if it occurs during sleep, it is called sleep apnea. And suddenly he starts breathing. So there is so many sequence of hypopnea and apneas during sleep in such patients, such children. And this mouth breathing causes craniofacial disfigurement. And there are so many studies that were earlier done by so many scientists, researchers, that there is a direct relation of mouth breathing with craniofacial anomalies. What are the craniofacial anomalies which you commonly see in our clinical practice? It is the long face syndrome, it is retrognathia with open bite deformity, prognathia with the narrow and high arch palate. And these are the common features we see in our clinics. If we compare this, these are the two twins. One is a normal breather on the left side, and on the right side, you can see a deformed face, which is called a long face syndrome. Maybe because of progenetia, high arch palate, and ill-formed maxillary area, ill-formed zygomas, ill-formed sinuses. So there is a craniofacial deformity because of mouth breathing. So what are the reasons behind it? These the cause of this pattern of growth, the craniofacial growth. These are the lateral extensile forces of the tongue on the palate which is lost. See, during development of the face in a child, tongue has a major role in creating upper arch palate. So upper arch or the hard palate. So these are the unopposed medial forces of buccinator and mesenteric muscles which causes progenetic and narrow and high arch palate. Similarly, the sequence of events which occur because of oral breathing, there may be extensile eruptions of posterior molars because the vector is downward. This is the vector which is downward and posterior, which is causing the disturbance in growth pattern of face. There is ill-formed mandible, the retrocalathea part, the vector is downward and posterior. If you see this small video, you can see that there is the development of upper arch. How it occurs? It occurs because of the pressure of the tongue, which is the weight of the tongue is around 500 grams in an adult. So pressure of the tongue creates the upper arch, the U-shaped upper arch. If the pressure of the tongue over the arch is lost because of the mouth breathing, it causes various deformity of teeth and the high arch palate. And this is the reason why we are having a high arch palate and deformed upper arch and causing the craniofacial deformity. These are the various common profiles which we see. First, that is the normal, the upper one, that is the normal phenotype, the facial profile. Second, you have a convex face because of the retrogalathia and downward movement of the mandible development of the mandible. And the third is the concave facial profile. So that is because of the progalathia. Now coming to the metabolic sequelae, because of obstructive sleep apnea in children, they have a sequence of events systemically also. So the metabolic sequelae, we have a very busy slide over here. But the thing is, just because of hypoxia during sleep, that is sleep apnea, it increases adiponectin secretion and it has a various effect on various metabolic sequence. There is increased insulin resistance. There is endothelial dysfunction, which can cause hypertension in children or adults, or diabetes in children. These are the common systemic metabolic problems which occur in obstructive sleep apnea. So there is decreased growth hormone, there is decreased insulin-like growth hormone, there is dyslipidemia, there is insulin resistance, all these causes metabolic. Because of endothelial dysfunction, there is cardiovascular sequelae, there is autonomic dysfunction, there is dysregulation of blood pressure, myocardial changes, and ventricular hypertrophy. So these are the patterns which occur in chronic patient having OSA. In children, these neuropsychological sequelae are very common. Attention deficit, usually called as ADHD syndrome. But in 50% of cases, if we work up in these children, they have obstructive sleep apnea. So we have to treat OSA as early as possible. There is hyperactivity, there is aggression, there is mood disorders, and maybe low scholastic performance. So all these things we have to see in a patient if we take the history. So what does this mean? This means we have to find out the cause. What is the cause of sleep apnea? See, the growth of the face, according to Mendel, it is completed at a very early age. That is 60% of the craniofacial development occurs in the first 4 years of life. And by the age of 12 years, it is 90% of the face is developed. And mandible usually develops around the age of 17 to 18 years. So, what we have inference, the result of discussing all these previous slides is we have to have early intervention in any case of having OSA. And this should happen at a very early age so that there is no craniofacial deformity in future. So the most common, if we talk about the most common, again, previously we are seeing that there is recurrent tonsillitis, recurrent adenoiditis, but because of the enlarged adenoid and the tonsillitis, there is OSA. And DNS and allergies are very common in children also. But there are various other risk factors that cause OSA in a child. It can be prematurity. Nowadays, we are having obese children. So, obesity is one of the causes. There may be some craniofacial anomalies, maybe syndromic child, maybe some neuromuscular disorders in the child, maybe sickle cell anemia or mucopolism. These are the various other risk factors that are associated with OSA. So, these are the syndromic children, basically, which have OSA in early childhood. Pierre-Robin syndrome, we know that there is retroglyphia. Down syndrome, we know that it is having a big bulky tongue which causes obstruction of the upper airway. Apert syndrome, there is again a craniofacial deformity is there just because of the deformity of cranial sutures. What we do usually in these children, we can do ESG or polysomnography, commonly known as sleep studies, for the diagnosis, and it is different from adults. Usually, AHI is apnea, hypopnea index. It is 1 to 5 when we call it mild OSA, it is 5 to 10 we call moderate, and more than 10 is severe OSA. So, how to manage these children? We all do adenotonsillar surgeries, but in case of sleep disorder breathing, we have to act early, we have to give results early so that we have to intervene early. And 80 to 85% we can cure these children with just adenotonsillar surgery. Other surgeries, we have a list of that. There is turbinate reduction, palatopharyngoplasty in children. There can be volumetric reduction of tongue, like in Down syndrome. We can have maxillomandibular advancement. It is again a very selfish surgery, we call it. And many times, if nothing goes right, tracheostomy. So this is again because I'm touching this topic, this population technology. So this is a very basic adenoid and tonsillar surgery with coagulation, and it is a bloodless surgery. So you can see the second part of the video. Adenoid hypertrophy, and the surgery is being done by coagulation technology. So earlier, the conventional method of surgery that was done by adenoid curate or maybe by nowadays by endoscopic and debrider technology we use it. But those are powered instruments and the injury is more. But in population, the injury is less, the heat is less, and complete bloodless surgery can be done. So just doing adenoid surgery, we can treat 80% of the sleep disorder breathing injury. So many researches have been done that the first indication nowadays for doing adenotonsillar surgery is obstructive sleep apnea. Nowadays, and the second indication for doing such surgery is recurrent or chronic tonsillitis. So the time has changed now. So what was the mystery previously in first slide? We have solved the mystery and we have going ahead with this diagnosis of OSA, and you can see that the results are promising. But in adults also, this is a video which shows us how much we are disturbing our own children by just snoring. So my request to all the youngsters and experienced ENT surgeons that one should adopt this OSA subject because it is a very wide subject and we have to learn about it and include ourselves in this subject so that we can have a subspecialty. We are already having this subspecialty in ENT. So I will request everyone to adopt this. So the take-home message is normal sleep is important for the survival, growth, and facial development of children. Primary care physicians, like general physicians or pediatricians, dentists, ENTs, all should be aware of STDs and disorders in the children. And the diagnosis and management is very simple. Around 80% we can treat just by diagnosing adenotonsillar hypertrophy. So thank you. And next, I will take a small, since I have to take the hands-on training session for youngsters. It's a small talk on applications of coagulation. So what is this coagulation technology? This is basically a single instrument, single consumable having everything in his pocket. The first part is the band. The second is the saline. When the band, the electrodes come in touch with the saline, it forms a plasma. This plasma basically is responsible for our dissection of tissue. And this causes tissue breakdown, and the byproducts are the tissue is vaporized and it is sucked into the suction which is there. The suction port is there to the coagulation bond. So if we compare it with the monopolar and the laser also, the temperature in monopolar and in laser as compared to coagulation is very high. So coagulation technology is having just 60 to 70 degree of temperature when it is working on an tissue. I will not go into see this is adenoid hypertrophy. I will call it grade 5 hypertrophy. Because it is going into the nasopharynx, through the nasopharynx into the posterior corona and the nasal cavity. So totally obstructing the nasopharyngeal area. So this causes OSA in a child having such disease pathology. Not going into the detail, these are the sleep apnea procedures we do in adults. The zeta palatoplasty, the various types of palatoplasties we do. These are the palatal advancement we do in this patient, the typical form of palatal phenotype. This is again another sleep apnea procedure. Not going into the detail, we do epiglottomy with this coagulation technology only, and we do the midline glossectomy, the tongue-based reduction, all with this technology. So there are various applications of technology, not particularly for tonsil or adenoid. So we can do the peritoplasty or uveropalatal flap. These all procedures are sleep apnea procedure. So not going into detail. This is very simple. We are doing a conventional part initially for a differential laryngeal, and after that we have done used coagulation laryngeal and microlaryngeal, and see the result. It is around 15 days post-operative. This is again a laryngeal polyp. These are very simple cases which we do with coagulation microlaryngeal band and see the result. Again, 10-12 days post-operative. We can use in supraglottic lesions also. This is a supraglottic lesion. We have done, I have done debulking with the same coagulation bond, which is used for this laryngeal bond or EPEX 70 bond. You can use any one of them. So this is the supraglottic growth, and debulking was done. And this is the result you can see. course, when the diagnosis was made, it was squamous cell carcinoma, and we had to do the radiotherapy part. So, for the resident, those who are joining me for this session, this is a tonsil adenoid trainer. It is having a group for adenoid. We will have vegetables or fruits, simulation or like adenoid structure, and we will use population in that part, and we do endoscopic population adenoidectomy. So this is the area where the adenoid tissue is there. This is the nasopharyngeal part, and this is the again the another two clips are there. You can see the third picture. There are two clips. So there we place a fruit, maybe some pea or something, some apple, two tonsils, resembling two tonsils. So this is the tonsil trainer which is placed in the lecture theatre, and those residents, those who have registered for this. So this will be a hands-on training for the residents, and we will use this technology for removing that vegetable or the fruit tissue. It will mimic like we are doing adenoid or tonsillar surgery. Another information that we have built it for the Canal Society of ENT Surgeons for this NESCON. This is the mid conference. NESCON is Neurological Equilibrium Society of India, and this will be organized in March 2025, probably, and will be organized by Society of ENT Surgeons of India. So, thank you. Any questions? Boring to नहीं लगा? It was very basic topic, so but not just basic. It was important basically. Sir. Definitely, sir. But
this lecture, though it's quite good and informative, it should be more told to the pediatricians rather than to the. Yes, people are all aware of this bacteria and so either it should be told to the dental people or to the pediatrician. The pediatrician should see more of this upper respiratory and they need to be convinced.
See, sir, the pediatric clinics, they are having, the pediatricians usually see ENT patients around 30 to 40%. So they are well aware, but they are not used to these things. We are trying to aware for last 15 years. I am trying to aware pediatricians, but it is not very much fruitful.
I recall, Sanjay, your wife is also.
Yes, my wife.
Have you convinced her?
Yeah, sir, she is very much aware. She is very much aware, so I am getting patient from her also. So, fortunately, it is increasing, the awareness is increasing day by day about pediatrician also. We are giving lectures to pediatrician also. But the question is, sir, as ENT surgeon, please don't take it otherwise. As ENT surgeon, most of us miss in the early childhood the diagnosis. This adenoid hypertrophy we usually miss, and we usually say the surgery should be done around 14 to 15 years of age. Now it has been changed. Most of our seniors who are practicing in interiors or maybe some other places, so they are usually referring, RMPs, they are usually referring patient at the age of 14 to 15 years. I have done such surgery in 10 months old child. Because as Ishwar said, failure to thrive is the main reason for doing the surgery. And earlier it was not labeled as OSA. Now we are labeling at OSA for last 25 30 years.
Sir, Dr. Sanjay,
what is the average time you take in one tonsil population?
Hardly 5 minutes, sir.
5 minutes.
5 minutes, 5 minutes, 10 minutes, 20 minutes in the adenotonsillar surgery.
But then convention method takes much less time than the
Sir.
population. Do you agree with that?
Sir.
Is
I'm
it-
not,
is
I'm
it-
not, I'm not against conventional methodology. I was earlier doing with monopolar diagnosis. For last 10 years, I'm not doing with monopolar, I'm doing with population. See, if in my hands it takes hardly, I'm saying 5 minutes. It takes hardly 1 to 2 minutes. So, but it is a bloodless
Will it
surgery.
be more feasible to remove the tonsil mass, set it down, conventional method, and hemostasis can be achieved with your coagulation mass?
So it's your choice. Whatever suits you, it's your choice.
For adenoid removal, this is the best tool. We all agree. For tonsil, I mean, there may be a difference.
Sir, you do your conventional method. There is no harm in it. Earlier we were doing it. So, but the main thing is application of population technology is not fixed to tonsil surgery only. There's various applications. So tonsil is a common surgery which can be done. Of course, it becomes not cost effective as we do because the population wound is costlier. So it's your choice what you are doing, what is good in your hands, what is your experience. You can do so.
There's no doubt about that. Population surgery is good for adenoids at least, and UP3. Tonsil, yes, because the learning curve, like you are saying, 1 to 2 minutes or 5 minutes,
Yes.
maximum. The learning curve is quite steep. The learning curve है time लगता है learn करने में because of for the new person who.
Yes, sir.
As Dr. Pasi suggested, most of the places, like I was working in a defense hospital, Bangalore, where we got this population in 2016 itself. We got 16 or 17. Then all of us learned it. There is no doubt about that adenoid surgery is beautiful. Adenoid, because what we do is we remove that part of adenoid, not necessarily the whole adenoid.
Yes,
Which is obstructing the stagnant tube and the coila, and just leave the rest part. The healing is so good. Those 60 part, yes, it used to take time, but probably the learning curve, as I was reiterating.
That's why we are having tonsil trainer over here for residents.
And for laryngeal surgery is another surgery, UP3 it is good. Thank you. Anna, one question. What is the incidence of secondary bleeding in post operation? Because this cautery has been broken off.
Sir, it is same. Only difference is about the slough that is over the tonsillar fossa. So slough is slightly more with coagulation rather than the conventional. Bleeding is, sir, the incidence same. Yes, sir. It is the incidence is same. Sir, I mean, my experience is same. I had just 2 cases of secondary bleeding, secondary hemorrhage, last 10 years. And that too treated conservatively. Just admitted for 2 days and gave antibiotics and nothing.
Because I think the blood formation is more because
Yeah.
the cautery with formation. So chances of that the process is there. Otherwise, it is not there much information. And one, two, 3 points I just wanted to say that nowadays lots of adenoidectomy is being done. I don't know why. Maybe it is because that we have various tools like operations and parents are also in hurry. Oh, this is the problem, it's blood vessel surgery, whatever it is. You know,
it is not like that.
I don't know why.
No, it is not like that. I'm sorry to interrupt.
They just collect it.
Okay.
And maybe that we, 2 years patients, 3 years, 4 years, why not we treat them conservatively? And with the sprays, like, follow it and so on, and tell them how to do it, and monitor them like that. And not having the spiritualitis media, I think that is prevention. So we can be aggressive and little bit with the conservative measure, rather than going straight away for exposure. And patients in which there is lot of problems, and you can say yes, OSA, and 3 to 6 months patients. You know, even I have seen that we are not giving the antibiotic treatment, just not even single course, not even sprays, waiting for some time. Let the child grows with the things and make the patient parents aware that how they should take care of the child. That good conservative. I have seen that not even know that how to put the sprays. The sprays are going in the mouth. So all these things we have to make them aware so that gain the time and 2 7 years, 6 7 years, even the resolution of the paranoid tonsils they start growing, patient is growing, airway is becoming bigger in size. So there is no need I think.
Ma'am, there is a point, ma'am, please.
So just if spiritualitis media 3 to 6 months patient, reluctant, ignorant patient, parents, and other changes have come if the partner. So I think we should be more extensively doing the conservative measure rather than going straight away for the surgeries. And after practically 6 years, 7, 8 years of age, just start progressing. There's no problem. Yeah, I think we must stress on these things rather than going for so many techniques.
What about 5 to 6 years that she said aggressive treatment? Only thing is that according to me, what I feel is only one indication for intervention is if the patient is having radioactive media and his or her conductive hearing loss is not, and the patient is learning to be on adhesive side of it. That is the indication. No, see, once we get the thing organized, we can treat it security of status media, but due to poor patient compliance, they are not coming for follow-up. You find that the person's conductive hearing loss is growing more than 30 decibels. That is time you treat.
One point to be noted, sir.
Sir,
Due respect, just one
with
point.
due respect to all, please अगला session के लिए wait कर रहे हैं. We have to cut short. No more cross questions. This is final. Please. I am very sorry. PGs are waiting. They are very bad. They have organized everything. Sir, please. Sorry. So we announce for this case discussion to start. Dr. Raman sir is the mentor for this case discussion, and you might know. Abhishek, start.
On the respected chairpersons on the stage, respected Dr. S.P. Yadav sir, Dr. J.C. Pasi sir, Dr. Aditya Bhatta sir, Dr. Raman Sharma sir, and Dr. Anshika Ajit ma'am, please come on the stage. I now request the presenters for this session, Dr. Damini and Dr. Sheila, to come on the stage.
start the
May I request all the friends to come forward and sit on second and third benches. Please make it fast. I am a headmaster of a medical college these days. I am used to. Don't waste time. Come forward. This session is only and only for you. Yes, Ramini and Sheila.
Everyone, start. Female resident of Delhi, clock faculty, by profession. The chief complaints were left ear discharge for the past 15 years, right ear discharge for the past 10 years, and bilateral ear decreased hearing for the past 10 years. The history of presenting illness was as follows. The patient had left ear discharge for the past 15 years, which was insidious in onset, continuous, purulent, scanty in amount, foul smelling, not blood stained, and was not associated with any aggravating or relieving factors. Then around 10 years ago, she developed right ear discharge, which was insidious in onset, continuous, purulent, scanty in amount, foul smelling, not blood stained, and was not associated with any aggravating or relieving factors. Around the same time, she developed bilateral ear decreased hearing, which was insidious in onset, gradually progressive. She was unable to hear whispers. She was able to hear normal conversation, but not able to comprehend it well. Was able to hear telephone ring doorbell. She prefers left ear for telephonic conversation, and the hearing loss is not good. There was no history of trauma or fever or ear pain, no history of any swelling around the ear or neck, no history of facial asymmetry, drooling of saliva, inability to close eyes or blow air, no history of ringing sensation in ear or dizziness, no history of pain behind the eye or double vision, no history of headache, molding, blurring of vision, neck pain, weakness of limbs, no history of any nasal discharge or obstruction, but there was history of recurrent URIs, and there was no history of any other hereditary complaints. On past history, there was no history suggestive of hypertension, diabetes, mellitus, seizures, asthma, or tuberculosis, and no history of any previous hospitalization or surgery in the past. On personal history, she is vegetarian with regular bowel and bladder habit, with regular sleep pattern. There is no significant family history. Social economic history, she belongs to a lower middle class according to the modified people studies.
Can you go back to that slide of no history of no history of no history of? You are a teacher, they are your students. Why have you asked all these questions? What do you want to know? One by one.
Might have had a ear pain is also without complications and some intermittent complications. Swelling around the neck and ear. This is for the abscess ringing sensation and dizziness was also ruled out in any involvement of the inner ear. Double vision and pain behind the eye was also ruled out Reddington syndrome. Headache, vomiting, blurring of vision, neck pain was ruled out meningitis, and weakness of limbs without any neurological deficiency. History of nasal discharge and obstruction rules out any fever pathology as a cause, but there was positive URS.
Go back to the slide of
Foul smelling. Why there is a foul smelling in a particular type of case? We will know that. Why is that foul smelling? What are the other bacteria? What about the blood stain?
Might be granulation.
What are the type of connective tissue granulation? Why they bleed so much?
Let's say discharge. With a slap on the pinna will give you a blood stain discharge. What trauma? Say an injury following skull-based fractures. Go closer to your mic. Not audible.
In temporal bone fractures, if the same is not perforated, then pneumotemporal will develop.
If the tympanic membrane is not injured, this will there be a blood outside?
Not in the external body.
What is that condition known as? So, pneumotemporal is not the condition of bleeding from the ear. That doesn't come out. It will come out only when you have an injury in the external body. From
Able to hear telephone also refers to the hearing of telephone. This is the implication.
The patient said that it means that the higher decibel sounds, patient is able to hear.
Or high
Frequency sounds, the patient
frequency is the correct word.
frequencies are higher frequency sounds, the patient is able to hear. She is able to hear normal conversation, but she is not able to comprehend and to understand the conversation well.
So according to you, what type of you reduce? What type of hearing loss is there?
She might have a component of sensory hearing loss, which is not able to comprehend.
In this case, able to hear, refer, able to hear telephone ringing doorbell. What does it mean? Patient is having this type of hearing. You yourself said these are high frequency sounds. Yes? Sensory.
this question of asking non-fluctuant hearing loss has some relevance in this case. You need to ask this.
Hearing loss, if it sometimes with the presence of discharge, the hearing loss changes, the patient perceives it as hearing loss.
That you can say that the ear is discharging, patient hears better. But when you say fluctuant, what does it mean? You are trying to rule out what?
There can be conductive forms or sensitive
Fluctuation in the hearing.
inner ear pathology. Like inner disease.
Yes. You are not dealing with monitoring. So it's not a must that you should ask each and every question in each and every case. You have to also know what is not to be asked. Leading on to in that case we should have the presenting symptom of the inner ear. That is giddiness, dizziness. If it is associated with that, then it becomes relevant. There is no history of giddiness in this case.
Postgraduate, this is one. Raise your hands. When we told that you residents come in the front, why aren't you coming in the front? What is stopping you? Because you are the people who should be participating more. Please come. Natasha, please come in the front. आगे आइए. Going to stop this session here only. Why are you scared in coming in the front? What? कौन रहेंगे और residents? वो सवाल उन तक पहुंचेगा कि वो कहीं नहीं आ रही आपकी. Please hurry up. Yeah. Carry on.
The patient will present with a painless ear discharge. It will be straw color, there might be multiple constellations. Pale signified coloration side effects. Disproportionate areas.
Then this garden effects are
Serous. Consistency. Serous. Good afternoon, respected faculty. On general examination, patient is conscious.
Is there any positive finding? Is there any positive finding?
No, sir. No, sir. On local examination, right side pinna was normal in shape size position. Pre-auricular region, no scar, sinus tag and post-auricular region, no scar, sinus fistula. There was no trigger tenderness. Mystoid tenderness was absent on right side. On EAC examination, no abnormality was detected as such. On examining the left side, it was also normal in same size position. Post-auricular region, there was no scar, sinus tag and swelling. And trigger tenderness was also absent on the left side. Mystoid tenderness was absent on left side. On EAC examination, there was cholesteatoma flex with a prolonged discharge filling the AAC with fishy smell.
Can you show us the picture?
Yes. This is the otological finding which we noticed on otoscopic examination, showing the parts tensa, tympanosclerotic patch over the parts tensa region from 3 o'clock to 9 o'clock position, with the prominent of anterior malleolar fold and medialization of handle of malleus, with the shadow of chorda tympani. On parts flacida region, there was grade 4 attic erosion.
with partial erosion of the head of mantis with grade 3 part sensor infection. Depending upon the orthoscopic finding, if the maybe case of chronic otitis media, inactive squamosal type with without inflammation. Cholestoma was there, but it's treatment.
How do you define cholesterol?
So, cholestoma is defined as a three-dimensional. It is defined as a three-dimensional stratified squamous sac that confirm the anatomy of middle ear plaque that has the propensity to progress independently and on the expense of underlying.
This specified squamous epithelium comes from which place?
It may come, yeah, very.
Comes from which place? Reflection ओके तो बात की बात है ना नॉर्मल एनाटॉमी अगर क्लियर की देखोगे तो कहाँ से आता है That's not it written. Are you sure? It is 99% wrong.
What are the three layers of tympanic membrane? Kindly provide them with one mic or less mic.
First here it doesn't matter if answer.
भैया वो दे दो कॉर्डलेस माइक.
Very good.
कितना के बंदे रखे हैं उधर माइक उधर देना इधर लेफ्ट को जाना.
It is not complete.
तीन बैठे हैं तीनों
हमने आपसे diagnosis पूछा है. How will you tell, or I'm your examiner, how will you tell me that? What are the components of diagnosis you might like to mention there? Actually, you complete the examination, उसके बाद.
Can you tell me what are the points in favor of your inactive spondylosis? What are the three important things you see when you label the patient as inactive spondylosis? What is retraction pocket? Three terminologies is mentioned in the news. When you label it, so there is epilepsis and this epidermization. Can you just elaborate with all these? Part of the secondary epilepsis. And we can see a lot of panels to lot of panels. So I focus.
Is the grading for erosion or एपिक डिफ्रेक्शन प्लीज ये छोटी छोटी चीजें हैं which can be grade 4 fatigue erosion. There is nothing like that. It is like fatigue deflection. And I'm sure you must be knowing what is the name of fatigue detection grades and what is. Oh, any of them. So we don't have much time in office. Please. She cannot write grade 4. She can write fatigue erosion. Fatigue erosion, not grade 4.
You can write fatigue erosion. After whose name these classification made in past tense and past tense. Speak loud. Speak. Come closer to the mic.
Pars placida toss classification and pars tensor satin.
All right.
Now, otoscopic examination to the left ear. It also shows the grade 3 pars tensor retraction with thickened and dull heel, with the shadow of the chorda tympani. And on pars placida, there is anti-erosion with the shadow of the neck and a part of head of mantis. The cholesteatoma present initially, which was clear later. Posterior malleolar fold was not appreciated well. The granuation issues with malleolar.
You understand by fundus? Just in an fatigue detection or fatigue erosion, what do you mean by fundus? What is the significance of this? And fundus not visible, especially your written.
If the fundus is not visualized, it medial end of the retraction. Fundus is the medial end of the retraction body.
The deepest or bottom of the deepest.
If it is visible, then it is shallow posterior retraction body. And if it is not visible, it is deep.
If I ask you to explain the previous scoping picture before clearing the cholesterol, how will you explain this? The one you are showing is after section clearance. Before also you are showing a picture. Normally you will get a question like that.
Picture like that is likely to be.
But all is visible on examination. You have to speak that only. How about cholesterol plates and the extent? Come closer.
The part posterior to the mass of the colchicoma plate could not be visualized completely.
What will you say about past sensor in this picture?
A collection of colchicoma plates in the region of the past tense. In this city, it is not.
Active body. Okay. All right. So, who did the section clearance out of you two? What was the discharge like, or it was only glioblastoma flares? There was no discharge?
There was
Virulent? Color of the discharge, smell of the discharge, blood stain or not? Anything here? Okay. I think they can go further.
on clinical testing, previous test using 256 first, it was negative on right side. Using 512 first, it was negative, and 1024 was also it was negative. On left side, previous test was negative on 256, 512 was, but it was positive on 1024 was. Weber test, it was localized to the left side, and absolute both condition test, it was shortened on the right side, and it was not shortened on the left side.
Most of the tests, they are significant names. So I don't have for you monitor signals. It is very sensitive, very important. Why there is no name to this?
With the college compared with the examiner.
Okay, it's very already. Another test I will see. You are using 512. Why you use 500? Any test? What is yes? Why you use it?
So it is better one.
Why not?
Regulatory component is less, and the quantity is also less in 512. It is lower frequency because have more vibrotactile stimulation. As in the speech frequency, there are two overtones and
You listen to the test, not vibrating. The vibration will be 126. What are the findings? Points to 512. First, that's why you use it. What's for the reason? Then we find it.
Are they visible? Are they audible? Are they audible clearly to all of you?
We strike at the junction of upper 1/3 and lower 2/3. We strike either at the elbow of the heel pad of the shoe to produce pure tones. We are not to strike it on hard surfaces, it will produce overtones. Yes.
हाइपोथैलेमस है या फैट अवेलेबल होता है वो नहीं है तो दिस इज द एंड वेयर डू यू कीप इट हाउ मच इज द डिस्टेंस फ्रॉम दैट एंड व्हाट एक्सिस
2 centimeter from the external vertebrae canal, the prongs should be parallel, axis should be parallel to the axis of the sternal vertebrae.
बोले एक्सटर्नल फॉर्म there is a name for that acoustic axis. It passes from one external canal and comes out to the other 230 meters away from that.
One hand, two hands, doing resistance. One hand from one.
We are not masking the barrier when we use one hand.
Like this. Stabilize the other hand. So simple as interviews.
What is your interest by doing these tests? No. Venous test 256 negative, 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 left way negative, negative, positive. What do you infer for? It's a very basic question, but it is being asked. इसका क्या मतलब है? Whenever is getting left towards जल्दी हमारे पास टाइम ज़्यादा नहीं है.
Sir, it will signifies the severe degree of the hearing loss. The upper is lateralized to the left, which means that the left has a conductive hearing loss component. And right side, there must be some sensory. All the
Your test is correct. We have each centimeter.
right, we have severe sensory neural hearing loss, and on the left, we have moderate conductive.
Identification of hearing with the help of tuning fork. Just tell us the theory part of it. इसमें नहीं ऐसे बताइए.
256 hertz is negative. In the need 256 hertz is negative, then a loss of 20 to 30 decibels is expected. 512 is also negative, then 30 to 47 to 45 decibels was expected. And 1024 is negative, then 46 to 60 decibels.
Okay. Go ahead.
Both side facial nerve motor function is intact. There was no spontaneous nystagmus. Fistula test was negative on both right and left side. Cerebral sign was absent. Corneal reflex was present on right and left side.
Visual examination, clinically, what functions have you not tested? You got the question?
This covers the motor
In other words,
and
clinical
sense.
examination in routine, other functions that we test, but there are other functions of the patient that we don't test.
There is a sensory root also, so it has sensation of the posterior superior part of the.
Talking about the sensory part now. Okay. Sensory part is not tested.
Sensation over the posterior superior part of external.
Okay. You can test, but generally it is not tested. You are focused only on the motor functions. What motor functions are not tested? One, yes. Two Two more muscles.
Post-articular.
Two more muscles. Anybody from the audience? Yes. Even seniors can answer. One more muscle. One more muscle. One more muscle. Like this. But can you test like this now? How do we test? Can you demonstrate? Yes, it is right. Okay. So these are the functions that we generally don't test. And the parasympathetic functions? What are the parasympathetic functions? Parasympathetic functions. What psychomotor functions are there with facial nerve? Recognition and speak loud. Which salivary gland is right? Rotate. Facial nerve is lying rotating. What about nasal secretions? How are these produced? Is there any role of facial nerve or its branch? Dr. Yadav is sitting here. He taught us how to reach that nerve and dissect that nerve. So no more done now.
Combines with the deep from the Britain, Britain canal, which
Pterygoid canal. Or the other name is nerve of pterygoid canal is also known as only 10 minutes are left. You have to go fast now. Any significant finding? You can skip. Okay, go ahead.
Now, as per the history examination, the liver diagnosis is a case of bilateral chronic media, left side active muscle, right side inactive muscle, with left side moderate conductive hearing loss, and right side hearing loss without any complication.
I think this without complication word should be used only when we have some complication. Otherwise, you can do everything with this.
How will you define complication?
ये फुल कर दी स्क्रीन
इसको
स्क्रीन को
स्क्रीन फुल ही है
अरे मैं अपने लिए कर रहा हूँ
फुल कर लो हाँ कोई इशू नहीं है
ठीक है
Definition of complication is when the disease has spread beyond the pneumatic parts. You must have had primary acquired, secondary acquired. Any other type is not known. You have done it, follow the training for this, follow HOL.
What is nasal polyp syndrome? Never heard. Both of you are appearing in exam, but you won't answer nasal polyp syndrome. The other name is the inactive scabiota. Now you can tell us. Now close the
This is the collection of lesions available inside the nasal cavity.
All of the earlier and happy involved. What is epidermization?
Epidermization is epithelialization of the middle mucosa.
All of the middle
Part of the
what about happy? Have you read it or just which book you read?
when mentioned that there is a retraction of the
What did you read? You read it.
some part which breaks off from there is portions from the
Here. What is encephalocystoma? Why you need shampoo? Your opinion that is the best book? You only want to read the year. No, sir. Please. Yeah. So what part was I? Was you clear part in more policy? No. Was your superior part of the past usually right?
in the posterior superior part, blood supply is better than the rest of the part. There are repeated infections. There is dissolution in the fibrous layer, it becomes weak. It is more prone to retraction pockets.
Right.
Because of inappropriate arrangement. There is the blood supply.
Blood supply is more from it will lead from to what?
More inflammation. The fibrous layer becomes very good. No hyperemia and
And this will be also see more common. And so
secretory drainage media. Okay. Now this is the diagnosis. If we take it as it is, what are you going to do with this case? We are not asking counseling. You just tell us the surgical part. Both are surgical sides, right and left. You would like to perform surgery in both the ear, left and right. Right, you will not operate. Both sides are surgical cases or not? It's a question of faith. You have the diagnosis in front of you. You have the patient. What are you going to do with the patient? You agree that both sides are surgical cases. Which side will you like to operate first? Speak loud. Speak loud.
Some basic findings, we first have to investigate the patient. Some basic findings left side.
Left side. Which is how do you decide this? Patient will say, I don't hear better on the right side. Right side is worse. You will say you want to operate the left side first. You tell us why do you want to take this.
We will investigate the patient first.
On investigation also, pure tone ultimately you find it is a mixed hearing loss right side more than the left.
You will be taking it to you.
You must hear first.
What is the name of the therapy you use?
Master exploration.
And exploration of what?
You plan as master, but in this case, we will perform under radical master.
Modified resident. What are other master techniques?
And they can be canal up or canal down.
Besides, what is the other name of modified?
Classify the master canal up and canal down. Canal up, we have vertical master technique. Combined into trigonometry procedure. And in canal down, we have radicotomy. Radical master technique, modified technique.
Other name of modified. Only the
Superior part of the question, but we can narrow down and
how it will work from modified resident.
enter the middle ear and modified radical. And the lowering of
Why is very very first? That's smallest. We will not name the patient. You will decide how the other name is appropriate. Right? The argument must say what is adjuvant mastectomy? Very simple. In every book you go there, any book. This is mastectomy or how do I get it? Mastectomy? What is the slider? With the reason. I was resident, and my professor was not with anyone. He will only say that is what on the same because or at least was seen. Not neither. What on the side must be done.
Patient not operated the patient and pre-operation. Already defined.
What is the advantage? Is there any advantage or disadvantage of this?
As it has already exteriorized the attic, it might become self-cleansing and there might not be infection.
It is good for the patient. There is no chance of the next level.
Okay, so you will like to operate the left ear because you were given the justification.
The attic from the
This is the active side and present. Okay. One is any other thing? What will you tell to the patient? How will you convince the patient?
will tell, first of all, tell the patient that the disease is present in both ears. Tell that left ear has active disease and no chance of
Active means what? What will you tell?
chance of progression. Disease as compared to the right ear. And since the hearing loss in right ear is already severe, like hearing loss, you already not able to right ear. There is a chance that we might operate the left ear. We might save the residual hearing impact.
Suppose this patient is a professional swimmer. What kind of mesolectomy would you like to do?
Very good.
2 minutes, okay. 2 minutes left. Patient is a professional swimmer. Okay, canal up. I'm giving you that. And if the patient wants to join the armed forces, then also canal up. I think one more question can be asked by all the experts sitting here.
Absolute indications are only hearing ear, pediatric cases, only any cases with complications and revision surgery. The little indication we can perform a surgery in the office.
And there is always an indication of HRCT. All such cases, if patient can.
There are two many possible solutions and many effective. It is minus disease. In which it is more. trauma may be seen in activity of physical period normal. Right?
President 30 residents from MRI till now. 30 residents. Is it clear? Cortical career? Cortical career? Cortical? How many of you have done cortical? My last question is, suppose you are an ENT surgeon in the hospital. On a call, like each of my word is important, please listen to it. आपको कैजुअलिटी से कॉल आती है आप जाके मैंने देखते हैं ये डिस्चार्ज ऑफ कोर्स विल बी अंडर योर ट्रीटमेंट दे हैव कॉल्ड इट उसको हाई ग्रेड फीवर है आपने देखा तो पूछा इंटरमीडिएट टाइप हाई ग्रेड फीवर है एग्जामिन किया एनीमिया है तो अपने निशाने में दर्द है व्हाट इज योर डायग्नोसिस what why anemia is there in the life problem. थ्रोम्बस बनता है तो क्या कंज्यूम हो जाता है What is the difference between thrombus and embolus? Thank you. Paucity of time, Krishwar. Ashika, your last question. No more question after this.
Predicts that how good results will the patient have post-operatively, what will be the post-op results in predicts the long time. It has various components, Delusion classification of Delusion classification, hospital classification, graduation issue.
I think we can wind up with this. Thank you very much, the organizers, for giving us the opportunity. And we feel that both the Garima, not Garima, Tamini and Sheila, they have done really well. And there was a poor response from the other postgraduates in the hall. And also, they did not listen to the repeated requests of coming forward. But your behavior has been found just like any undergraduate students of a private medical. I think, yes. Thank you.
Now I would request Dr. Ishwar Singh sir and Dr. Uma Garg ma'am to kindly felicitate the experts for this current session. would now request Dr. S.K. Yadav sir, Dr. J.C. Pasi sir, and Dr. Aditya Bhagav sir to kindly felicitate Dr. Damini and Dr. Sheila. I would request Dr. Rama Sharma sir and Dr. Anshika Harith ma'am to kindly felicitate Dr. Sheila. Let's continue our journey to the next session, which is invited talks on oncology. I would request Dr. Ashok sir, Dr. Arvinder Singh Man sir, Dr. Gulshan sir, and Dr. Preeti Singh to kindly come on the stage to chair the session. I would request the speakers, Dr. Giri Datta ma'am, Dr. Vikas sir, Dr. Danish Arora, Dr. Abha Singh ma'am to kindly come on the stage. I request Dr. Nikhil Arora sir and Dr. Kanika Rana ma'am to come on the stage to chair this session. Request Dr. Vineeta ma'am, who will be presenting on mastectomy tips and tricks. Ma'am is working as professor and head of the Department of ENT in Maulana, Ambala. She has presented various talks and conferences and published many papers in national and international journals.
So good afternoon. I think it was to be a good morning session, but I'm here now in between your lunch and the session. Good afternoon, everyone. Please tolerate me for another 20 minutes. We'll discuss mastectomy just at the undergraduate, postgraduate level, the tips and tricks how to go about a mastectomy surgery. So it is basically a surgery to open the mastoid cavity. Our primary aim is to remove the disease cells and improve meningeal ventilation. If possible, reconstruction is the call of the day, and if we are able to, we should give equal importance to reconstruction of meninge. So it has evolved over the years from simple trephination by Schwartz in 1873 to the current endoscopic mastectomy, or maybe a canal wall down with reconstruction of the posterior canal wall with obliteration of the cavities, with a good caring of the patient. So first of all, to do a good mastectomy, we should have a good microscope. So high quality optics with variable magnification, objectives with appropriate focal length, adjustable eyepiece, camera mounted for photo, video documentation, for teaching. जब हम PG कर रहे थे, we did not have these facilities of a monitor. So we used to peep in from the side of our professors to see. But nowadays, you postgraduates have a better exposure. You can see what the surgeon is doing on the monitor. Fine balance to allow for full range movement with minimal efforts. And the operating surgeon should check settings prior to washing. Here we are using the Zeiss S7 microscope in Malana. The next important instrument are the drills, the micromotor drill and the burrs. So we should have a modern high-speed drill that allows rapid board removal with minimum force. Cutting and diamond, round, conical of various sizes should be available. And no matter how much you keep, at the end of the day when you are operating, आपको कोई ये नहीं चलता, ये नहीं चलता. So, but then you have to keep your store full. The older the burrs, the more pressure is required and the sense of feel is reduced. So they should be replaced in this. Drilling to be done using the side of the burr. Now this is very important that the side of the burr should be used to cut directly under vision. The tip of the burr will cause unnecessary action, will not cut, and that keyhole effect is not going to cause a pressure damage. The size of the burr is again important. What area are we drilling? We have to change the size of the burr according to that. When we begin drilling at the Maximus triangle, we should start with the largest size cutting burr. We should also keep a note of the sound of the burr. As we come to the close important structures, maybe when we are left with a thin plate over the dura or the sinus, that tinning sound of the burr is important and it gives us a suspicion that we are approaching the dura or the sinus. Similarly, when we are drilling over the facial bridge, the pinkish tube has to be kept in mind with adequate irrigation. Short burrs give precise control. So it is important how you hold the drill, how short the burr, how precise and confident you will be. But when you are dealing with the deeper structures of the mastoid cavity, then the length of the drill needs to be irrigate in the area of facial, to avoid thermal injury, to avoid clogging. The use of diamond burrs, especially in important vital areas, and also if we have to stop bleeding, we will use a diamond burr without irrigation. If we are short of diamond burrs, we can use a cutting burr in reverse direction, which will again act as a diamond. Another important point is that when we are drilling in vital areas, we can keep, because अगर हम cotton रखते हैं, sometimes it comes into the drill and you have to temporarily stop the surgery. So keeping a suction tip in between the vital area and the drilling site will avoid injury to the vital area. Suppose you are drilling, you are loading the canal and you have exposed or there is a recent horizontal part of the facial nerve. You will keep your suction there to avoid injury to the facial nerve by accidental slippage of the preoperative concerns. Now this is very important that you have to prepare the patient by giving him antibiotics and steroid drops so as to reduce the inflammation, the edema, so that the intraoperative bleeding is less, intraoperative time is less. HRCT temporal bone that was covered in the last session, and it's true that every patient who can afford should be ordered an HRCT temporal bone to make things easier for the operating surgeon. You can beforehand decide whether you are to go for a canal wall up or a canal wall down procedure. Consent is very important. Now, consent both for facial nerve, it may be a bad day for you or for the patient. You have to take a facial nerve consent, and secondly, you have to take a consent for the worsening of therapy also. Patient may be a polycythoma therapy. So your chair should be good. The sitting chair for a mastoid surgery, the longest surgery, I think Dr. Shok has given me only 10 minutes for the surgery that takes the longest. So the chair that on which you sit should be comfortable. Your sitting position should be okay to prevent your back and neck. And all your senses should be high alert. Now, William Weil's incision for the post-auricular approach. How the incision is to be altered in case of an infant where the mastoid process is not developed, the stylomastoid foramen lies superficially. It has to be more posterior and vertical. So exposure, first you have to expose the middle ear. Before you start drilling the mastoid antrum, the middle ear has to be exposed. You have to keep in view the floor of the middle ear before exposing the antrum. So raising the tympanomeatoplasty, raising the tympanomeatal flap, and what I generally do is that I release the tympanomeatal flap superiorly, far anterosuperiorly, and reflect it inferiorly, so that the attic and the posterior superior part of the middle ear is quite open and is not occluded by the sometimes bulky flap. So after you expose the middle ear, you need to start drilling in the mastoid antrum. So we know that the landmark for the drilling in the mastoid antrum is the Machiavelli's triangle we talk of so oftenly. The superior boundary is the temporal line, the anterior is the line from the posterior superior margin, and the third is the tangent rod to it. And the mastoid antrum lies roughly 1.5 centimeters deep. Here we can see the boundaries. And another important landmark is the spine of Henle. So we know that the antrum lies postero-superior to the spine of Henle. So spine of Henle कई बार बहुत बड़ा भी होता है. It is too huge. So it is better to drill the spine of Henle and pair it with a posterior canal wall so that your vision to the middle ear is not hampered. But you should not drill it completely that it does not act as a landmark for your drilling. First of all, when we start the drilling to expose or to reach up to the mastoid antrum, which is the largest and the most constant cell of the mastoid air cell system, we have to expose the three main landmarks. Superiorly the dura, posteriorly the sinus, and the thinning of the posterior canal wall anterior. So first aim is to delineate the dura or identification of the dura. So we drill with a large cutting burr along the direction of the dura, and with irrigation, as soon as we see some pinkish hue, we should change to a diamond burr. Similarly, we will drill along the sinus, and any suspicion of a blue hue, we will change to a diamond burr, and then we will expose the sinodural angle. Simultaneously, we will keep thinning the posterior canal wall so that our vision is well maintained. So, the three boundaries which are most important for a cortical mastoidectomy, that is the tegment plate above, the sinus plate behind, and the posterior canal wall in anterior. Right? So, once we have completed and accentuated all the mastoid air cell systems, we call it a completed cortical mastoidectomy with the boundaries of tegment, sigmoid, inferiorly the digastric ridge, anteriorly the thinned out posterior bony external canal, and anterosuperiorly we will be able to see the glimpse of the incus, and medially the bony labyrinth. In case you suspect a dehiscence in the tegment plate and you feel that there is a hanging dura with granulations adherent to it, you are not sure whether they are granulations, whether it is dura, you can ask your anesthetist to give a valsalva. And once the valsalva is given, you can see the throbbing of the dura and confirm your diagnosis. Another important point that I want to share with you as a beginner, we always like to use a ballpoint. So once you open the mastoid antrum, you will definitely ask for a ball probe, and you will try to rotate the ball probe in all directions from the cell that you have opened to see the limit to which you can uncap the cell. So this ball probe is a very safe instrument which will keep you confident that you are not going in the wrong direction. Next, when you have exaggerated the mastoid hair cells, you have opened the mastoid antrum and you see the smooth ivory look dome of the lateral semicircular canal. It comes as a welcome sign. So identification of the dome of the lateral semicircular canal is so important and so good that yes, that you reached your medial limit. Now difficulties arise when there is a contracted antrum or when there is a corner septum, right? So we all know that the corner septum is the anatomical fusion of the squamous and features part of the reported bone. And we come across it when we have accentuated the superficial mastoid hair cells, we have the false peeling of reaching the antrum. Therefore, it is essential to expose the middle ear at the same time as we are drilling the antrum, so that we can compare the depth of the two and we know that still it is way to go, right? So, important. So when we come across a corner center, it is better to drill along the dura. And medially के बजाय we should shift our drilling to posterior, posterosuperiorly, या posteroinferiorly, posterosuperiorly along the dura or posteroinferiorly along the sinus. Enter the mastoid and then go anteriorly so that we do not hit the second GU or the semicircular. Here we start our drilling quite posterior if we are suspecting a corners septum. So this is the importance of exposing the middle ear and the antrum so that we can compare the depth. Similarly, जब भी complication होती है, it's never when you have all things in your favor. Whenever there is a contracted antrum, the tegment is low lying, the sinus is antipose, posterior canal वाला आप कितना thin करोगे? आप thinning इतनी करोगे, there is always a chance to hit the second GU or the lateral semicircular. So in such cases, जब बहुत ज़्यादा contracted है antrum, it is always better to go for an inside out approach. So we can approach the antrum from inside rather than to continue drilling and repeatedly and cause complications. So the next important structure after the antrum is the facial nerve. So knowing the surgical landmarks of the facial nerve is very important. And the more we know about the facial nerve, the more confident we will be while doing mastoid surgery. The various landmarks we will discuss one by one. Just briefly, we know that we have two segments that we come across mainly during our mastoid surgery: the horizontal or the tympanic segment, and the vertical or the mastoid segment. So, in the tympanic segment, our major landmarks are the lateral semicircular canal, which lies superiorly, and facial nerve, which is just inframedial to the lateral semicircular canal. The stapes is below, and then we have the fossa impetus, and we will discuss. So here in this diagram, you can see the tympanic segment of facial nerve. This is the tympanic segment of facial nerve, right? And this is the bulge of the lateral semicircular canal. So we can very well see the relation of the facial nerve. It is just inframedial to the bulge of the lateral semicircular canal. This is the stapes suprastructure. This is the oval window. So they act as a landmark for each other. अगर हमें facial का bulge दिख गया, so we know that the oval window will be just inferior to it. If you are able to see the oval window, just above will be the tympanic segment, the facial. The next is the cauda tympani. Cauda tympani also acts as a landmark for the facial nerve. They run almost in a similar direction. This is coming from anterior to posterior. This is going from posterior to anterior. But they are running almost parallel. The difference is that the cauda is quite lateral to the facial. That means as long cauda is under vision, the facial is very deep. And deeper to the cauda is the annulus, and deeper to the annulus is the facial. How far lateral we are to the facial nerve during our routine tympanoplasty surgery. Here again, if we see the anterior part of our attic, again we can appreciate this is the anterior attic and this is our area of geniculate ganglion. This is the cocciformis process. Cocciformis process is important because this is the most resilient landmark of facial nerve. Even in the most extensive of diseases, this is not eroded. So, genicular ganglion just lies anterosuperior to the cocciformis process. And this is COG, which is a bone-like, shaft-like plate from the tegment, which points towards the cocciformis process. Here again, we can see the relation to the lateral semicircular canal, the relation of facial nerve, and how it is related. So this just signifies that जब तक हम we are lateral to the lateral semicircular canal, we will not injure the patient. Relation to the digastric ridge. Now, when we are operating in the region of the mastoid tip, we have the digastric ridge, which divides the tip cells into the medial tip cells and the lateral tip cells. So, lateral tip cells we can exteriorize with the help of a cutting burr safely. When exteriorizing the medial tip cells, it has to be done under vision because the facial nerve, the vertical part of the facial nerve, will lie anteriorly and medially to the medial tip. Next, when we come across important structures, the facial is when we are dealing with the facial recess area. So while dealing with the facial recess area, it has to be a high intensity illumination, high magnification. We have to use long, gentle strokes. First, naturally, we will do the cortical mastectomy. We will keep the incus under vision. The short process of incus will act as a guide. We will leave the incudal buttress in between. So, the incus acts as a guide. We will leave the incudal bridge or the incus buttress in between by giving long parallel strokes. Long parallel strokes along the posterior canal wall. We will estimate or we will get the idea by the pinkish hue of the facial nerve which will lie medially, and then we will enter the posterior mesotympanum with the cauda later. So this is again important that we leave the bridge, and sometimes here we might encounter a Herald cell. The Herald cell, which is an infidel Herald cell, which gives us an idea of the facial nerve which lies medial to. Here, we very well know that if this is the endoscopic picture, that if this is the annulus, the facial recess lies deeper to it, and the facial nerve still deeper to it. But the sinus tympani is deeper to facial nerve. So when we are removing disease from the facial recess, the facial nerve is deep. But when we are removing disease from the sinus tympani, we are deeper to the. This is again a picture of the posterior tympanotomy where we can see the incus, and this is the fossa inclusus, and this is the cauda laterally, the facial nerve medially, and we are seeing the stapes superstructure by zooming the posterior tympanotomy. So now dealing with the key areas, we discussed entry into the antrum. When we have to drill the perifacial cells, we have to again use long gentle strokes parallel to facial. We have to beware anomalies of the vertical course, and any soft tissue in the direction of the facial should raise suspicion. So this is very important. Whenever we come across some soft tissue, we think that it is facial. But then you revise your landmarks, you see the level of the horizontal canal, whether we are lateral to it or have we got deeper to it. So it is important to trace the soft tissue and to confirm that yes, this is just granulation and not facial. So here is the direction of the bird parallel to the facial. Retrofacial cells, if the mastoid is sclerosed, we will just go where the disease takes us. So now, normally, when we are dealing with chronic otitis media, the mastoids are sclerosed, and we may not feel the need to open up all the cells. So, in a pneumatic mastoid, sometimes the retrofacial cells need to be opened up, and here the important structure, more important than the vertical part of facial nerve, is the posterior semicircular canal, which is in close relation to the vertical part of the facial nerve. So here again, there is this guarded approach. So here in this diagram, if you see, this is the facial ridge and the lateral semicircular canal, but the vertical part, this is a retrofacial cell that has been opened. The posterior semicircular canal is in quite close relation to the vertical part of the tip cells we discussed. Now dealing with the attic. Now once we are dealing in the attic area, we need to shift the position of the patient and of the surgeon also. It's better to take the microscope towards the foot end. We move our chair towards the foot end of the patient and focus on the attic and lower the head of the patient by roughly 30 degrees so we have a good visualization of the attic region. So we start drilling, we can start drilling in the attic area with a cutting burr, but then when we get the reflection that only an eggshell bone is left behind, we shift to a diamond burr to open the attic. Now it is very important that we should know the status of the ossicular chain beforehand. If the three ossicles are in continuation and while opening or drilling in the attic, we hit the incus, you will cause permanent citizen damage to the patient. So it is important that we first inspect the middle ear, and if the chain is continuous, we must disarticulate the joint between the incus and stapes and then drill near to the impetus medialar joint or the attic. Right? So this is important that we drill in the attic without hitting the ossicular chain. Now this is showing the exposure of the attic, and you can see that the medius head and the incus body are lodged in the attic. So the facial nerve lies deep to the medius and incus. So when we are doing any surgery, we try our best not to remove the incus till last. क्योंकि जब तक incus वहाँ पे है, तो उसके medial facial nerve safe. So here we have a picture showing. This is a very God has made it that way that the important structures, facial is there, stapes is there, and the disease is there. So you have to remove the disease, preserving the vital structures. Therefore, you have to be very calm when you are dealing in this area. So here we can appreciate the attic cholesteatoma with a tympanic segment of facial nerve, which is missing. So normally we get a good plane with cholesteatoma. With a cholesteatoma, using a cotton pledget, using an elevator, you can gently lift the cholesteatoma off a dehiscent facial also. You will get a plane. The problem is when there are granulations. And granulations may be adherent to the facial nerve. You may not be able to find a plane between the two. There may be without stretching the facial nerve. So it is better to trim the granulations close to the facial nerve rather than stretch and cause post-op facial nerve. Next important area is stapes area. So after dealing with the facial in the horizontal part, the stapes area is again important. So sharp dissection is needed here in stapes area. Sickle knife is used to peel off the epithelium over the stapes arch. Again, along the superior tendon. You cannot go across it. Already it is a disease area. The stapes structure should maybe disease. It may not have that much strength. You may dislodge the stapes by removing the disease. So we need not be very aggressive, but it has to be sharp dissection, and with the micro suction, you sometimes have to stabilize the stapes and then remove the graft. Here they are showing the use of sharp dissection. Posterior tympanum. Now canaloplasty and making the view appropriate and good view of the middle ear by doing canaloplasty is again important. The drilling of the posterior canal wall from middle ear side, thinning of the posterior canal wall. So tilting the patient towards your side. If you tilt the patient towards your side, you can see the medial edge of the posterior canal wall. So you can drill with a cutting burr laterally, but as you go towards the medial edge, you should use a diamond burr or a curette to expose safely up to the pyramid. We can expose safely up to the pyramid because we know that the facial nerve lies posterior to the pyramid. So up to the pyramid, you can safely expose the posterior part of the mesotympanic. This is the drilling of the posterior canal wall. Next important thing is that what is the anterior buttress, what is the posterior buttress, what is the facial bridge, and what is the facial ridge. Now this diagram adequately shows that the green facial ridge is the medialmost part that directly overlies the facial vertical part of the facial nerve. So the part of the posterior canal wall that is medialmost and directly overlies the vertical part of the facial nerve is the facial ridge. This is present. This is surgically present in all cases. Now facial bridge is the bony wall that connects the posterior canal wall to the anterior canal wall. This is made by the surgeon by drilling. So this facial bridge covers the tympanic segment of the facial nerve and the attic ossicles. This is made by the surgeon by drilling and it connects the posterior canal wall to the anterior canal wall. So here the anterior buttress is the connection of the facial bridge with the anterior canal wall and posterior buttress is the connection of facial bridge with the posterior canal wall. So to define the anterior buttress is point where the posterior canal wall meets the tegment plate and the posterior buttress is the point where the posterior wall meets the floor of PSC lateral to the facial nerve. So facial bridge is the portion of the posterior canal wall that bridges over the notch of reminiscence, overlies the ossicles. Facial ridge is the posterior canal wall that houses the vertical segment of the facial. So this is again showing the facial ridge and the created facial bridge. So we can see the ridge overlies the vertical part and the bridge overlies the tympanic part of the facial nerve. So once we have created the bridge and we are going for a canal wall down mastectomy, we need to narrow the bridge and eventually the last part of the bridge is moved with the help of a house curette. So we are breaking the bridge. The bridge is always broken and the bridge is always lowered. So breaking the bridge and removing the anterior and posterior buttress with the help of a house curette, the direction being away from the facial canal. Now after the attic is cleared, the bridge is broken, the buttresses are paired to the responding canal walls, we remove the disease and we can remove the incus also. Once we remove the incus, we can see the tympanic segment of the facial nerve clear. So this tympanic segment of the facial nerve will act as a landmark for the vertical segment of the facial nerve up to what level we can lower the facial bridge. So the facial bridge to be lowered only after the facial bridge is broken and we can see the level of the horizontal part of the facial nerve. So the lateral part can be removed with a cutting burr, but the medial part we have to use a diamond burr with copious irrigation to prevent thermal injury to the facial nerve. Direction has to be parallel and with copious irrigation. So our ridge will be high only if we are afraid of facial. We will not be afraid of facial if we can see the dome of lateral semicircular canal. Say lateral that we are safe. If we can see the tympanic segment of the facial nerve, we can trace it and we are safe. So we should flush the facial ridge with the lateral semicircular canal to prevent post-cavity problems. So this is a lower facial ridge. So we discussed how to deal with the corner septum, contracted antrum. We should always suspect any tubular structure anywhere. People have reported even on the promontory that facial nerve is lying there. So any tubular structure that is running along the course of facial nerve, you should be suspicious and not excited to just tear it off. Nascent facial nerve, we all know that it is extremely common in the tympanic segment, especially above the oval window, and it is better to be parallel to the direction of facial nerve. This is a diagram showing the nascent facial nerve in the tympanic segment. Revision surgeries are challenging because of the scarring. The removal becomes of the granulations and the scar tissue becomes difficult at times. So what are the common mistakes that we make during mastoid surgery that leads in for complications?
PGs who has opted for PG-based competition can go for prelims and lecture paper to inexistent PG. Please go for the prelims of PG.
Last few slides are left. Never deal with a deep corridor, narrow deep corridor. Exposure has to be wide. Control hole wala kaam nahi hota. You always have to make a full boundary of that Mackie's triangle that you have to drill. So temptation to reach the deeper structures without desired degree of fatal exposure will result in complications. And whenever there is bleeding, use epinephrine soap, cotton pledgets and wait for a while. Let the bleeding stop and then you proceed. Change to diamond burr whenever in doubt. Disorientation to surgical landmarks. If you are lost somewhere, you regain your surgical landmarks and you sit and then again reassess the case. Right? So it is important to identify the landmark. It is a surgery of landmarks. If you know your landmarks, there will be no complication. Saucerization of the cavity is again important for adequate drainage to make it a single cavity. Important to prevent the post-cavity weeping cavities. And adequate natoplasty is also important because you need to follow up the patients to clean and examine the ears on later. So the keynote message is temporal bone dissections. Repeated temporal bone dissections, especially for the postgraduates and also for surgeons. It is not that we don't make mistakes. We also need to go back to our books and to temporal bones to improve ourselves. Thank you so much.
Always having a key observation. Observation is very important. Whenever your leg is doing something, observation is very important.
टेम्पोरल बोन जिन्होंने कॉपरेशन के हैंड्स ऑन के रजिस्ट्रेशन कराया है उनका सेशन वर्किंग में बिल्कुल जाके अपनी ट्रेनिंग करते हैं और अपना पेपर जिसके बीपीजी का पेपर अभी मॉर्निंग में बच गया था पेपर प्रेजेंटेशन और प्रीलिम्स चल रहे हैं जिसके हम गोइंग टू नेक्स्ट सेशन ऑफ case discussion in neurology, please get ready for it. We are going to start very shortly.
I would now like to call Dr. Vikas Gupta, who will be presenting on facial nerve decompression. Sir is working as Associate Professor in the Department of ENT in AIIMS Patna. Sir did his MBBS from SPMC Bikaner and is a gold medalist. Sir did his MS ENT from RPGMC Tanda. Did senior residency from PCMS Rohtak. Sir has published various papers in national and international journals.
Good afternoon, everyone. Myself, Dr. Vikas. I would like to thank Dr. Vikas for regards to residents. Another more important information. I'll be discussing about the patient. Describe patient decompression. As we all know, longest most of the patient has the longest most of the body. But in cases of injury or inflammation, there's less space for expansion. So at least it is not that. So this is the as we all know, course as already told by Dr. The segment, the master segment, and everything. So the branches of the patient, as we are all very much with the papers. Usually, I always deal with the lower of the neuron type of things, which is so basically the causes of most common causes of health palsy, the post traumatic so nobody has seen a patient of fictional paralysis, whether to go for decompression or not. It is rather a dilemma. Sometimes in trauma cases, usually it is difficult to elicit whether there is an immediate medicine or there or not. It has to be the patient is not sometimes. So once it is defined whether the case is a surgical case, you have to go for pre-operative workup, the timing of surgery, which segment of the nerve is involved, surgical approach, post-trauma transfer, or in the consent. Important I would like to highlight this point that we usually tell our residents to take a video presentation of the initial observation of the facial manifestation, emergency or availability. It is important in case of follow-up or improvement or pursuing and observer bias in sometimes it is rated it is a grade 4 facial manifestation. It is 4 to grade 2. We have a you should always be only not but if the patient also is not then the patient when you know patient of decompression, there are really all kinds of compression or involvement, nerve connections, studies showing a decreased amplitude and 6 to 8 weeks of paralysis without which is not resolved in a maximum of the reservation. No threshold for decompression should be there to prevent pre-operative workup includes the onset of paralysis, whether it was sudden or delayed, lower motor neuron, upper motor neuron, how to protect the gradient system. Very important to following up. So the first one is the patient from the operative trauma to the resident is the patient. He has to document whether the house spectrum grade 1 or house spectrum grade 2 improvement or person or it is stable. Radiology, it is very important. Audiometry of the patient, nerve connection studies, and the topographic test. To know the site of injury of the patient or compression of the patient. In radiology, we mainly see the fracture injuries, the post-traumatic patient. Indirect segment is involved, or the vertical segment is involved, the supine is involved, or each of the continuity of the patient. In these cases, CT is rather confirmatory because the whole patient is a fully part. So CT is almost complete. Segment of the patient are involved in the disease process. Any of the abnormality of the face and which may help us decide. So there are sometimes questions asked whether to go for a CT in every patient or not. In some aspect. So this was a case we recently saw. there was a patient of polycythoma. We got his CT done, planned for mastectomy. We can see this large, it's looking like a cavity lesion, but rather was not a cavity lesion, and the income was normal. This polycythoma with the large anticoagulation is completely free of muscle. So the question whether to have CT or not is the answer. For beginners especially, get a CT scan during every patient which you are planning for to save yourself from the intraoperative surprises. Radiology is must. Nerve conduction studies are most of the documentation. In limited cases, it is required for decision making. It is useful in usually cases of demyelinating disorders of the patient or consent. Always have a video documented consent of the patient, as it is rather impossible to assess whether the full recovery of nerve will be achieved or not. It will invest time with the significant that this patient already. So, something like us have already discussed in the previous lecture. This process, the short process, data sensor, and the old video. If you usually see, this is video showing this is the facial nerve, this is the old window, this is the copy formation process, the old window and copy formation process on the anterior inferior part of the facial nerve and the data sensor analysis. So, facial nerve is lying in between these two. So, approaches to facial nerve decompression. This is important. Consideration whether to know which part is involved, patient's hearing is intact or not. Then we can reach that area without moving the normal landmarks. So, that's two interesting cases which we see in our so the case of facial paralysis of 4 to 5 days, 4 to 5 patients for 2 months. We had a history of trauma 2 months back, presented later for OPD. On CT, there was no fracture lines as it may have been. It was just a softish density region over the so we planned the patient consent to the patient to be compressed. After taking a great official outcome, as it was not expected to move after such a long time. So in our double approach for cutting this patient, the soft tissue, as we see, the granulation tissue was present around the same of patient and the patient was decomposed. So the granulation tissue was removed and decompressed was surprised 6 weeks after the complete closure of eyeball was achieved. In a similar case, there was a post-traumatic case because the fracture line was passing to the first chemo of the patient. The patient couldn't give a history or tendency to give a history of immediate or delayed patient paralysis, but there was grade 5 and seeing the patient fracture line crossing the invalid segment of first chemo, we decided to decompress the patient. So we, our down approach was and fibrotic tissue was found compressive over the first gene. And the intact, it was not that patient will be intact in any plus extra. हमने decompress किया, but we tried to find the segment with the able to do that, and the patient ended up similarly, a patient is also old man, 72-year-old male, presented with ear discharge off and on with 5 to 6 patients for 2 months. On examination, there was inflammation in the AC, the lining membrane was more or less normal. CT was done, so it was seen that the vertical segment of the facial nerve, there was inflammation around the vertical segment of the facial nerve near the next part. All of the inflammation and the lining membrane was normal. So we planned to diagnose and decompress the nerve if possible. So this was done. Vertical segment of the facial nerve was exposed. This was whole of the vertical segment. We removed the granulation tissue around the facial nerve. This granulation tissue was removed. The facial nerve was found to be intact. Decompression was done 1 centimeter proximal to the disease. To our surprise again, the eye closure was present after 1 month of post-op. Such a great engulfment of the nerve by the chronic granulation tissue over 2 months of time. The PCR in this case was negative. The report came out to be only chronic granulation tissue over the vertical segment of the patient. So these surprise surprises are very much seen. We should not shy away from doing what patient will be covered. In some cases, case intact canal wall is also required. This was an interesting case of a female with starting here with a grade 4 patient. Came out to be Superman's hospital, we started on we was negative, but so we planned decompression and exploration method, exploration of the patient. To our surprise, we found a page granulation tissue covering the second chemo of the patient. So we removed the tissue. It was completely looking intraoperatively like it because we we removed the granulation tissue, granulation tissue, and decompressed the patient as much as possible. We already understood. I don't know whether decompression was required or not in this case, but after 2 months of ATT and we said came out to be positive, and post 82 months, patient has to be closed for that. This kind of cases are also similar. This is another case of intact canal wall, patient decompression, similarly a fracture line is seen here. We operated this case, there was a fibrotic issue, we removed this fibrotic issue. We compressed the nerve from the first chemo up to the mastoid vein. These are two interesting cases. In these two cases, serviceable hearing was there. Hearing was intact, and the patient had facial paralysis. Patient had a post-traumatic facial paralysis. So it was difficult to decide whether to go for decompression or not. The patient was 6 weeks to 8 weeks old. So we consent from the patient. We went for decompression of the nerve to posterior internal without doing any ocular chain discontinuity. The ocular chain was kept intact. All of the patient was hearing fresh. Most of the hearing was normal. All of the patient are rectifying members of intact. Similar to the case of transplant. So take home as endoscopic approaches are also there for patient decompression. Points to remember, not all post-traumatic facial paralysis need intervention. Those who are fit for criteria for decompression should be done at the earliest, depending upon the hearing status, to decide the approach to the facial paralysis. So, fit for approach is a very good approach for improving the or maintaining the hearing of the patient. Thank you so much.
Thank you, sir, for sharing your insights. Now I would like to call Dr. Ava Singha, who will be presenting on universal hearing screening. Ma'am is currently working as State Nodal Officer with National Program for Prevention and Control of Deafness for Haryana. She has done an MS in JNS and senior residency from Government Medical College, Chandigarh.
Good afternoon, everyone. Respected chairpersons and seniors and my dear friends. First of all, I would like to thank Dr. Ashok and the organizing team for giving me an opportunity here to speak about this, the very main topic, that is universal neonatal hearing screening. Today, the topic given to me is universal neonatal hearing screening. Just for the introduction, that the hearing impairment is one of the most critical sensory impairment in infants. The prevalence of hearing impairment, that is severe or profound permanent bilateral hearing loss, it is a serious condition affecting 1 to 1.5 newborns per 1,000 term healthy neonates. And in high-risk infants, the prevalence is around 10-fold increase, that is around 1 to 1.5 per 100 infants. And bilateral mild to moderate hearing loss, the prevalence is around 1 to 2 per 1,000 newborns. So seeing this so much prevalence in infants, there is failure to detect children with hearing loss, congenital or acquired, may result in lifelong deficit in speech, language, psychosocial, personal, and behavioral problems. So today I am dealing with newborn screening. It has got many components, that is birth defects, visual birth defects, blood dysplasias, congenital heart disease, for eye screening, for neuropathies, and for the newborn hearing screening. Today I am dealing with newborn hearing screening. So why is hearing screening important? The first 6 months of life, they are very crucial for the development of speech and language. The vocabulary of a 3-year-old child with typical hearing, that is with normal hearing, is 500 to 900 words. But if we see the vocabulary of a 3-year-old child with hearing impairment, which got remediated at birth, it remains only 300 to 700 words. If remediated at 6 months, the words remain 150 to 300. And if the same child remediated at 2 years, the vocabulary becomes negligible, that is 0 to 50 words. Hence, screening for hearing loss should ideally be initiated before 1 month of age. Without screening, hearing deficit is usually diagnosed between 2 to 5 years of age, and parents actually seek advice for language delay, not for the hearing loss. Just to add for this is each month lag in the diagnosis of hearing impairment accounts for around 17% month delay in receptive language and 30% month delay in expressive language. So what is universal neonatal hearing screening? It is a strategy that enables us to identify congenital deafness and hearing impairment. The major objective is to identify children with all kinds and degrees of hearing impairment, both unilateral and bilateral, and to lower the age at the time of diagnosis for early hearing amplification so we can maximize their linguistic competence and literacy. What is actually targeted screening? Targeted screening is when we are screening actually only at-risk babies. What are the pitfalls? UNHS, if we do only targeted screening, we are actually likely to miss approximately 50% of the infants. That means I mean to say that the 50% of the infants with hearing loss, actually they have no known risk factors for hearing loss and they are discharged from well baby nurses. One more fact I want to add here is that 90% of the infants who have hearing loss, they have actually normal hearing loss. These are the major risk factors. I don't want to I will skip this. The current status. In actually developed countries, nearly 1/3 of the world population is almost or fully covered by UNHS. But in countries like us, we have lack of relevant policies, human resources, we have lack of equipment, we have so many challenges. And these challenges are further actually aggravated by hearing loss and its associated stigma. So what are the two main tests currently used for UNHS? That is autoacoustic emission test and automated auditory brainstem response. These both tests are non-invasive tests and they are easily performed in neonates and infants, and we can have a specialized portable machine for WHO recommends both the tests for early identification of BBHL. I'm skipping few slides here. So what is a target group? UNHS actually aims to cover all infants irrespective of the risk factors before discharge. It also aims to cover the births including home deliveries, and due to high birth rate and resource limitation, country like us, the first step would be to cover those at risk and then rapidly expand from targeted screening to universal. That should be our aim. What is the time frame for screening? First stage. We have two stages, first stage and second stage. The first stage, it should be done as early as 24 hours of life. It should be completed preferably before discharge. And in smaller infants, screening should be done when baby weighs more than or equal to 1.5 kg. And if the baby is on ventilator or the baby is very sick, when the baby is stabilized, then we can do the screening. And outside hospital deliveries, screening should be linked with immunization. That is at 6. So, this is first screening. First screening, that if the result is pass in both the years and if there is no risk factor, we can review if there is concern. If there is a risk factor, we have to monitor. If the referred result in 1 or 2 years, then the second screening. Second screening is again with autoacoustic emission test. If autoacoustic emission test is negative, we have to do automated auditory brainstem response. So I'm telling next slide. The second stage screening, infants who fail first stage should have second stage screening. Should occur either still in the hospital after a gap of several hours to reduce false positive tests due to few transient newborn conditions. And if the second stage screening fails, then we have to do preferably an AABM. Now, this was the first, before a few months before, we had a principle of 136 that the hearing screening should be done by 1 month of age, the diagnosis should be made by 3 months of age, and intervention should be done by 6 months of age. Now, many countries are shifting from 136 principle to 123 principle. That is, hearing screening should be completed by 1 month of age, diagnosis should be completed by 2 months of age, and intervention should be completed or should be initiated till 3 months. So, principle from 136 has shifted to 123 principle. What is autoacoustic emission test and how does it screen? Or because of the time constraints, I'm not dealing with this. I'm just telling the OAE protocol. First, when we are doing OAE 1, that is first time, if it is passed, then process is complete. If it is negative, we can do second OAE in next 2 weeks. And then, if it is passed, no problem. If it is not passed, that means it is negative. We can rescreen or we can assess the middle ear, otoscopy, tympanometry. Even if it is not passed, that means we have to refer the patient for AAP. I'm a state nodal officer in Haryana for NPPCD program. I did training for the staff nurses to initiate UNHS program in Haryana in Feb 2023 of all the staff nurses of obstetric and postnatal ward so that we can initiate UNHS in Haryana. I did hands-on training for OE machine. So here we did hands-on training. We told them how to do these tests, in which room, the room, few prerequisites are here for these tests. That is that room should not, background noise should be less and room should not be very soundproof, but we can reduce the background noise. The baby should be well fed. The baby should be swaddled. The body movement should be minimal, and we can do this test. We did hands-on training. We showed them the different ropes, how to do this test, in both ears, and how to give the diagnosis, and how to refer these patients. In which conditions? So what are the benefits of UNHS? Benefits that the children identified with hearing deficit before 6 months of age may not have any speech and language delay, and they are likely to develop equally to their hearing peers in terms of speech and language. So I'm just finishing it. Early intervention is mandatory for the best prognostic outcomes. Limitations, only 2 slides. Limitations that it does not diagnose late onset of deafness. We can miss late onset of deafness. The first stage of screening might miss auditory neuropathy because OE just tells about the cochlear function. False positive test, because OE test is very much sensitive. So much that is very 4% false positive test, so which increases the cost of the program and prolong the unnecessary diagnostic procedure. And the problem in India is loss to follow patients. Future is only the last time I am reading that the combination of OE and ABR testing provides the most accurate diagnosis for hearing loss and significantly reduces the referral. Take home message. The first thing, hearing loss should be screened preferably before 1 month of age. Even images rather than targeted screening should be ideal, should be an aim. If abnormal OA detected, it has to be repeated at 6 weeks or on the first immunization visit. And if again abnormal, please do AABR for the confirmation, followed by full audiological evaluation and remediation till the 6th week. And all high-risk babies, that is NICU babies, should undergo AABR testing to rule out auditory neuropathy or auditory dysfunction. Thank you so much.
Thank you, Dr. Abha. It was a very nice lecture on UNHS, and you rightly said that not to be targeted, but it should be a universal immunization screening for all hospital deliveries. Though the newborn is discharged, that in first screening, the pass should be set. And that lead to early intervention and sir, we'll have to involve our ENT person. ENT sometimes ENT becomes not. Yes, yes. Showed us that this should be go to every labor room so that all know when to Thank you.
Good afternoon, all. I'm Dr. Dameshwara, here to present the topic on traumatic ear perforations. How can we reduce the challenges with them? So, the first challenge that comes with this topic is how to diagnose. The patient that comes or walks into the OPD, the symptoms are as good as any other ear problem. The patient complains of pain, complains of discharge, or something sound, not able to hear. And most often, the patient tries to confide the history because it could be a case of domestic violence or physical assault, or the patient could actually be having a medical legal case, which he or she would not be wanting to tell the primary physician. So, a careful history along with reading the body language of the patient is very essential. The second is examination. In examination, as the patient is already undergoing so much pain and is frightened, a very sensitive examination of the ear is of the prime importance.
The next is diagnostic test. A audiological, that is a pure tone audiogram, can be used for patient education to convince the patient that yes, you are having a hearing loss, and for a medical legal support. High resolution CT could be used for some complex cases or some medical legal cases. The next is the challenge in the immediate management. So first of all, we have to address the pain of the patient. If the patient is in a lot of pain, we can probably give them some intramuscular diaphragms and instill some lidocaine into the external aortic canal. So the patient allows us to move any further. Infection risk, we have to prevent the infection at any cost, because no matter how much is the size of the perforation, how good the patient is taking care of the perforation, if there is an infection in the period, the healing would be impaired and it will result in a residual perforation. Now coming to the healing and recovery, now this is the main problem. The healing time is variable. It depends on patient to patient. There is a variable in the factors that would be influencing this recovery. And the major problem is the risk of a non-healing or a chronic perforation. So how can we address to this non-healing or chronic perforation risk? So I would like to present two short videos in which I have shown that how can we improve the results of our traumatic perforations. So this is a traumatic perforation that we can see can be easily identified with this red marks all around. The most important thing is to examine the patient under a microscope or an endoscope so that you can exactly see what are the status of the edges, the torn edges of the perforation. So as you can see, this is a fresh traumatic perforation. This is a good case in which now, in this case, what we can do is we can try to reposition the torn edges. The edges could be inverted or inverted. This happens in roughly 60 to 70% of the cases. And if a timely intervention or an examination of microscopy is performed, these torn edges can be used to help in the early recovery or a better prognosis of the healing. So in this case, like we see, we are using microsphere suction just to reposition the torn edge and bring it in place. In very few cases, we are able to get almost complete closure like this. But the most important is we have to hold a micro instrument in that very position for some time and take the memory of the soft tissue. But not every case is like that. In many cases, we are not able to get these torn edges. In those cases also, after performing an examination of microscopy, a negative suction pressure over the edges helps in the rest of the 25-30% cases in which we do not get those torn edges. A simple negative suction around the edges of the perforation tries to bring back the vascularity of the edges and that helps. The last step is we place a small piece of abject. It does not have to be necessarily impregnated. It can be a dry abject piece also, which just covers the layer. First of all, it holds the torn edge that we have repositioned back into the place. And secondly, even if we have not repositioned or not been able to get the torn edge, it just provides a surface for the perforation to grow. So the key point I would say would be here has to be absolutely dry. Second is it is better to reposition when the torn edges of the perforation are fresh. So you have to tell the patient, sometimes the patient says, okay, we want to try the medicine for 2-3 days. I tell the patient, if you want to do it, get it done before right now, because after 2 to 3 days, when the torn edges vascularity would have gone down, the chances of recovery would be less. The no torn edges are found, negative pressure by suction is helpful. Follow up is after 1 week, we see the patient. If there is no infection, just a multivitamin for another 2 weeks is helpful. And after the 3 weeks, the piece of abject is removed, and in usually cases we see a complete impact. The most important thing is try not to disturb the middle ear by any medicine or instrument, because this is not a case of chronic otitis media. In case of chronic otitis media, we as a surgeon are very eager to probably use a 4% or adrenaline into the middle ear, but because it is a diseased middle ear, they are not being affected by it much, but in a version here like this, as soon as we insert any penicillin into it, the chances of rapid stimulation are very high. So, starting when we have to locally anesthetize the tympanic membrane, we use a cotton pledget which is soaked in 4% but not dripping so that it enters the middle ear. We just place it over the tympanic membrane and we go it up. The summary is a short and easy procedure that can be done. It reduces the disease morbidity and reduces the financial burden to the patient. Yes. So the last operation, in fact, the last operation, the prognosis for spontaneous scaling is already very low. 50% of the times I get some inverted margins on the, so those inverted margins I try to position them on the longer tympanic membrane. So the results are definitely better than the spontaneous closure. Normally, I say it is 90% in overall. If we go for this patching and scaffolding, and otherwise it is roughly 70%. It is medium size. So in the literature, there are many. In the literature, there are many studies in which they say and which significantly improve that scaffolding and improves the result. So not it's all. I want to discuss an article also on this. When I started reading on this, so in that also it was significant. Can you differentiate and blood trauma? I think the case usually patient comes out with some history and we can
दसना पड़ा कि पेशेंस का गाना तो बात हो
your practice
गाल वाला पड़ता है गाला गाला वाला चलो मैं
everybody will be 3 weeks.
आइए सीधे सीधे
And I don't think there is any confusion about it. I think let us applause Dr. Danish Arora for presenting a topic which is generally not discussed. I want to congratulate you for this very simple, very important. And generally, also because there is no
all the speakers of otology, please come on the stage of presentation in between.
patients do not go to use personal time. Hearing loss is somebody who wants to especially those cases in the domestic violence cases. The issue I don't answer like when do you start? I simply ask when did you get hurt? So the patient is being so comfortable, otherwise they don't give the history. Yes. So sir, I don't correct them. Sir, I never correct them. I never tell them that no, it doesn't happen like that. Yes. Sir. Only the surface. I use that over a bottle. I will try this. Sure, I will try this. Thank you, sir.
I will, I will now request Dr. Krishan and Dr. Sunita to kindly felicitate the speakers, Dr. Danish Arora, Dr. Vikasi, Dr. Amar Singh, and Dr. Vinilata. I will now request Dr. Gulshan to felicitate Dr. Danish Arora. I will now request Dr. Arvinder Mann to felicitate Abba Singh Mann. I request Dr. V.K. Agarwal sir and Ashok sir to kindly come on the stage and felicitate to take the chairperson for the session. Proceeding further. Now is the time for case discussion on biology. For our upcoming session, I would like to invite Dr. Nitin Gupta, Dr. Rubina Arora, and Dr. Kanika Rana on the stage for this session. Dr. Disha, Dr. Monica, and Dr. Nishi will come on the stage for the case. Good afternoon, respected faculty members, all the consultants, and all the residents. Today we are going to have a case presentation on years of months. As for history, 58 years. So I'm Dr. Monica Volkane from Civil Hospital, Kanishkar. A 58-year-old male, carpenter by occupation, Muslim by religion, belongs to low socio-economic status, came to ENT OPD with chief complaints of nasal obstruction since 1.5 years, which was much more to left than right side. That's a nasal discharge since 2 months. In the history of presenting illness, the patient has complained of nasal obstruction since 1.5 years. It was insidious in onset, chronic in duration, progressive in nature, much more in left nasal cavity than right nasal cavity. Persisting all day long, more at night, it was aggravated by cold, not relieved from medication, and was associated with weight loss. Patient has also complained of nasal discharge. It was since 2 months. It was acute in onset, greenish yellow in color, mucoid thick in consistency, scanty in quantity, non-foul smelling, blood stain. It was scanty, red colored, on and off, non-progressive in nature, and there was no aggravating or relieving factor. In the negative history, there is no history of trauma to nose, post-nasal discharge, or decreased sense of smell, or recurrent sneezing, cold, or headache. There is no history of ear discharge, ear pain, or reduced hearing. No history of eye watching, double vision, pain behind the eye, or blurring of vision. There is no history of decreased mouth opening. There is no history of loosening or falling of teeth. There is no history of facial numbness. There is no history of throat pain, difficulty in swallowing, or painful swallowing, or shortness of breath. In this past history, there is no history of any chronic illness like diabetes mellitus, hypertension, tuberculosis, or asthma. There is no history of any past surgical intervention. There is no history of blood transfusion, hospitalization, no history of any allergic reaction. In his personal history, patient has normal sleep, normal appetite, diet is mixed, bladder power habits are normal, and in his addiction history, patient is a BD smoker. He smokes 12 BDs per day since 20 years. In his family history, there is no such similar complaint in any family members. It was second history. I request Dr. Uma Garg ma'am to come on the stage to chair this session.
by ruling out the negative history of post-nasal discharge, recurrent sneezing, cold, and headache. We want to rule out the history of allergic rhinitis. By ruling out the ear discharge, pain, and decreased swelling, we want to conclude that there is in the ear there is no any pathology nose which is causing ear pathology. And in history of eye watering, double vision, painful mechanical blurring of vision, since there is a mass in nasal cavity, so that mass can reach out to the orbit and can cause the following symptoms. So we want to rule out if there is any orbital involvement or not. And history of decreased mouth opening, since it is a case of mass nasal cavity, we want to rule out any other malignancy or any other area. So if there is more mass involvement, so it can spread to thyroids, which can lead to the decreased mouth opening. So we have ruled out that if nasal mass. Involvement of thyroid.
Which is focused on this maxillary sinus. It is a procedure related to all of the maxillary sinus. It is related to thyroid. So if it extends towards posterior, then it may involve thyroid plates and going to maxillary and then.
In history, by looking at the history of losing of teeth or falling of teeth, trying to dental diseases, or in cases of history of patient illness, we are trying to look at let's take this one. 1.5 months to 2 months. Trauma to the lower step due to as well as
Granulomatous diseases like sarcoidosis. So in case of benign synovial tumors like emergent papilloma, so in cases of malignancy of synovial like carcinoma or squamous carcinoma, there will be a very serious challenge.
Reading from the
Good afternoon, everyone. I'm Dr. Disha from GMC Chandigarh, and I am presenting the examination. My patient was moderately well nourished, and oriented to time-based. His general condition was better.
taken in the right upper arm and sitting position. His temperature was 98.6 degrees Fahrenheit. There was no pallor, atrial cyanosis, clubbing or left retinopathy or complaint of blood stain discharge. So if there is excessive blood loss in the mouth of the in case of cervical lymphedema, in case of nasopharyngeal carcinoma, level 2 to level 4, submandibular lymph.
I think temperature should be mentioned, right? First, and then rest of it. Then rest of it. Keep all the things and then first mention temperature.
On systemic examination of the CVS, S1 and S2 were normal. There were no audible murmurs. On respiratory system, there were normal bronchovascular vesicular breath sounds, no fractures or no gaps or no wheezing. On examination of the abdomen, it was soft, non-tender, and there was no organomegaly. On examination of the CNS, the higher mental function, the motor functions, and the sensory functions were intact. On examination of the cranial nerve, in olfactory nerve, the smell perception was absent via both nostrils. Rest of the cranial nerves were within normal levels. Now, sir,
एक लस्सी कम
so there could be, sir, if there is metastasis, there could be abnormalities in the abdomen. Cranial nerve examination. Sir, there is no cranial extension in the abdomen. Then on examination of the nose on inspection, on external examination, the upper one third, middle one third, and lower one third dorsum of the nose is crossed the midline. There are deep indented patches present to the dorsum of the nose. There is fullness of the left nasomaxillary groove. There are no sinus or scars. There is no widening of the nasal bridge. On palpation, there is no crepitus, tenderness, or sweat. Then on vestibular examination, there was thick mucoid discharge present on the floor which was suctioned out. There was no caudal dislocation, erythema, ulcer, perforation, blasting or fracture. On anterior rhinoscopy, the septum was deviated to the right side in the cartilaginous part which was not touching the inferior turbinate. In the left nasal cavity, there was a pale polypoidal lobulated mass filling the left nasal cavity completely reaching up to the throat, whereas we can see on probing, the mass was soft, insensitive to touch, it bleeds on touch, and probe could not be passed superiorly and laterally. On posterior rhinoscopy, there was an irregular pale polypoidal lobulated mass completely filling the left corner and going into the nasopharynx and partially obstructing the right corner. The posterior end of the septum was not visualized. The left eustachian tube orifice was not seen, while the right eustachian tube orifice was normal, and the posterior superior wall was not seen, and the soft palate was normal. On examination of the paranasal sinuses, there was no frontal, ethmoidal, or maxillary sinus tenderness. On transillumination test, the transillumination of the maxillary sinus was seen on the right side, whereas it was absent on the left side. And for frontal, we press on the superior medial aspect of the orbit, just above the medial canthus. For For ethmoidal, medial to the medial canthus, and for the maxillary sinus tenderness, it is done in the canine. It is superior medially to the medial canthus. Away from the yes. I use the torch and I place it in the examination.
जी सर। हाँ जी, मेरा खाना इधर ही था ना, इधर ही था। हाँ, कितने बंदे खा गए मेरे? ठीक है, अभी शाम का मैं बताऊंगा आपको ना, कितने बंदे खा। ठीक है, अभी यहीं पे है, फिर मैं आता हूँ शाम को आपको क्लियर करता हूँ।
Hello. So you have to insinuate your fingers between the orbit and the floor of the frontal sinus, and should be away about 1 to 1.5 centimeter from the midline. Because just close to the midline, you are having supraorbital vessels along the nerves. If you are pressing over, then you will not be able to test. So you should testing over the floor, and then.
Then functional tests were performed. On cold spatula test, there was absent fogging on the left side. Fogging was present on the right side. On cotton wool test, there was no movement on the left side, while movement was present on the right side. And in Potty's test, there was no improvement on both sides. The smell test, it was absent bilateral. Then diagnostic nasal endoscopy was performed in the right nasal cavity. In the first pass, as here we can see, there was a spur present which was not touching the inferior turbinate. The inferior turbinate was normal and the flow was clear. And here we can visualize the nasopharynx also. In the second pass, as shown in this image, there were multiple pale polypi which were occupying the sphenoethmoidal recess. In the third pass, the middle turbinate was polypoidal and middle meatal area could not be visualized. In the left nasal cavity, there was multilobulated pale polypoidal mass which was seen obscuring whole of the left nasal cavity, which were arising lately from the middle meatal area. It would be allergic. Allergic. This is the video for the DNA. This is on the right side. So we go along the first pass, so we can see a spur present on the right side of the septum. Inferior turbinate is normal. So we see the nasopharynx, which is clear. And as we go superiorly, this is the superiorly the middle turbinate was polypoidal, and in the SCI multiple pale polypi were present. This is the DNA of the right side, of the left side. Here we can see multiple pale polypi which are present. And here is the allergic mucin. We try to suction it out, but we are unable to suction it.
No, sir. Then on examination of the face, there were depigmented patches present over the face, and there was diffuse fullness present in the left nasophacial loop. There was no sinus scar or fistula. On palpation, there was diffuse fullness present. We confirmed the findings of infection, and there was diffuse fullness present in the left nasophacial. It was tender. There was no local rise of temperature. It was soft and consistency. The skin over the swelling was ventricle, and the underlying bone was not palpable. This is the image. There was a swelling. Diffuse swelling. Yes, sir. No, sir. Yes, sir. But the patient. Then on examination of the orbital alveolar, bilaterally it was within the normal depth and vision. There was bilateral finger counting at 3 meters. The color vision was normal. The extraocular movements were bilaterally full, free and painless. In the pupil, it was bilaterally MSNR and there was no RABG. Or there was no proptosis. The bilateral corneal reflex was present, diagonal reflex was present, and intraorbital sensation. An examination of the neck, the laryngeal contour was normal, the trachea was midline, the laryngeal crepitus was present, and there were no palpable lymph nodes. Then an exam. Sir, if there is if the tumor erodes the bones, there can be a compression of the intraorbital nerve, due to which the intraorbital sensation is not. And ma'am, in the superior part of the pathway.
Now, if presenting now, okay,
Then an examination of the ear. In the preauricular area, on both sides there were depigmented patches. In the pinna, there were depigmented patches present all over the pinna. In the post-auricular region also there were depigmented patches on both sides. The external auditory canal was clear on both sides, and the tympanic membrane was intact and mobile on both sides. Then an examination of the oral cavity. There was adequate mouth opening. The orodental hygiene was poor, and there were nicotine stains present all over the teeth. The hard palate was normal. There were no dental caries, loose tooth, or swelling. The oral pharynx was within normal. What is normal mouth opening? Myself, Dr. Rishi from GMC Amritsar.
This part, lymph phenopathy which you mentioned, the part is not critical. When you are doing patient of nose, nasopharyngeal area, then again,
So on the basis of our history and examination, we went over the differential diagnosis of chronic sinusitis with nasal polyposis. Since the patient was presenting with the nasal polyp on the unilateral side and was an age group between 6 to 7 decades, so a suspicion for inverted papilloma and also he was a woodworker, so inverted papilloma, sinuses and malignancy will be observed. Allergic from the sinusitis is also a differential diagnosis. We then marked the patient for BSL biopsy, and biopsy was taken from the multilobulated pale polypoidal mass, which was obtained in the left cavity and has been sent for pathology. We also made the patient go under contrast enhanced computed tomography. These are the following sections in which we are going and here we can see that the anterior wall of the maxilla, it is divided by a enhancing heterogeneous mass, which is obscuring the nasal cavity also and also moving to the right nasal cavity. Here we can
That is where you see anterior. And so was colonization. We will also see that posteriorly the mass is also obstructing the posterior wall of the maxilla. In the axial sections, here we can see that the mass is going into the soft tissue, in the premaxillary fat, and also it is obstructing the anterior wall, posterior wall, and also a slight posterior extension into the infratemporal fossa. In this. In the central section also, we can see the mass obscuring the maxillary sinus. So yes, sir. Mass is a hypodermic surveillance. So what are the conditions we will find surgeon? Month in fungal what is the reason? Well, what is the reason for that? Presence of fungal and the cross tissue. Some fungal infection have metallic salts. So that also according to the radiographic reporting, the large extent and mild enhancing lesion in the left maxillary sinus of sleep, the mid part of the left maxillary and causing soft tissue projecting into the maxillary fat and red and spread to maxillary fat with erosion into the left posterior thigh. Patient also underwent magnetic resonance imaging. The ecosystem section of the long-term magnetic resonance imaging shows a mass which has hyperintensities with focal points of hyperintensities which may signify internal hemorrhages and may go to the side of malignancy. Next section also, we can see hyperintense intensity all around surrounding a homogeneous mass, and in this we can see that it is affecting the maxillary sinus and also going into the nasal cavity. This is the image showing the coronal sections, which is showing the mass again, and here we can see a slight affection of the inferior wall of orbit, but the lateral rectus muscles they are appearing on. Now, CPSS gives us a better view of the bony erosions, and MRI gives us a view about the soft tissues. Not in the bony erosions, so like I tried to essentially the walls of maxilla we are looking at the skull, that whether are ligaments and the skull base or not, if it is orbital in the orbital walls of orbit. MRI helps us to differentiate between soft tissue factors, whether the secretions are, whether it is collection of secretions or it may be a mass, which is occurring.
The patient in which there is a breach of the skull base. It was really breached by tumor. After going into the integrating but there is focal sign. At the mark of breach.
Also, it is the mark of pain for the vital energy. So, this was there. Yes, whenever a patient is in the urinary and that inverted papilloma. So that is MRI cerebral conclave forms RC.
Inverted carcinoma gets converted to malignancy, undergoes malignancy, then treated.
That state is charged or sometimes blank meaning. That state is charged.
Neuroblastoma. Right, is also
What is the basic principle of treating a particular problem of principle?
While basic model, when we move forward, automatically whole model can be removed from here and concentration of the cytoplasm.
Irrespective of where the tumor may be, if there is a function, mostly it is likely in the equation. You have to basically go to the attachment and build the attachment so that the bone becomes not the bone is it goes back to the function. So approach may be exactly and depends on the location. If it anything basic
What special precautions will you take course of treatment in the case of air holes? What will happen is there any role of hydrocolloid? This will be the patient for what pressure and what blood test to do. And we will do as well as zero function test. We can give it for 450
I would like to, I would request Dr. Vishnu Kumar and Dr. Upendra to kindly come to the stage to participate in this. Now please stay on the stage for felicitation. Please come on the stage. We request the speakers to come to the stage for felicitation. I would request Dr. Umar Ma'am to kindly felicitate Dr. Nisha. Request Umar Ma'am to felicitate Dr. Disha. I request Umar Ma'am to felicitate Dr. Disha. I request Nitin Gupta sir to felicitate Dr. Monica, Dr. Rubina and Dr. Kanikarana to felicitate Dr. Nisha. Now going on in lecture theatre, the selected teams for quiz are first GMC Chandigarh, Nancy Delhi, PGI Chandigarh, GMC Faridpur, Civil Hospital Panchkula, and GMC Patiala. Now moving on to the next session. our respective chairpersons for this session. Dr. Preetham Arora, Dr. Gurjan, Dr. Arvinder Singh Maan, please come on the stage to chair the session. I request Umagar Maan to come on the stage to chair. I request Dr. Rajnita Gupta ma'am, Dr. Nikhil Arora sir, Dr. Hitesh Verma sir, and Dr. Sandeep Cooper sir on stage. I request Dr. Rajnita Gupta ma'am, Dr. Nikhil Arora sir, Dr. Hitesh Verma sir, and Dr. Sandeep Cooper sir on stage. I request Dr. Giri Datta ma'am, Dr. Harsha, I request Dr. Arvinder Singh Maan sir, Dr. Tanika Rama ma'am, Dr. Abha Singla ma'am to kindly come on the stage to chair the session. I request Janita ma'am to come on the stage. Ma'am did her MBBS in 1992 from Government Medical College, Rohtak. She did her post-graduation in ENT from PGI Chandigarh. Ma'am is serving in PGI Chandigarh, NJ. Ma'am has won various awards like Satyapal Khosla Award in Outbound Conference, IS Gupta Senior Consultant Award Paper, and Junior Consultant Award Paper in Northwest Zone and Authority Conference. I request ma'am to please come on the stage for this rhinology session, says tips and techniques.
Thank you, Dr. Monica, then also to join the session with you. Finals of quiz are going to start in lecture 32. The winners' names has been announced for winners or not? Teams, many teams has gone for this quiz. It's going to start very shortly in lecture 32.
I'm Dr. Vijay, professor in PGI. So I have been given task to speak on functional endoscopic sinus surgery tips and techniques. First of all, I would like to thank Dr. and his organizing team. We'll be talking about functional endoscopic sinus surgery. Now, this term is little restricted down nowadays. We more say that endoscopic sinus surgery because it's used for so many CRS, AFRS, angiogramas, and various tumors, and whatnot, all surgeries. So, functional endoscopic sinus surgery. So, the aim is to preserve normal structures, removing only obstruction part, preserving the mucosa, and an attempt to restore mucociliary function and make the conditions conducive to have availability of the topical easier. So, like this is a simple case, like it's an AFRS involving isolated maxillary sinus. And we have these type of pictures also in North India side. Extensive fungal granuloma, AFRS. So, again means functional endoscopic sinus surgery and debridement, and followed by the post-op topical steroids and follow-ups, regular follow-ups. Again, this is a allergic fungal rhinosinusitis. This patient is with me since 12, 13 years, and had operated 12 years back by Smith monitoring approach. It used to be like that earlier, and after that also once I operated endoscopically also. And We had this is on energy converters and sectors. I think Hitesh was my first thesis candidate, and we did this study. We have a prospective study comparing the surgical modalities, similar as well as endoscopic. Those were the errors, and not only endoscopic is the only error. What we need to study is NCCT nose layers with three-dimensional small structures in all three planes, axial, coronal, and sagittal planes. And this for the residents, the close is the mnemonic. We need to look for the triple plate, the lamina patracia, orally cells, sphenoid sinus civilization, and interior part. So we should have all idea about this. And this is all how we use our deviation and attachment of the intersphenoid septum to the carotid artery. All these things we need to see. Then various factors which are taken into consideration in various laser endoscopes, 0 degree, 30, 45, 70, be with you to approach all the sinuses. The through-cut instrument is very important. Through-cut receptors, straight and angle dividers, shaver system, power instrumentation, imaging, whenever required, along with CT, MRI, if you want to know the very high environment. The image guidance system has also various indications. I'll talk about it later on. Thorough knowledge of the anatomy is very important, and hypotensive anesthesia. Important to do endoscopic sinus surgery in hypotensive anesthesia. I keep my BPM heart rate low, around 90 by 60, and pulse my heart rate around 570. So these are various stable intranasal landmarks which are important to know. If you have better dominant, you don't have unsafe process, whatever you don't have, then look for these things so that you go ahead for the functional surgery, even in the division cases. So basic techniques are basic plunger. This is anterior to posterior approach. It starts with the removal of the unsafe process, to expose the infundibulum, removal of aortula, then exposure of frontal sinus ostium, identification of proof of. Once skull base is identified, then resection continues posteriorly, involving the anterior posterior points, and then sphenoid sinus. Then ostium of the maxillary sinus is seen with 30 degree and widened. So Weigand's technique is opposite to this posterior to anterior approach for completing the atherectomy. Begins with a partial resection of superior abdomen, opening of posterior points which are placed laterally and endoscopically and medially sphenoid sinus. So I like Weigand's technique much because we identify the skull base first in this and then come to. So less chances of complications in this. The major advantage is the pain that I will. So with the 0, 45, 70 degrees, with 0 we have less angle of the instruments, with 30 and 70 degrees we have more angulation of the instruments. So that makes more difficult the instrumentation, leading to less exposure, bloody surgical field, slow progress of the disease. Sometimes it causes frustration to the surgeon and causing inadvertent injury to the surgeon. Is line or something. So this axillary flap approach was devised by the government, PJ Robert, and he designed it to enlarge the area of the axis, especially for the frontal sinus and to open the frontal recess area. What he does is, as you see the attachment of the middle turbinate in this axilla, 8 mm incision above axilla of middle turbinate is given to and bring it forward by carry it back into 8, 8, 8. And then lift the flap and take out the stone which is with the Kelsen punch, which is Kelsen punch, and you can see the full stop picture. And it's very nice dealing with this. And as you do it with a 30-degree endoscope, and if we don't remove the axilla, there's much of angulation and so this approach was devised. So that to take out the rear face of the agonizing with the 0 degree and less of angulation of the instrument is required. Straight up you go ahead to have a frontal loss. So what are the results of this? Like, it provides visualization of 96% of the frontal sinus osteotomy. Lesions are less, prevents relation tissue formation over exposed bone, prevents neuro-osteogenesis and scarring. This is the video showing case of this, in which this was actually the case of IIH, idiopathic intracranial hypertension, and for which I did the optic nerve sheath fenestration. This is just to show the clarity of the anatomy. So first of all, this lateral anatomy was done, then uncinectomy, which can be anterograde, retrograde. So retrograde when you do is vital, back forceps, and anterograde when you do tears and musical life. Then when you go for the sphenoid pause, always decongested nicely so that you can see the speed. Always cut in the inferior medial direction with our show punch. I like this instrument very much. And as you see, there is no extra bone involved with this. And we should not do it circumferentially, otherwise that will cause stenosis. Then superior turbinate, lower half can be taken out. In this, I am taking out more because the more space in the posterior points and right sides. You can see very clearly that endoscopically, medial to the superior turbinate is always sphenoid sinus, lateral to superior turbinate is always posterior sinus. So very clear with this. And when you cut and widen it with a through cut punch, never pull and always use the through cut instruments forward and straight forceps. And if you can send punch again, you can out the part of the middle turbinate also. So, further, as you go, this is just to show that we can see the other things, but it's not true in basic polyposis and so, another case in which we can see the orally cell. So, this large orally cell was there, and this also optic nerve was very clear anatomy we can notice whenever we go for the other surgeries, we should look for the anatomical areas and the picture is very clear in your mind. So this is the case of the nasal polyposis. So whenever this type of picture is there, you first remove the polyps with the divider, and then you can see the polypoidal process was there, which was again divided. Open the maxillary loss, and with the angled instruments always 30 or 45 degree, you with the angled divider you take out the polyps. And again, you go immediately, and in the sphenoid recess area, and then here. Whenever you are opening into the voids, interior voids, you go inferior medially, not towards laterally, and then do the uncapping of vulva. So this is being done, and then in progress posteriorly. Sorry for the and then going towards the anterior voidotomy and frontal recess area. So as we are going ahead, you can see when you approach the frontal sinus area, you should always use the giraffe instruments, 45 degree endoscope and divider. So all frontal cells, frontal recess cells are to be opened, and when you see with a 45 degree, always look for that you have entered into the frontal sinus. Always look for the frontal globe. So this you can see the left side. You can see such a nice frontal globe. I never complete my surgery without seeing the frontal globe, or left side as well as right side. Whenever the disease is there. So you can see that I am using giraffe instruments anterior posterior. If you are not able to approach with the small instruments and the giraffe instruments is required, that means you are in the frontal sinus. Again, you can see on the other side, right side, frontal sinus is now, another case of primary truncal sinus aspergillosis. So this was also published. We had cases of isolated primary truncal sinus which we published in in this case, when you approach the frontal recess area, actually fungal granuloma AFRS they already widens the frontal recess area. So many times you just take out the person and then it is already made its first with the guideline and as you can see, we have mentioned about the frontal sinus with the angular instruments. 45 as well as 70. With 70 you can examine because it is difficult to 70 degree instrumentation. Then you can use 70 degree to examine. You can see that we have the J unit. Beautiful instrument called the and as you can see, some SSL peeling out into this. That can be dealt with the irrigation environment. Irrigation is also good clearing the frontal sinus areas. So, frontal sinus irrigation records should and the would adequate levels of frontal sinus. And always look for the frontal. So that we can then in the role of modified lockdown, very rare cases like revision surgeries, many multiple surgeries have been done, such as new osteogenesis and calcaresis or osteo, and disease with the resultant loss of the posterior wall of the frontal sinus, failed years this lab which we use with observation for observation with music formation. Whenever we use this contraindications are just the poorly rheumatized narrow interdistrict of the frontal sinus. The peak is bigger. Then that means the NRSI is there, that needs to be taken out. If it is very narrow, very small NRSI, then it's difficult to do the modified outcome. So indications for navigation also nowadays we are available the navigation systems. We can take that, otherwise self-surgery doesn't need more than 300 surgeries like that. And we use navigation system that should be revision sinus surgery, distorted sinus and apnea of development, extensive sinus process, and functioning organ frontal posterior points, sinuses, disease of buttons, cavities, optical, artery, CSF primary sometimes, and then we can we don't have this, then we have to good practice of these various courses, knowing that and various conferences and this in the workshops. So beyond sinoplasty also has a role. Indications are in negatively failed for in these cases, which is available for the can be used as an active procedure also. And children also limitations are various variations in mechanisms, sometimes solos are used. Thank you.
myself to test the complications of this. Dr. Yeshua, Professor in Department of Laryngology, Head Surgery, ENT New Delhi. My publications in liver high transgenders in heart and is author of essential biology textbook. And one significant awards for best publication awards related to the World Medal Management Consulting
Good afternoon and good evening, everyone. There's an outsider and for the organizer. So my topic is complication of health. So functional endoscopic sinus surgery is physiological functioning and to present the anatomical structure and to present the functional anatomy. With the help of powered instruments, geotechnic image guided surgery have improved the efficacy and safety of the procedure. Why still there is a risk of complication? Because of variable anatomy, close relationship with the cranial cavity and close relationship with the vascular structure. So factors that help in avoiding complications with thorough knowledge of anatomy, detailed assessment of preoperative imaging, advanced technology, as we have discussed in previous presentation, image guidance, and hypotensive disease. So complications are more common when there is a revision surgery, when there is extensive disease, when abnormal anatomy, places of a disease, hypoplastic sinuses, variable anatomy like long and high should be formed because of extensive pneumatization. Inside and more active, other anatomical variation like asymmetry between cells. So, some stable landmarks which we use in revision surgery like middle terminate remnant, posterior corona, sphenoid sinus, skull base, septum, maxillaris sinus. So this is a list of complication of endoscopic sinus surgery. Nasal is more common than orbital than intracranial. In nasal, we will discuss one by one. So, sinus is the most common complication of stress, seen in 10 to 20% of cases. And it develops when two opposite raw area comes in close contact. So when there's a microfibrillary band forms, and over a period of time they organize and form. So whenever how we can prevent the synechial formation by losing all those hanging mucosa, we should remove during surgery. Packing should be done under vision, so there is no new trauma occur. If middle terminate is unstabilized, in that case, pulverization or suturing of middle terminate can be done, and regular follow-up and proper cavity cleaning. And if synechia occur during even follow-up, then release of synechia is required. So video is also not working. Okay. So hemorrhages. So there can be mucosal pores or there may be bleeding from the named vessel. So we are primarily bothered from the bleeding from the named vessel. Ventricular artery is most commonly discussed, but it is not that common. So when it is majority of time it's run intracranially, but in the pure situation it can be run within the nasal cavity, like wider frontal recess, presence of supraorbital ethmoid cell, and there's a kilo type 3, long and longer triple conclave. So management, if someone is leaning at the side of the enteroethmoid artery, so it should be done in the central part of the enteroethmoid artery, so that if there's an injury occurs, then even though we can clip the artery at both ends. And because of enteroethmoid artery coming from the orbit, there is a risk of orbital hematoma. So prevention is preoperative assessment of radiology and proper handling and prevent the injury. But even though when injury can occur, we will show you. Other vessels, which include sphenopalatine artery, can be injured at the posterior end of the middle meatus. So identification at the sphenopalatine foramen, which is basically just behind this is the ethmoidal crest, which is just anterior to the posterior end of the middle. So we can identify it here. Sometimes maxillary sinus, maxillary artery ligation may be required if we are dealing with the infratemporal fossa area. So if we are not able to ligate these vessels in that case, or if someone has facility for embolization, then embolization can be preferred over the specific vessel ligation, as because maxillary artery ligation may require extensive surgery. Like sphenopalatine endpoint maybe can be handled by simple endoscopy and cauterization. And if internal carotid artery injury occurs in that case, the patient will go for stenting on that. An external carotid artery ligation is another method when facility is not available, or even though we know even after the embolization bleeding can happen, in that case artery ligation can be used. So IC injury is more common with the cellular type of pneumatization because party wall is thin in that case. So sometimes SSC septa directly attaches at the level of the internal carotid. So, like ma'am said, we should handle carefully when there is a septum well removed. Either we should drill or we can use we should not pull the attachment. Or sometimes there may be pre-existing anomalies or there may be injuries from party. So, pre-operative assessment, like someone is doing surgery after the trauma, in that case, annulus can be there. And there may be natural descent of the internal carotid artery. So, this is one of the case, like we have published 2 cases where the internal carotid artery injury occurred following septoplasty or some endoscopic sinus surgery. And then we made all the cases were managed by stenting of the internal carotid artery. So pre-operative radiological assessment is very important, and surgery should be done under vision as we discussed previously. And if intraoperative injuries occur, then if someone is not able to control the bleed, in that case, form packing, and patient should be transferred immediately to the intervention radiology room, and then the stenting can be done, and after once the stenting is done, then pack can be done. Next line of management is orbital, which predisposing factors are natural descent of lamina fibrillation due to because of disease, revision surgery, extensive disease, post-operative, and there is significant bleeding intraoperatively, in that case orbital injury can occur, or hypoplastic maxillary sinus can also lead to orbital injury. So subcutaneous emphysema is a complex orbital complication, it's just a collection of air under the lip. So it's a pre-septal kind of thing. So it generally settle by its own. We should avoid major where the pressure in the nasal cavity can raise, like avoiding blowing, sneezing, or putting a mask ventilation. Only in anterior compartment syndrome with the collection of air or pus present in the lips in very tense form, which is painful, that simple incision can be made, like we are draining the abscess that can be managed. So this is a case of natural descent of the lamina fibrillation. Here we can see, and the site of attachment over the middle terminate over the lamina is the weakest point from where it can be injured. So if we draw the imaginary line from the magnus and the medial rod, If orbit come medial to it, then surgical corridor will be less, and if it is orbit is come later to it, then surgical corridor will be more. In that case, injury to the orbit is can be less or more, but it is not that specific because if disease is extensive, you know, the risk of injury can be there. So careful handling is important. So damage to the lamina capacia. So that can be occur even we can preserve the with periorbital preserve, nothing will happen. But because of our instrument, someone is using inadvertently, in that case, accidentally, like in this video, we can see the fact is right here. So retrograde uncinectomy is relatively safer when there's a uncinect is much more severe or later. Advanced stage or hypoplastic sinuses can also increase the risk of injury to the orbit. So this is sign all knows when we put the pressure outside over the orbit and that will move in lateral nasal cavity wall will move inside because of direct communication. But in doubtful cases, fat can be taken and put in the water. That is fat will flow. So management avoid leave as such, avoid suctioning. Do not pull or push the fat, avoid packing or tight packing, and do not ask the patient to avoid blowing in post-operative period or antibiotic to avoid orbital complications. So orbital hematoma is a collection of blood within the orbit, basically post-septal. This can be slow venous form or fast arterial form. So slow venous form may not require any treatment, but one line of management shows if pressure is below 30, in that case we can wait and watch. In 30 to 40, it can be managed as a form of treatment. And if above 40 needs urgent lateral campylopexy or orbital decompression. But we are not following as clinician, we are not following this. We are generally seeing patient clinically if orbital, like in this case, if we can see if it is procedure is progressive, condition is progressive. In that case, we can clip directly over the lateral canthus and we can put the release incision to reduce the pressure. The extraocular muscle injury can be occurred. It should be managed as early as possible because subsequently patient has going to post-operative period. And once a scarring happened, then it is very difficult to manage. So a ophthalmologist should be called or it should be called on field. Then the damage to the nasolacrimal duct. So exit scans are very important. How nasolacrimal duct is running in the medial wall of the nasal. These are the maxillary sinus. So in this radiology, we can see it is quite away from the anterior portion. So if we are doing and posterior to anterior uncinectomy, in that case, we can injure the nasolacrimal duct. But in this case, it is running just anterior to the anterior most of the sinus. In that case, it is less likely to injure. So preoperative assessment of radiology is very important. And then the injury to optic nerve can happen if we are dealing with extensive rheumatization presence of monoties and this extensive disease here. So sometimes there may be indirect injury occur, sometimes maybe hematoma collection can be there. If someone identified intraoperatively, then orbital optical decompression should be done. If identified postoperatively, IV steroids can be given if patient is not improving in short span. In that case, 3 days is the time. In that case, orbital decompression can be done. And if direct injury occurs to the optical, then it is not show the results. Then CSF rhinorrhea. So patients of skull base, by the disease, by the surgery, or unadvertent manipulation of the middle turbinate, in that case, CSF leak can be occurred. So if it is identified intraoperatively, it should be managed in synthetic. If identified in post-operative, then we can treat like as a traumatic birth, so traumatic CSF rhinorrhea. In that case, we can do conservative management initially. If patient is not responding in that, then we can go for surgery. So these are the few factors which are responsible for CSF. If height of ethmoid lobe is in relation to the orbit, if it is high, for example, it is half of the orbital length. If it is less than half, in that case, skull base is low. If it is more than half, in that case, the skull base is very high. So if it is skull base is low, then injury to the foveal quadrant can occur, and if the skull base is high, in that case, injury to the lateral lamina of concave canal. Then kilos classification, you all know, type 3 is associated with CSF, and sloping pattern of the skull base is also important. management I already told you. Meningitis is less likely to occur, but it can be seen in the post-operative period, especially while getting close to the dura, then infection can happen. So proper cavity management is important. The pneumocoel is important when there is an air entrapped within the cranial cavity after the FES surgery. So generally air subsides by its own. If it is increasing in size, then it can create a symptom of like headache, pressure symptom. In that case, repair of that effect site is required. So the progression of the patient mucosa, like I told, if someone is dealing with someone is with dilatation of the sinus, it should not be done on all sides to get any scarring. So once the mucosa occurs, then non-surgical treatment. This is one of the cases where mucosa forms after twice surgical procedure. In that case, complete scarring will occur at the level of frontal outward tract. So we put the stent and kept it for around 1 year so that the tract was formed. And then this is a frontal disease. This is last complication, post-operative tumor. This is subperiosteal abscess collection because of osteomyelitis. Patient may have necrotic bone. So bone removal is required in such cases to correct the complication. Thank you.
Thank you, sir. I request Dr. Amrit Gulati sir and Dilip Panchal sir to sit on the stage. Now I would like to call upon Dr. Vijay Arora sir, who will be presenting on CSF and area. Sir has done his MPH in MS from Mulana Azad Medical College, Delhi, and CS residency from Mulana Azad Medical College, Delhi. Sir worked as assistant professor in Baba Saheb Ambedkar Hospital, Rohini, Delhi, and also in PGMS, Rohtak. Sir is currently working as assistant professor in Mulana Azad Medical College, Delhi. He has various national and international papers to his credit. He has special interest in the field of rhinology and veterinary surgery.
So CSF malorial is the region of CSF from the subarachnoid region to the liver cavity. There is a defect in the liver pulmonary mucosa. Daddy was the first one to repair a successful CSF the cranial approach. What was the spatial art this is the triangle posterior in 1990s. When we first started using laser endoscope to close the CSF field, CSF. This is the classification, which is the O'Mara's classification, very described it in 1968, and it is still being used. This is the modification. It divides the chromatic and non-chromatic, further chromatic into accidental and actogenic, and non-chromatic into today's ICP normal axis. More than 85% of the chromatic CSF peaks, they tend to see within 7 days. Popular sites and with some of the conservative measures which I would say they tend to cease their fibrosis, and if not, then we need to go for closure. So, how is the patient present? Patient will present with a nasal discharge, nausea, hypoxia, needs to be head trauma, with a headache, or patient might be affected in the medicine board with a recurrent disorder of meningitis, and later on it is like the radiological investigation. Patient comes to us, we can do this reservoir sign, ask the patient to bending forward, and with a certain flush of clear watery fluid. We can do this halo sign, also not very reliable because it needs to be post positive result, but before it, the other ring, one ring of the RBC, the blood and the other peripheral of the CSF. It is also called as the target sign or a handkerchief test. Now, this oxidase test again people used to do in the CSF patient. Copy the CSF, it is 30 milligram per liter or more. But again, it is very sensitive test and it turns positive even at low values of glucose. And in the patients who are having uncontrolled diabetes or inactive bacterial meningitis, this can give false negative result. So we are not using it nowadays. Very important is to identify the site of the leak and then inform it by various investigation, and then we decide whether we have to go for a surgical closure, which approach we have to take. So component site of the leak are the will be formed in the foveal, frontal, medial, lateral. Multiple factors can also be there in RT cases in frontal. And then sphenoid we can have from lateral cases, renal, fever or tuberculous leaks. So we do a normal endoscopy in the OPD. There is a small leak like in this case, there is a necrosis from the people area. We can see the OPD as well. The diagnostic test, the gold standard test for the diagnosis of CSF leak is it normally takes 5 to 7 days, and there's a wonderful, very good sensitivity in system. Another test that by giving a second commonest routine in CSF is 35-fold higher than the last one. There is possibility to not as of the renal bacterial. Another one of the diagnostic tools which we do ultrasound of the patient and eye is related into the impulsive phase. But it has got its side effects. Many cases of seizures, headache, nausea, vomiting, and even the peripheral muscle weakness have been reported. But many people are still using it. So the concentration that which they use is of 0.1 ml. It can range from 0.1 to 5 ml. You need to do, use the lower of the concentration of 10% fluorescein in a 10 cc of the patient's own CSF. And it is very important that you inject the dye over a period of 5 to 10 minutes because the side effects are particularly less. Particularly notice that it is not FDA approved, but still many surgeons in the US also are using it. So what I think is a useful uses on maybe intrathecal fluorescent can be used is one case in which we have a multiple needs. And second, the revision cases in which the CD or MR system will not able to at the site of the lead. So this is how you inject the dye, and this how you look in the OT, some greenish bit coming in, locate the site of the leak for you. You can use blue, some people use blue filter also to enhance the magnification. But this is the gold standard radiological investigation, the CT systemography of the forming a lumbar puncture and integration of the radio opaque contrast. This usually tells us the site of the leak more often than not. But what I have started, this is my investigation of first test. MR sonography because it is non-invasive, so you just ask your radiologist to go for P2 images, so they got a CSF P2 images, and also for a HRCT scan, what to do. So both of these things, HRCT will tell you the oscillatory and MR system will tell you the confirm you the site of the leak. Some people go for MR with interference contrast also or contrast. Contrast and also is about function. The diagnosis again it's an invasive thing and it has its own side effects. There are the usual side effects of lumbar puncture. So early post-traumatic are that we are getting a CSF leak within 48 hours. It is usually of the symptom. Some people give, some people are against CDC has posed this. we do, all the patients have to be given the focal vaccine. And lumbar puncture, again, this is a controversial thing, lumbar puncture. Neurosurgeons, some of the neurosurgeons say, we have to do this lumbar puncture, but it is again a gradual thing and not much benefit. But only benefit of a lumbar puncture can be in a high pressure CSF leaks, which we need to control the CSF pressure. So extra cranial techniques followed by some of the neurosurgeons, and they are also not transitioning to the endoscopic approach. You require a craniotomy, so there are morbidities like brain compression, hematoma, seizures, and very high failure rates. But the only present indication of extracranial technique would be a frontal sinus posterior wall defect, which whole of the posterior wall is dominated, or there are multiple defects in the frontal sinus. Various graft materials we can use cartilage or facial data or frontal cartilage or alloderms like Uragen. You can close whether by inlay or only, both are equally effective. Gasket seal, some people use it, placing a fascia over there and then placing a cartilage over it. This is one of the technique. Or you can use vesical flap like a Madar flap. This is a the sphenoid artery based flap and sphenoparietal artery based flap, and you can take it very length, you can right up to the category junction. And for me, I've used this other only in case the defect is very big or it's a very high pressure leak or it's a revision case has already has been operated before. So you can raise a very big flap and cover your defect, big defects also. Cases of anemic disease also, this is a very good flap. Or a path technique, as I said, where people is a very good technique in which you just pass a suture from one end of the pad and take it out from the other, and then insert this pad into the defect and just pull the suture out. So it seals your defect very effectively. In fact, the first layer which we are closing in CSF leak is the most important. This will be the layer which will decide whether there will be a recurrence or not, and all other layers are just the enhancing layers. So first layer is very important. Post-operative care, you have to watch for any potential intracranial complications like meningitis or any headache, severe that to seizure episode. Antibiotics are usually ceftriaxone on anti-meningitic dose. Strict bed rest, obvious precautions normal that avoid chronic seizing for 6 weeks. Estrazolamide, carbonic anhydrous to decrease the CSF secretion is good. Number puncture for hyperCSF. So this is This is a small video to close. This is the case. Most of face someone get a face and
फिल्म दो तरह की बनेगी ना, दोनों तरह की बात होते हैं
and patient had complained of CSF anorexia. This is the superior dominate. I'm just writing again like this sinus side writing. Sinus was depressed, so was writing this sinus was also writing. So this effect was identified by the Negotiation started to reduce with bipolar forces. And very important that you have to remove the mucosa around 5 mm around all the sides because the mucosa graph and anything that we are able to take, it will stay only if all this mucosa is gone. Otherwise, it will not stay. So all around this mucosa has to go. And keep on reducing the effect of bipolar. This is the lead we should bipolar and just we have to reduce it till the minimum. We can also cauterize it through the line and we can take a sugar and use it out. We have reduced all the body margin and closure with the fat as the first layer. This will decide whether this fits or not. It's very important that this reinforce with the cancer facial. And then you should do by use. Particular stock can be built, but user should use it. This is a post of 3 months. This is the defect area which is including
ये भी ना करिए, 1 घंटे में करिए भाई, मैं कॉन्फ्रेंस में बैठा हूँ करना 1 घंटे में कर देगा, कोई नहीं हो गया कोई या फिर एक मिनट रह गया लास्ट में। हेलो हाँ जी भैया, हाँ जी भैया, हाँ जी भैया, हाँ जी, हाँ जी, हाँ जी भैया, आप भेजिए अपने मेरे पास। हाँ जी, हाँ जी भेजिए। चाहिए ये चाहिए कब तक आपको भैया? हाँ कोई बात नहीं, मैं अपना अभी तो मैं बाहर हो गया करनाल हो 2 दिन के लिए कॉन्फ्रेंस में डॉक्टर की, तो मैं आपको कल या परसों सैंपल सेंड कर दूँगा, जो भी आप कहोगे वैसे मैं, हाँ हाँ जी भैया सैंपल भेजूँगा ना आपको जो बनाए हुए हैं। ठीक है हमारा सही बनता है 12 बाई 18 में, 10 बाई 16 बाई 20 में, 16 बाई 20 तक है, फिर उसके बाद 16 बाई 24 है, 20 बाई 30 है। एक मिनट, जो 16 बाई 24 होता है सर, वो 16 इंच बाई 2 फुट वैसे तो 16 बाई 24। हाँ 16 बाई 24 बहुत बढ़िया। मैं 2 तरीके की लाइट दोनों का वो कल लाइट भेजूंगा, दोनों को सैंपल करके दोनों ही टेस्ट करना।
There are 3 options for the organ preserving in the early chronic cancer: radical radiotherapy, transferal laser surgery, and preserving of the partial. There are various factors which can be actually determined, including the approach of the maintain power in these studies. They demonstrated the local control, bandwidth preservation, survival rate was similar to all the 3 options. Laryngectomy is the poor voice quality and expensive as compared to the radiotherapy and transferal laser surgery. Hence, they recommended the open partial laryngectomy is reserved only for locally recurrent early chronic cancer. Now, coming to the remaining 2 options, the radical radiotherapy and conservational laryngeal surgery in early chronic cancer. Goal is always in the case is growth is the best possible functional outcome. At present, radical RT and DFDS are the standard of current treatment for any carcinoma. But there has been a long-standing debate on the right of use of chemotherapy with regard to chemotherapy is a very time-tested approach, very simple planning for an early chronic cancer. It's proven to be an efficacy better and equivalent voice outcome. While the transferal laser surgeries are quicker, they are repeatable and have many salvage options. There have been many studies published on comparing these 2 treatment modalities. Economic in 2014 published a series of 60 patients, in the 28 patients were in the RTR and 32 patients were in the ELSR. The local control at year 2 years was comparable in both the rounds, while the voice quality was similar, but voice was more building ELS, while less often was in the RTR. Similarly, other studies also they demonstrated local renal control at 5 years, equal in RTR for ELSR, while the voice preservation was better in the radiotherapy arm. There have been multiple systemic reviews comparing the endopharyngeal surgery and the radiotherapy, but none identified any randomized control trial. They varied in either in the or the outcome of the study included. The comparative studies similar oncological radiotherapy and radiotherapy for alleviating carcinoma is not considered as acceptable treatment. Preserving approach for the locally advanced renal cancer that is stage 25 years ago, the standard treatment was laryngectomy followed by therapy as part of larynx preservation treatment in 1991 when the VA trials. So first initial landmark VA trials, they enrolled 332 patients which were randomized to receive the 3 cycle of cisplatin and fluorouracil followed by radiotherapy, versus surgery and adjuvant radiotherapy. The clinical tumor response was assessed after the 2 cycle of chemotherapy. Partial responder received the 3rd cycle of chemo followed by radiotherapy, while the non-responder was subjected to the laryngectomy followed by radiotherapy. After the median follow-up of 33 months, the 2-year survival was equal at 68% for both the arms. Likewise, in both arms contained 166 patients in the VA trials. On this final conclusion, they said there were more longer relapse. However, the fewer distance metastasis were seen in the chemotherapy group as compared to the study group, surgery group. The larynx was preserved in successfully 64% cases without dividing the 2-year survival as compared to the upfront surgery group. The significantly better quality of life for patients in related to more freedom from the pain, better emotional well-being, lower level of depression than the preservation of the speech functions. This established the laryngeal preservation strategy as a treatment option. This study had the patient predominantly with pragmatic movement and but higher hypnotic primaries, either the vocal cord or the forelegal or the cartilage invasion, which again hinting at the scenarios where the laryngeal preservation may not occur, as if we all of Standard laryngectomy was required in the 44% patients in stage 4 as compared to the 29% patients in stage 3 laryngeal cancer. High proportion of recurrences occur locally and less within 1 year of the treatment. This landmark trial established the induction chemotherapy followed by radiotherapy as an alternative to the laryngectomy for locally advanced cancer. To determine the contribution and optimal sequence of chemotherapy with the radiotherapy, RTOG conducted a randomized trial to investigate the 3 radiation-based studies. This RTOG trial, there was a 3 arms. The first arm included the intensive second arm was zero. The rationale for the second group was based on the enhancement of the radiation effect on the tumor cells with concurrent administration of the injection system. Primary objective was to compare the trials for laryngeal preservation with all the 3 arms. In this study, the patient will continue in a VA trial, patients with cartilage invasion was included. This is the RTOG trial, patients using all the 3 arms. In their final results they showed at a median follow-up of 3.8 years, patient receiving CTRT has a significantly higher rate of laryngeal preservation versus the induction chemotherapy arm. However, there was no difference between the induction chemotherapy versus RT alone group for the laryngeal preservation. In the long-term update of the landmark cardiology trials, after 10 years, median follow-up of 10 years, 550 patients were analyzed. Both the chemotherapy regimens significantly improved the laryngectomy-free survival as compared to the RT. In their initial 5-year follow-up, 3.8-year follow-up, there was no improvement in the induction and group, but on long-term 10-year follow-up, they found out that even compared to the RTO. So the overall survival, our overall survival didn't significantly differ in the all the three arms. Now, the outcome of the always total laryngectomy following important whether study patients who underwent total overall total laryngectomy that was total preservation treatment was acceptable morbidity is for laryngectomy was the after the R1, 2 or 3. This successful implementation of the laryngeal preservation in the laryngeal primary cancer also lead to the extension of the paradigm to the hypopharyngeal cancer where the laryngeal preservation is much attempted, and this was studied in the EORTC trial. 194 patients were distributed, 94 patients in the upfront laryngectomy followed by operative radiotherapy and 100 patients in the induction chemotherapy. After 2 cycles, the response was checked. Partial responder was subjected to radiotherapy, and less than partial response of the progress was subjected to salvage laryngectomy. They concluded that the disease-free survival at 3 and 5 years was 43 and 35% in the induction arm and 32% and 27% in the surgery arm. All survival was also better, 7% in the induction chemotherapy arm and 43% in the surgery arm. Laryngeal preservation was in approach laryngeal elimination was 48% at 3 years. However, there was no difference in the local regional control, but there were more distance metastasis in the surgical arm, that is 36% versus 25%. Now, another study which showed the induction chemotherapy in the laryngeal and preservation was the PROTECT trials. They added docetaxel in addition to the cisplatin and 5-fluorouracil for the induction chemotherapy for the laryngeal preservation. Both laryngeal and hypopharyngeal CA patients requiring the proper laryngectomy were randomized after the 321-day cycle of either PF or the DPF. There is docetaxel, cisplatin, 5-fluorouracil, and only cisplatin and 5-fluorouracil. Patient responding to induction chemotherapy received a conventional fractional RT. Non-responder underwent total laryngectomy. In this trial, total 213 patients, 213 patients were randomized. Of 3 years, in 3 years, then as compared to the only PFR. The overall response rate after the induction chemotherapy was also higher in the PFR as compared to the PFR. There was no significant difference in overall survival as well as the disease-free survival for them. This EORTC showed the TPF induction chemotherapy significantly improved the survival as compared to the only 5 program. However, the newer studies like DECIDE and the paradigm suggest there is no overall benefit from the addition of the induction chemotherapy when we compare with the concurrent CTRT. Kodak also in the study of the meta-analysis showed that the induction treatment with the DPF followed by the CTRT doesn't result in the significant improvement either in the overall survival. These are the various trials which I have discussed. Now coming to the one other mechanism, the meta-analysis was done in the chemotherapy for it was not only for the head and neck cancer, it was not only for the CA larynx, it was for overall head and neck cancer. The 93 randomized meta-analyzed in these 23 trials. These RCTs were done between 1994 and 2000, and they showed an absolute benefit of chemotherapy at 5 years of approximately overall survival rate. 5%. They also concluded that the CD now the limited study monarch in radiotherapy or the radiotherapy synthesis of the overall. However, the targeted therapy has never been compared head-on with the concurrent CDRT, which still remains the standard of care. So I would like to conclude that surgery, our parties preferred because of the excellent equivalent control and landed preservation and better voice, but equal voice quality and efficient time tested. For advanced laryngeal malignancy, concurrent CTRT is best organ preserving modality. Induction chemotherapy followed by an RT or CTRT doesn't show any benefit of upfront CTRT.
Thank you very much, Abhi. I want to tell everyone here that there is less audience, still we are online. So, if you are attending online also, you can continue with your work. Thank you. You can bring us here.
Thank you, sir. I would now like to call Dr. Ankit Karati on the stage, who will be presenting on parathyroid adenoma. Sir is MBBS from Malana, Ambala, and MSc from PGMS, Water. Sir did senior residency from TMC, Chandigarh. He has worked in consultant in various hospitals in Rajasthan and Haryana. Now currently working as consultant in Mohali, Punjab.
Good evening, everyone. So I will be speaking on parathyroid adenoma. So now the history dates back to 1862 when the first parathyroid was identified by Sir Richard Owen in Great Indian Rhinoceros. Therefore, it is also known as Owen glands, and the parathyroid naming was given by an in 1880. And in 1925, the first parathyroid surgery was performed by Phillips. Now, the parathyroid word is derived from a Greek word which means beside, which tells its location that it is located beside the thyroid gland. And parathyroids are this yellowish brown in color. Usually, there are two glands on each side. That is, totally 4 parathyroid glands are there, but the number may range from 2 to 12. Each gland is 6 by 4 millimeter in size, with a weight of 30 to 40 milligrams. And if the weight is more than 60 milligrams, then it is considered as pathological. The main function of the parathyroid gland is to regulate calcium balance in the body. Now, the superior glands are more constant in location, and it usually lies in a plane deep to the recurrent laryngeal nerve, while the inferior parathyroid gland usually lies superficial to the recurrent laryngeal nerve. There may be aberrant locations of the parathyroid gland, like in the posterior mediastinum, advance, or they may also be located intrathyroidal, intravagal, esophageal groove, etc. Parathyroids are derived from the endodermal in origin. First, you get at 30 days. The superior one arises from the fourth nasal cloud, whereas the inferior to the neck, leading to paracervidosis and may lead to recurrence. Equally can make subsequent surgery more difficult. histological artifacts that mimic parathyroid. Now, on the basis of all the above investigation, the system is highly sensitive and is usually considered as the gold standard, having a sensitivity of up to 100% with specificity of 96%. There's one more test which is done during at the time of the surgery. In this test, we measure the parathormone level. One protocol which is followed is Miami protocol, in which the parathyroid hormone levels are measured just before giving incision, at the time of ligation of the blood vessel, and 10 minutes post excision of the specimen. And the surgery is considered to be successful once the post 5 and 10 minute sample demonstrates a PTH level 50% or greater below the T0 level. That is at the time of incision. It has a 95% accuracy in single gland disease and 75% accuracy in multi gland. Now coming to the management, there are two types of management. One is medical and the other is surgical. Medical management includes adequate hydration, avoidance of calcium in diet, avoidance of thiazide diuretics, bisphosphonates. Bisphosphonates help by inhibiting the osteoblasts and stimulating the osteoblast. Cinacalcet is the calcium mimetic drug and estrogen replacement. Surgical management is considered to be the mainstay of treatment in symptomatic patients. However, in asymptomatic patients, according to NIH guidelines, there are few indications. First is if the patient is less than 50 years of age, the patient is unable to effectively follow. Serum calcium level is more than 1 milligram per deciliter above the normal range. Urinary calcium more than 400 milligram per 24 hours, and there is a 30% decrease in the kidney function. The surgical techniques are of two types. One is the open standard approach, in which we give a classical neck incision, and the other is the minimally invasive parathyroidectomy. It is further of three types. One is open minimally invasive, in which the size of the incision is length of the incision is 2 to 3 centimeters. The other ones are video assisted and purely endoscopic. Now, the minimally invasive parathyroidectomy has reduced complications. It has a focused extent of dissection. The patient has a limited stay. It can be done in local or regional anesthesia. It can achieve biochemical cure in approximately 97 to 99% when using adjuvants, that is intraoperative parathyroid measurement and routine use of preoperative imaging. The other approach is bilateral exploration, which is a default standard approach, which is performed when there is a inability to localize the disease glands. It has a long-term success rates of more than 95%. In this approach, we identify all the parathyroid glands and they compare the size. It is preferred for discordant finding of localizing lesions preoperative, in which there is high suspicion of multi-gland disease. The intraoperative parathyroid hormone level measurement is not available, and a surgeon preference. Endoscopic parathyroidectomy was first described by Gagner, especially for the posterior located parathyroids. The incision size is 1.5 centimeter, and the two other incisions are made for the dissection. One is for the instrumentation and the other for the CO2. This is a small image showing the endoscopic parathyroidectomy. Now, the complications of the surgery include hemorrhage, injury to the recurrent laryngeal nerve, wound infection, hematoma, and hypocalcemia. Now, to summarize, parathyroid adenomas are the most common cause of primary hyperparathyroidism. The symptoms may vary and lack specificity. Symptomatic patients should be investigated and managed accordingly. Systemic scan is considered the gold standard investigation, and accurate localization of the offending gland and good surgical technique provides a recipe for complication-less and uneventful post-operative.
So much, sir.
I would like to call on stage Dr. Vineet Panchal, who will be presenting annual presentation of invasive fungal infection of head injury. Dr. Vineet Panchal is MS ENT from PGIMS Kolkata and is working as a consultant in Karnataka. He is specialized in the field of pulmonology.
Good evening. I will be discussing some interesting cases of the invasive fungal infections of animal. Fungal sinusitis is a disease characterized by the inflammation of sinus mucosa due to fungal infection. It is usually seen in immunocompromised patients, but can be seen in different house. Positive agents includes zygomycetes, which includes aspergillus and mucormycosis. Along with these, there can be pneumocystis, candida, and penicillin. Again, positive factors include diabetes and immunocompromised, positive steroids, and chemotherapy. Broadly, fungal infections can be classified into invasive and non-invasive. Non-invasive are usually cold and meningitis, and invasive, which includes mucormycosis, also known as black fungus, and aspergillus. Chronic invasive includes aspergillus and other zygomycosis. Today we will be discussing about zygomycosis infections. Zygomycosis basically consists of two orders of fungus, which are basically mycorrhizas, which include mucormycosis, which are more common, and entomophorales, which are Conidiolus and Basidiolus. Conidiolus is basically Conidiolus coronata, which are very rare, indolent fungal infections. These are chronic granulomatous inflammations, and they are also known as rhinofacial zygomycosis. This is first case. Here we can see 25-year-old male which is presented with complaints of swelling over the face, since last 4 years. Main complaints of patients were nasal obstruction, intermittent yellowish nasal discharge. On examination, they were slightly tender, woody hard, diffuse swelling of the forehead, dorsum of nose, upper lip, cheeks. Bilateral nostrils were narrowed due to swelling around the bilateral of the punctures. There was history of some nasal surgery 1 year back. I think it was really fresh. There was no documentation available, and swelling has increased progressively since the surgery.
This swelling has led to severe disfigurement of the face, leading to social avoidance and loss of growth. There are multiple intranasal biopsies which were inconclusive. Then the biopsy was done through upper gingivobuccal sulcus incision from the around area of pyrenoculture and upper lip, and report shows the broad projection attached to small angiofor with splenomegaly phenomenon consistent with the comedulus coronata. These are the microphotographs of histograph report which shows multiple fungal hyphae which are encased within the eosinophilic material consistent with this splenomegaly phenomenon. This is the second case which presented with the swelling over the nose and nasal obstruction. There was diffuse, slightly tender body part swelling present on the dorsal nose. It was extending over the right cheek. As you can see, there are small dimpling of the skin over the right cheek. Endoscopic examination showed narrowing of the nasal airway due to diffuse swelling of the hand. Again, multiple biopsies were inconclusive. Biopsy was done from the area of head of inferior turbinate and pyrenoculture, and the histograph report came out to be broad projection attached to pharyngeal with this splenomegaly phenomenon consistent with the comedulus coronata. Both of these patients were started on tablet voriconazole 200 mg twice a day and potassium iodide 20 mg per day, and severe monitoring of liver function test and treatment was given for 8 months till the resolution of symptoms. Now, after 8 months, this is the picture of the first patient. Here we can observe the complete resolution of swelling around the face, forehead, nose, or cheeks. And patient was symptomless after 8 months of treatment. Third case is a 26-year-old male presented with the left facial and temporal region and numbness since 6 months. Patient had classical E2 territory anesthesia, means ophthalmic the maxillary area hyperesthesia and numbness. As we can see here in the diagram, this is the sepsis line of the face, which is supplied by trigeminal nerve, ophthalmic, maxillary, and mandibular branch. This green area represents the maxillary branch, in which patient presented with the hyperesthesia and numbness. Contrast analysis MRI was done. Here you can see this is the total section of contrast MRI brain and paranasal sinus and orbit, which shows a T2 hypointense mass, which is completely involving the left sphenoid sinus, left stellar area, paracellular area, infratemporal area, and this is the temporal adjacent to the temporal lobe of brain, with 360-degree encasement of the left internal carotid artery in the cavernous sinus. Nasal endoscopy was done and report came out to be invasive aspergillosis on biopsy. Patient was started on tablet voriconazole 200 mg twice a day. After 2 months, repeat MRI brain was done, which showed 50% reduction in the fungal mass. Patient has improvement in the pain, but no improvement in the numbness. This is a fourth case in which we can see a 20-year-old male presented with swelling and anesthesia of the right cheek since 4 months. Here you can notice that ill-defined swelling over the right cheek, and on examination, this swelling was firm, no tender, ill-defined, and slightly mobile in the right infraorbital region with overlying skin normal. There was fullness present in the right upper gingivobuccal surface region. Nasal endoscopy was uneventful, eye examination was formal, right cheek anesthesia was present, infraorbital nerve involvement. Contrast analysis MRI was done of the paranasal sinus, brain, and orbit. Here you can see this maxillary area, which shows a T2 hypointense mass in the maxillary area, which is extending posteriorly. As we are going behind, you can see this is orbit, this is the mass, which is extending through this infraorbital nerve below the orbit, going behind, and in the infratemporal fossa. And through this infratemporal fossa, this fungal mass was going towards the cavernous sinus and paracellular area. CT scan was done, which shows this is the area of the sphenopalatine foramen, and you can see the difference between the size of two sides of sphenopalatine foramen. Left side was normal, and right side sphenopalatine foramen was dilated. It shows the involvement of the pterygopalatine fissure and sphenopalatine foramen area. Here you can see clearly. And through this pterygopalatine fissure, this fungus was growing in the intracranial segment. Now this is the contrast as MRI axial cut, and you can see this T2 hypointense mass in the right paracellular region, and these are the carotid arteries. This is the intraoperative picture where we are taking a biopsy from the upper sulcus incision, and this CC mass, yellowish colored CC mass is the fungal medium. This biopsy came out to be invasive aspergillosis, and patient was started on the tablet Buliconazole 200 mg twice a day. Reduced significantly within 1 month of treatment, and patient is still under observation. Now, various differential diagnoses can be taken in these situations, like facial cellulitis, complicated sinusitis, skin and subcutaneous pathologies, granulomatous disease, malignancy, which could be primarily for metastatic and benign tumors. These cases are very rare and they present very uniquely different from the textbook pictures, so you have to keep in mind these differential diagnoses. Once you have seen these patients, you will never forget these cases. Always talk to your pathologist and talk to your radiologist, because neither the pathologist nor radiologist, they don't see these patients clinically. Only if you will guide them, only then they will tell you what is the actual picture in the histopathological examination. Otherwise, they will write the findings like granulomatous chronic inflammation, eosinophilia, or like this, and there will be no use of your biopsy. So you have to talk to your pathologist and radiologist. Treatments are usually very long, they take years, and treatment-related complications should be kept in mind. These patients are usually very anxious and hopeless because of very prolonged course of disease, multiple failures, multiple interventions, and they still have no diagnosis in their hand, so no treatment will be started. But once these patients are diagnosed and treated appropriately, these are highly rewarding patients, and they can move your practice. Thank you. And here is a small video of
was a nice presentation, and I think I have checked that 34 online viewers are listening very well. Now I can thank them.
Thank you, sir. I would now request Dr. Ashok and Dr. Ritesh and Dr. Vikas to kindly felicitate the speakers. I request Dr. Ashok to kindly felicitate Dr. Sandeep Bhukkar. Request Ashok sir to kindly felicitate Dr. Ankit and Dr. Vinay.
This will conclude our all academic sessions, and quiz is going on in the lecture theatre one adjacent building. All the audience are requested to be there in the quiz, and after that we will start with our valuation very shortly.
Gila. Aduh. Ini dia. Ini dia. Sampai kहाँ है? वो की करी है?
I requested to proceed for the debate.